I hope that didn't go anywhere.
Yeah, you are on room. Okay, let me just see. Yeah.
Good morning, everyone, and welcome to Giant 2020 Health Event. My name is Jerry, and I'm going to be the Master of Ceremonies for the Inbound Trade Mission demonstration stage. This year, Giant put together a specialized program called the Inbound Trade Mission. This was designed to help companies from abroad to engage with and enter the UK healthcare system. Through our conference, we aim to introduce health technology and life science companies around the world to healthcare providers and give these companies an opportunity to showcase their products and their services. By doing this, we hope to encourage innovation and collaboration within the healthcare system. Following the ITM demonstration stage, you will be able to attend the virtual stands of all the companies presenting today. This will be in the exhibition hall, where you can further ask questions and establish valuable connections through one-to-one video meetings. Tomorrow, there will be a half-day conference featuring expert speakers who will provide dedicated guidance on how to sell in the UK. This will help you to learn everything you need to know about how to enter the UK market and how to sell your products and services into the British healthcare system. I'm very excited to say that we have 7 health technology companies joining us on our demonstration stage. In the agenda, the companies will be discussing topics that are extremely relevant today, including mental health and well-being, airborne diseases like COVID-19, insomnia, mobility vehicles, preventable blindness, and health risks for the elderly. Following each presentation, there will be a 5-minute live Q&A session, which will be a great opportunity for the audience to ask any questions to the companies presenting today. For the ITM demonstration stage, we are going to be hearing from 6 companies consecutively from 9:45 to 11:55 a.m. We will then have a short 40-minute break. At 12:30, we will all come back to the demonstration stage to hear from our last company, Vision Quest Biomedical. We are now going to have our first presentation. I would like to introduce you all to Karthik Srinivasan from Next Step Dynamics. Oh, hello? Can you hear me? Oh, wait. Through the thing, not through the call. Eros. Good morning, everyone, and welcome to Giant 2020 Health event. My name is Geer, and I'm going to be the Master of Ceremonies for the Inbound Trade Mission demonstration stage. This year, Giant put together a specialized program called the Inbound Trade Mission. This was designed to help companies from abroad to engage with and enter the UK healthcare system. Through our conference, we aim to introduce health technology and life science companies around the world to healthcare providers and give these companies an opportunity to showcase their products and their services. By doing this, we hope to encourage innovation and collaboration within the healthcare system. Following the ITM demonstration stage, you will be able to attend the virtual stands of all the companies presenting today. This will be in the exhibition hall, where you can further ask questions and establish valuable connections through one-to-one video meetings. Tomorrow, there will be a half-day conference featuring expert speakers who will provide dedicated guidance on how to sell in the UK. This will help you to learn everything you need to know about how to enter the UK market and how to sell your products and services into the British healthcare system. I'm very excited to say that we have 7 health technology companies joining us on our demonstration stage. In the agenda, the companies will be discussing topics that are extremely relevant today, including mental health and well-being, airborne diseases like COVID-19, insomnia, mobility vehicles, preventable blindness, and health risks for the elderly. Following each presentation, there will be a 5-minute live Q&A session, which will be a great opportunity for the audience to ask any questions to the companies presenting today. For the ITM demonstration stage, we are going to be hearing from 6 companies consecutively from 9:45 to 11:55 a.m. We will then have a short 40-minute break. At 12:30, we will all come back to the demonstration stage to hear from our last company, Vision Quest Biomedical. We are now going to have our first presentation. I would like to introduce you all to Karthik Srinivasan from Next Step Dynamics. Good morning, everyone. Whilst we are having some technical issues, I thought I would just speak to you all about our inbound trade mission. So, I just wanted to discuss what was part of our package and what we are offering all of you people today. The audience, we are here with 7 amazing companies who are going to showcase their products and their services to you in a moment. So, this really gives you the opportunity and the chance for you to converse and make really valuable connections with these companies. They are offering amazing products and amazing services for you to be able to take on within your healthcare industry. This is a really, really good opportunity. Also, I would just like to point out again that there are virtual exhibition stands where you can speak one-to-one with all of these companies presenting today. This is really important, and you can find out more information from these companies about what they are offering you. Hello, Michael.
Oh, shit.
Can you hear us? Hi. We're really
Hello, I'm Daniel. I am the CEO of Flow Neuroscience.
And I'm Nikki, and I help with clinician partnership efforts here at Flow Neuroscience.
And if you're interested in a new way of treating depression, then you come to the right place, because we offer an at-home, medication-free treatment that could work as an alternative to the standard model of care.
Yeah, and today we'll explain to you who we are and what we do, and how you can best support your patients with our treatment.
Okay, so let's start with who we are. So we are a health tech company specializing in the neuromodulation field, trying to bring a new wave of mental health treatment to the public. And our first product, Flow, is a unique solution for unipolar, or what we call regular depression, of mild or moderate degree, based on brain stimulation and virtual behavioral therapy. So in this treatment solution, we bring brain stimulation home to the patient by combining a medically certified TDCS headset with the Flow app. And our solution ensures that the patients and the clinicians have a very powerful treatment solution that is free from severe side effects version of TMS, transcranial magnetic stimulation. And it has decades of research behind it. Numerous double-blind RCT studies published in, for example, the New England Journal of Medicine and the British Journal of Psychiatry show that TDCS is almost as effective in treating depression as a larger dosage of SSRIs. So in our internal data, we see that 81% of our users decrease their depression symptoms in just 3 weeks. And what's even more important, about 35% go into remission. This is a truly remarkable number in a real-world setting. So to get you to understand us a little bit better, we're going to take you through some key use cases for where Flow might fit you. So Nikki, take it away.
When clinicians come to work with Flow, they come with specific patients in mind. One of the most common types of patients are the ones who come and say, I am suffering from depression, but I do not want to take antidepressants. Often patients do not want to take medication as they worry that they will be on it for a long time if they start. And patients are also worried that they will become dependent on it. And as you know, they are particularly anxious about well-known serious side effects of antidepressants, such as weight gain, insomnia, sexual dysfunction, and even potential suicidal risk. However, what we hear from clinicians often is that they find it very hard to know how else they can treat these patients and what they can offer as an alternative to medication. At the moment, they either suggest lifestyle changes or low intervention methods like meditation. However, clinicians often do not have an alternative option that can fundamentally tackle the imbalance in lowered activity in the brain regions of these patients. And this is where Flow comes in. Now, with a solution like Flow, clinicians can bring a medication-free, safe, and effective treatment. Unlike antidepressants, patients do not have to go through the risk of serious adverse side effects. Patients now can treat their depression first with Flow. For these patients, Flow brings a neurological effect as well as a behavioral effect with its brain stimulation headset and app-based behavioral therapy. And then there are patients who have already been on medication. And this is a second type of patients that clinicians see Flow fit in their treatment journey. As many people with depression know, being on medication can be for the long haul. This leaves many in a position where they've relied on a substance for years that has an effect on other parts of their brain and body. To cope with tolerance, emotional blunting, and other long-term side effects, many of these patients want to lower dosage or come off medication altogether. But it can be very hard to go completely cold turkey or even start to lower the dosage without having another option that provides similar effects to their brain. So with a solution like Flow, you can provide another tool in your toolbox as a clinician to help long-term depression patients reduce their medication or come off it altogether. Recently, Flow has been featured on BBC. BBC featured Mike Story, who successfully managed to reduce his antidepressant usage with Flow. Clinicians long to help their own patients with Flow, as Flow had done with Mike. The third type of patients that clinicians introduce Flow to are the patients who cannot or do not want to see a doctor regularly. Many patients and clinicians alike struggle with the amount of visits required to handle and manage depression. This can be tough, especially as you work to maintain contact with your patients and provide them with the appropriate care in between when you actually meet with them. With Flow, you as a clinician can introduce a treatment method that reaches your patients at home and creates a big advantage to reduce the barrier to your patient getting better. As you know, our Flow treatment combines a brain stimulation headset and an app-based virtual therapy program. And it is this combined nature of the treatment that allows you to treat your patients effectively at home. First, patients can access our treatment very easily from home. The Flow headset can be delivered directly to their doorstep, and your patient can download the app for free. Secondly, the app guides them through how they can stimulate with the headset, monitors their stimulation usage, tracks progress over time with a self-reported matter scoring. Thirdly, the app also provides them with virtual behavioral therapy sessions. So with our at-home solution, you can better support the patients who cannot meet with you regularly or as often as you wish to. Lastly, Flow can be a great option for the patients who have already been treated with other brain stimulation techniques such as ECT or TMS, but now looking for a more accessible, safe maintenance option. There are many depression patients who are well aware of brain stimulation and have tried this treatment in clinic, seeing great results. However, it can be very difficult if they wish to carry it on as part of their regular treatment plan. If they continue with ECT or TMS, people have to invest a large amount of time for ongoing in-clinic stimulation sessions, and the cost will be very high if the type of stimulation is not covered by their healthcare. Flow brings brain stimulation to your patients, but in a safer and more accessible form. With a more mild current making it safe for at-home use, Flow provides a convenient, safer, and more cost-effective solution for your patients as part of their long-term care plan. So the question is, how can you as a clinician and your patients access Flow? Great news is that patients can directly access Flow right at the moment through our website. As we are medically certified as a Class 2A medical device for patient at-home use, we can offer our solution directly to the patients. On our website, they can either choose to buy and own our device or rent out a Flow solution. And as a clinician, you can work with us to decide what works best for you. Right now, we offer different options. First, you can choose to get a demo device and test it out in your practice right away. For these clinicians, we provide a special healthcare professional discount offer for the demo. Secondly, you can choose to work with us as a clinician node. As a clinician node, you will be working with patients interested in Flow or using Flow in your area. For these clinician nodes, we will provide all the relevant training and materials so that you can best support these patients. No other financial commitment is needed, just the commitment to help the patients coming your way. Thirdly, you can choose to refer your patients to a clinical trial program using the Flow solution. For example, there is an ongoing independent study run by University of East London at the moment. And lastly, through our Expert Spotlight series, you can share your story of innovating mental health care. Our Flow team will work with you to create content to share with our own Flow patient community as well as your patients at no cost. We believe that you know how to best support your patients in your own context. So we work with each of our clinician partners to identify how we can best work together. If interested, please reach out to us and we look forward to bringing our solution to your practice.
Thanks for joining the talk, guys. If you like to hear more about flow, then you can just come and join our booth.
You can also reach out to partnership@flowneuroscience.com to continue our conversation. Thank you.
Okay, one moment. presentation. It was absolutely brilliant, and also an absolutely incredible product that you are offering. So I would just like to say that statistics from COVID-19 show that mental health issues are on the rise, and access to relevant psychologists during this time is slightly difficult. Your product is extremely accessible to all these practices and all the patients who will be needing care for their depression. So in terms of the actual product itself, can you tell us a bit more about the practicalities behind the product that you are offering? Day-to-day life. Yeah, brilliant. Absolutely. So in oh, I'm sorry. Yeah. Yeah, brilliant. Of course, with COVID-19, everything is very difficult in terms of accessibility. So this really is an amazing product to help clinicians with their patients. So in terms of right. Okay, one moment. Thank you for pointing that out, Magnus. I'm going to quickly sort that out. One moment. Yeah. Speaking to ourselves. One moment. I'm very sorry, everyone. Let's have a look. So, yes, as they were saying, whilst we're quickly checking that problem, their product is extremely accessible. Um, One moment. The product is extremely accessible and available worldwide. They have been working already with clinicians during COVID-19, helping all of these companies with psychotherapy. It's very important during this time, especially as the rates of mental health issues are increasing considerably during this time due to loneliness, fear of safety, really, with COVID-19. All of these issues are so relevant today. So Nikki and Daniel, if you could just quickly say something to check that the system's working well, thank you. One moment, they're saying still cannot hear talk. If we all just click off live quickly, please. Of course. One moment. Brilliant. One moment. So the next question that we did want to ask was about scientific evidence. We are quickly going to check in with your microphone and we will go on to the scientific evidence around how this product works in terms of effectiveness with patients so far and all the evidence that you have. Yeah, and 3 weeks,
Most welcome to Giant Health 2020, this year in a virtual form. My name is Peter Hojeback. I'm CEO of Avidicare, and I will show you a lot of information about why airborne infections are such a terrible thing and what we can do to improve. Let me share my presentation with you. Avidicare is all about towards zero infections and protecting patients from airborne contaminants. But really, why should we bother about airborne infections? Well, actually very deadly. 5 times more people die in such infections than die in traffic. And any one of us can need this surgery. It can be our friends, our family, our kids, our neighbors. Anyone, when you open up the skin, you are susceptible to these terrible infections. Furthermore, some pandemics are also airborne. So that's another reason why we should worry about airborne infections. But let's start with the first one, the really big killer that we know of, surgical site infections. It is a very serious problem and it's getting worse and worse. And just as a starting point, of course, these are infections you did not have when you came to the hospital. And nobody should become ill in a hospital. Looking at some statistics from the US, the CDC reports about 1.9% of people doing surgery getting these surgical site infections. But many are worse. We have a US Medical Cancer Center reporting 12.5% surgical site infections. This totals up to about 300,000 cases in the US a year. And if you were to get such an infection, your risk of dying is between 2 and 11 times higher than if you hadn't gotten one. But in reality, the real figures are probably way worse than 2%. It's probably more like 6%. That is at least according to a very big study made by the Veteran Administration in the US. They were looking at 600,000 patients they had over the last couple of years and found that the real figure after a year was 6%. The tragic thing that while many other hospital-acquired infections are going down, quality measurements by the CDC show that this is not the case for surgical site infections. And at the same time as these infections are very hard to minimize, we need infection-sensitive surgery more and more. As we're all getting older, we want to remain active. We want to keep playing tennis, golf, walking in the mountains, going to the beach, running, whatever we do. And by the time we're getting older, we may need a new hip or a new knee for that matter. And these are among the absolutely most infection-sensitive kinds of surgery that you can possibly do. Another very big concern here is that antibiotics are losing their powers because the antibiotic resistance is increasing. This is a huge problem to society. And of course, that means that if you can't treat the infections with antibiotics, it's even more important to make sure that those bacteria do not get into the wound in the first place. The second part of the problem relates to airborne infections such as COVID-19. Here COVID-19 can show, even if COVID-19 isn't primarily airborne, it is still transmitted over the air. But it does show clearly what healthcare must be able to do to protect both its staff and its patients. Again, some figures from the US. It is a country among the top in the world when it comes to cases and deaths. And you can see the figures from the New York Times here to the right a few days ago. By July 16, the CDC reported that out of those who had died by then, 641 of them were healthcare personnel, and they are really exposed. In the UK earlier this year, the figure was that 1 in 10 dead were healthcare personnel. Over the last few months, we have also seen increasing evidence that long-range aerosol transmission is actually happening. That means that the virus, the COVID-19 virus, is transmitted long distances over the air and not only short distances on droplets. There are documented studies showing that SARS-CoV-2 virus is found in the air outside isolation rooms. It's in patient rooms where there haven't been any aerosol generating procedures. And they even find these virus particles in HVAC ducts about 50 meters away from where the patients were. So obviously it is traveling through the air. So now these growing concerns show that both the WHO and the CDC have had to revise their guidance on how to protect yourself from COVID-19. Of course, there is still debate. How much of it is airborne? How much infectious is this transmission when it comes over the air? But either way, what all experts agree is that better ventilation is needed. Well, with this status of the world today, are we okay with what it is? Because we do know that there is ventilation in every hospital already. Still, with the figures I've shown you, status quo is very deadly, it's super expensive, and indeed it's not helping healthcare to remain open. We also at the same time see a need for increased surgeries, especially infection-sensitive hip and knee replacements. The antibiotics are losing their powers, which is a global threat to humanity. So we conclude there is indeed a big need for innovation. Now, what should ventilation do in healthcare? We believe it should do three things. It should minimize the airborne bacteria and viruses. It should provide excellent comfort for staff. And it should use as little energy as possible. So with these design goals in mind, we have made an innovation. It's called temperature-controlled airflow. And it's a new system, or somewhat new. The first installation was done more than 12 years ago. That, thanks to the long time it has been around, now has been fully scientifically validated during surgery. It's a system that actually works, especially in operating rooms, when it needs to work. What is the innovation then? Well, traditionally, it's either, as you see on the left, that you're just mixing the air in the room randomly around, and you're diluting the bacteria. Or you can see to the right, it's a protected zone system. They're sometimes called unidirectional airflow or laminar airflow systems. They're basically creating a small zone in the middle of the room where it's clean, although the rest of the room is not. Our innovation, temperature-controlled airflow, makes sure that the whole room is clean. It's even ultra clean, and it does it by combining these two systems. A bit more in detail, how does it work? Well, I said it's a combination of two systems. The first part, the blue one in the middle you can see here, is a sweeping unidirectional airflow, air falling slowly, quietly down in the middle of the room. This is HEPA-filtered air that's released from a ring of so-called air showers or diffusers that's above the OR table and staff. It falls down not by the impulse from a fan, but is driven by gravity, since this air is 2 degrees colder than room temperature. And cold air is, of course, heavier than warmer air, so it falls down. It even accelerates and goes faster as it falls to the floor. This is a very, very quiet system and a very robust one. It's not much impacted by obstacles in the airflow, such as surgeons' heads, nurses' heads, or surgical lamps. In the periphery of the room, there's a mixing flow or sedimenting flow that drives air down towards the floor. It's of course also HEPA filter there, and it pushes the air down to the floor and out in the 4 low corners of the room. The system in this way automatically controls the room temperature. So it's really an automatic system. You just set the temperature you like, and as staff, you can set any temperature that you desire or any temperature that the patient may need. The key benefit of this is that it enables safe care, both for patients and staff. It is ultra clean the whole room, which means that the surgical team can use all of the room for their work and not just a small square in the middle. It's really comfortable, and we have scientific evidence on that as well. It means that the staff can stay focused and calm and focus on their work, not being distracted by the ventilation. It does have the lowest energy need in its ultra clean class, and it's even been awarded for sustainable healthcare. It is the most sustainable or most stable airflow when it comes to resisting and keeping its performance even during movements, when there are obstacles in the airflow, or when doors are opened. It's also a very flexible system. It can be installed in old hospitals, in new buildings, in many places where traditional systems cannot fit. I mentioned scientific evidence. And we've been working with several top 100 universities, and then I mean global ranking top 100. Among them is the Royal Institute of Technology in Stockholm. They have been publishing several peer-reviewed articles and a doctoral dissertation as well, where they're using computational fluid dynamics simulations run on the most powerful supercomputer in Northern Europe to validate that the air indeed moves the way we are measuring. And you can see the figure on the right of some of these simulations. Some of them are also virtual reality, where you're actually entering the world and can see how bacteria are moving in the room. We've been working with Lund University, another global top 100 university, and they have done the real world measurements, measuring how much bacteria are there in the world, also measuring and researching comfort and sustainability and energy need. We've been working with Weiden University in Germany. They made an outcome-based study that showed that before installing Opragon, they had about 3% surgical site infection rate, and they checked 1,000 patients. Then they did this change to the Opragon temperature-controlled ventilation system. Afterwards, they got 1% surgical site infections for the following 1,000 patients. And those patients were very similar in characters. We have also measured extensively during ongoing live surgery inside the room in more than 700 occasions. And this database gives us a very powerful and very strong confidence that we are able to keep the whole room ultra clean, which means way below the 10 CFU per cubic meter. That is the requirement for ultra clean. So temperature controlled airflows is indeed already used in healthcare in many places. We have full surgical departments, operating rooms, hybrid imaging operating rooms, prep rooms, corridors. We have sterile processing departments. We have labs, even full floors we have designed. We are also now getting requests if we can make sure that other parts of a hospital also receive the benefit of a downflow that could minimize the risk of airborne transmission of, for instance, viruses. So then we're talking about the intensive care units, emergency departments, waiting rooms, and also isolation rooms. A current customer of ours, is the recent one, is one of the top orthopedics clinics in the world. They're ranked number 6. They have top outcomes and indeed very, very few infections. They equipped their 7 new operating rooms as well as their prep rooms with the Opragon temperature-controlled airflow system. And they said they chose it because they really wanted to have ultra clean in the whole OR so they can use the full space. They wanted to have the best working comfort, and also the flexibility provided meant that the staff could focus on the patient and the job, not focusing on the room. We also recently did a hybrid operating room with Philips and their new Azurion FlexArm imaging system. You can see it's here on the right. In this case, it was great because they needn't compromise between hygiene and image quality. You can actually have both. So it's both a comfortable one, where they don't feel any draft anymore, and where the sterile area where the staff can perform their work is much bigger than it used to be. And this was a very good cooperation between us, the hospital, Philips, Getinge, which medtech company, and also the designers and builders and architects. Now, for a little bit about our company. We are more than 12 years old, and the company did its first installation in a real clinic more than 12 years ago. And today we are approaching 250 installations. We have leading market positions both in Sweden and the Netherlands, customers throughout Northern Europe, also Germany, Switzerland, Eastern Europe, but also in India. Further, we have an installation in Buffalo, New York with 2 operating rooms. And we're planning for strong growth internationally. Our headquarters is based in Lund, Sweden, just across Copenhagen and Denmark. We have very strong owners and an extensive patent portfolio protecting both the system as such with the temperature controlled airflow and the details of some of its implementations. So, if you really want to drive and help your customers towards zero infections, we can help you make your next project a true success. And at the same time, we will help to make the world a little bit better place and come closer to zero infections. So just contact us. We will help you with a free design for your next project. Please visit www.avidicare.com. Thank you for listening. Questions. I mean, we will. I have another presentation I need to go online with in a very short time. So I'm.
Oh, right.
So if there are no questions, I will just listen and see if anybody's there. And you could, of course, ask me about.
We would like to ask some questions about his company. So, Peter, if you could just explain a little about your current plans for expansion and the growth of your company in general.
Well, it's always when you're introducing a new technology, people don't really know if it is actually working or not. So that's why when we started the company, we wanted to establish it on the home market, that being Sweden. So after a number of hospitals had started to use it, we had the universities come in and check it, of course, and also discussing with the staff and evaluating any infections that might have happened or any reduction in infection rates. Then the company slowly grew into Northern Europe. And by now we have a very strong market presence also in the Netherlands. Now we are looking into further markets both in Europe, including the UK, but then of course also looking into the US. And we have several designs we are now also working with in Southeast Asia. So the technology is generic. I mean, bacteria and viruses, they behave the same no matter where in the world you are. So the technology can be employed more or less in any setting where you are concerned about infections.
I see. Yes, understood. And do you have you mentioned that you actually had 250 customers so far.
Yes.
Yes, that is a lot of people worldwide already, and who are already purchasing your product and installing your system. So in terms of these 250 people, have they left any commentary on your product or any, let's say, statistics on reduction of rate?
Yes. We have excellent customer testimonials from all of them, and it's very positive to work with a system that is so appreciated, because compared to most other systems, they will feel that the air coming down is so quiet. They always ask us, is the system actually running? Because they're used to laminar flow systems where there's just like a big hair dryer blowing lots of air down over your head, and when you're working, that is quite cumbersome and annoying. Whereas in our system, is anything happening? You have to hold out their hands like, oh yeah, now I can feel there's actually a little bit cold air that is falling down here. Wow, okay. So that is it's a very pleasant working environment. It's not only very, very clean, it's also very comfortable.
And that, of course, that is one of the most important things as well in operating theatres. We have very important people, surgeons, neurosurgeons, working on very difficult procedures. You need a system which is quiet, effective, but also in terms of psychologically, if you don't feel like you are safe in an operating theatre, or there are worries that your patient is going to, contract an infection, this will also improve actually the quality of the healthcare being given.
That is true, and also now with COVID-19, we have much more seen also the concern for staff. I mean, they don't want to get any infections themselves, airborne. And if you have a very controlled movement of air, that all air moves down, the likelihood of anybody infecting anybody else is much lower. And that is, of course, also why the system is interesting for so many other areas in a hospital, where you also, rather than just mixing the air so everybody gets to share everybody else's bacteria and viruses, I mean, that's just the standard ventilation system you have in all your conference rooms, meeting rooms, all homes, just mixing ventilation. And that is not the most clever way of handling any risk of airborne infections. It's much better to make sure that all air is moving in a controlled direction, so you don't have to breathe the air that just has been exhaled from somebody else.
Yes, of course. And in terms of practicalities, let's just speak a little about that. So in terms of installation and practicalities and ease of installing this system, do you have any comments about that?
It's actually quite similar to installing any other ventilation system. So the differences are very, very small. One of the things we have found out is that in many refurbishments, when maybe you have an older hospital and you don't have enough air, you don't have enough space between your inner ceiling and the fixed hard upper ceiling, our system can be very small. So that means you can fit it into very many places where a traditional laminar flow system cannot fit. So far our design engineers, and one of them is even an architect, we haven't declined any project so far. We have been able to, with a little bit of imagination, to get the system in there so they could have the perfect working environment and the safety that they need for the surgeries.
Absolutely brilliant. Yes, I think being able to install it into small places is so important. So in terms of this product, it is very accessible to hospitals and all of these areas where we do want to limit infection, which is so important. That's great. So you've adapted your product to be able to be put into these areas.
Yes.
Yes, brilliant. Excellent. Peter, do you have any final comments you wish to speak about, or anything you would like to point out to the audience?
One of the things that are being discussed in one of the other tracks is virtual reality. And I think that if we could see bacteria and viruses with our own eyes, I think our business would have been so much different and so much better, because sometimes we are ignoring things we cannot see. And by using simulations that we have been doing and also putting on your VR goggles, there is a not too distant future where you can enter an operating room with these goggles, and actually even before they are built. And then you can compare the kind of ventilation we are providing with what you're having already. So then you can see with your own eyes how the bacteria are moving away. So you will have that comfort of knowing how to behave, where you can be in the room, how you can move. You can see the impact of lamps in obstacles in some rooms are not as sensitive. You can see what happens when you open the doors. So I think the ability to see bacteria and viruses, if we could do that, and we're going to do that with virtual reality, things will change a lot. And we are there with a solution to help out for those who really want to work towards zero infections.
Yes, VR, that idea of VR in a hospital setting would absolutely change healthcare, definitely. Being able to really see the effects, being able to really see the bacteria live in person with the VR goggles, it will be so important for healthcare. Absolutely brilliant.
We have a question here if it can be installed in any closed environment. And from what do you mean by closed? Is it a bit how can we interpret a closed environment?
In a closed environment. Well, as you mentioned earlier, I believe you can install it into smaller environments. So perhaps they are talking about small closed off environments in that sense.
Yeah, we are doing, for instance, isolation rooms where you want to have a downflow over the patient. If they are contagious, then you want to make sure that whatever they are exhaling is not flowing around in the air. So you could have a controlled downflow over the patient. So in such a room, if that's the question, the rooms or even venues, yes, is the answer. We can employ it in many different kinds of rooms, since we have it in labs. Huge labs that are several thousand of square meters. You can have the system. And in some places you just have air showers, and some you have temperature controlled. Depending on what you are doing in different parts of the room, you can employ the technology in a good place. We have it in the central services department, where you do packaging of sterile goods. There you have air showers that are just sort of supplying the periphery with a limited downflow, where you have a powerful downflow over some of the work tables where you do the work that needs the highest level of cleanliness.
Brilliant, amazing, yes. Do we have any more questions from the audience before we wrap up? No? Well, Peter, thank you so much for your time here. Absolutely incredible presentation. Thank you for joining the live Q&A. And thank you for attending Giant as well. Thank you.
Thank you.
Much.
Thanks for setting up. Thanks.
Bye.
Bye.
Winston Churchill once said, "Healthy citizens can be the greatest asset a country can have." I might add, the same can go for companies. Hi, my name is Clive Mickelson and I am CEO of My eHealth. My eHealth is a company, healthcare and rehab provider. Our primary focus and objective is to look after your company and your employees' health and well-being. We work in a fully integrated and interactive online environment, supported by professional health caregivers and health coaches. In other words, we take care of people so they can take care of your business. We are also your business partner. By that I mean that we're there to help you, your line managers, your board of directors to understand what's going on and to be there for the personnel. Remember, we don't all have the time to counsel and to be with each individual employee, but My eHealth is there as your partner. Mental health problems are increasing across the board. If you look at the World Health Organization's calculations for the costs for mental health on an annual basis, they are over $1 trillion a year. If you're looking at business costs, they're over $700 billion a year. This is a huge cost for companies. So the mental health challenges today are actually increasing, not only because of time and space implosion, but also some of the lean mechanisms that are placed within the workplace. For instance, if you sent in a letter in the old days, you would write the letter, you would post it, you would wait for a reply, maybe a week later you would get that reply. Today, on the other hand, somebody sends you an email and they're expecting you to reply within the minute. These all compound to have other effects on your mental sustainability. So the question could be, are companies dealing with this issue today? And there's a simple answer, no. And there are a number of reasons why they aren't dealing with this effectively. One is there's a stigma in the workplace, either in the company culture or your own personal belief of, I can't go and talk to my boss about it because I don't want to put my job in jeopardy, or I don't want to be pointed out. And usually that's a personal inhibitor preventing you from communicating these things with your colleagues or your boss. So Deloitte came out with a really fascinating report in January 2020 relating to absenteeism and presenteeism. Absenteeism is naturally when you go on sick leave. Presenteeism, on the other hand, is loss of productivity at work, where you're at work and you're present, but you're not really there. You're not at full capacity. Within that Deloitte report, they also found quite a significant difference between absenteeism and presenteeism. The absenteeism costs in the study groups that they had were around £6.8 billion a year. Presenteeism costs, on the other hand, were around £29 billion a year. That's almost 4.11 times more than absenteeism costs. As the saying goes, knowledge is power. In this case, it's extremely powerful to understand the culture of your company. My eHealth does this by looking individually at each person's parameters and how they are affected within their situational environment. We can look at the historical and trend lines for each individual and help them whenever we notice deviations to their health and well-being. So what do we offer employees? Well, put it in a nutshell, psychological safety. The psychological safety is provided through our online and encrypted network, where we provide employees with access to their own health coach, their own psychologist, psychotherapist, and statistical information about how they are feeling. Where all data compiled is protected under the GDPR and HIPAA regulations. Integrity is key, not only to an open trust environment, but an environment where employees feel safe. Ease of use is one of our key fundamentals in My eHealth. It's got to be simple. That's what we've tried to do by using a web-based platform. That means you don't have to download anything. You can just log on with your computer as long as you get access to the internet. They log on to their account, to their private space. They can take their assessments. They can log into their caregiver's calendar. They can book an appointment which suits them, and they can get feedback, a live feedback from either their coach, their psychotherapist, doctor, or psychologist. In addition, There are a number of self-help tools in order to combat stress, improve self-awareness, work on your diet, nutrition, exercise, and things like that. All with the purpose of helping somebody to maintain a health and happy lifestyle. So if we break it down, each employee gets issued quarterly assessments. Those quarterly assessments we call EFP, Empowerment for Participation. Each employee gets feedback based on their data and any deviations that we might notice. That data then is compiled and made into a knowledge base for us to understand different parameters within the company. Things like motivation, stress, defense routines, anxiety, depression, burnout, and also engagement are all measured and measured down to the department level. This compiled data gives the company the knowledge to get ahead of the curve. We have many solutions that can be adapted or tailor-made to your company, but if you look at a standard version, standard package you can say, the cost is less than an hourly wage for somebody per month to get 4 feedback sessions and 4 assessments per year to make sure that we can maintain their health and well-being. So what's in it for me as an employer? Well, increased engagement for one, mental health and well-being 2, happy workforce 3, and an improved productivity base for your company, all leading to a better bottom line. What's in it for the employee? Well, a happy employee, an employee with a balanced life-work relationship, an employee that has a private space where they can go and get the psychological safety that they need in order to take their place in the work environment, or not just in work, but in work and life. With more than 15 years of research behind us, our tools entrusted by the Swedish National Health Insurance and many companies have proven to provide high reliability and validity. Achieving preventive medicine or preventive care in psychological wellness means you've got to have a distribution risk that you can work from. By this I mean you can see a distribution of the risk levels within your departments and your company for burnout, anxiety, depression, and even engagement for that matter. So extrapolating the data from the engagement scale, we can put that into days. So we can actually look at the amount of days that you lose based on presenteeism or psychological challenges within your company. That cost can be given to you in both days or in numbers. So if you'd like a cost factor, that's available through my eHealth. We serve large and small companies alike, and we can follow your employees nationally or internationally. So if you would like to know more about my eHealth and how we can tailor-make a solution just for you and your needs, just reach out. Thank you very much for your time.
terms of, you said psychological safety, which is so important for the workplace and life in general, do you believe that perhaps some workplaces do neglect this side of their employees?
Absolutely. That is one of the key benefits of using My eHealth, is that we try to provide that psychological safety for the employees, where they can reach out, they get feedback from us live online through an interactive website, and we monitor their psychological well-being, and any issues or challenges they might have, we take up and we help them with. And this helps us to preempt, you can say, a lot of challenges that actually grow into problems.
Yes, definitely. So at the end of your video, actually, you were talking about tailored packages. You can tailor what you are offering to specific individuals. That is such an important part of the psychological process of helping people, as we are all so individual and come with different problems. Could you speak to me a little bit more about tailoring what you offer?
Sure. Well, the original, we have a full set of healthcare givers. We call it a multimodal team, where you can get access to a nurse, a clinician, psychiatrist, psychologist, psychotherapist, a health coach, nutritionist, and all of these actors are actually connected to each individual. So an individual chooses their healthcare providers, and those are the ones within the system that are available to help them with feedback whenever they need it. They get access to their calendars, and it's all live.
Brilliant. I think the live aspect of your platform is so important as well, because perhaps people, when they come to you and they feel, as you said, there's a stigma towards coming towards and getting help. So the aspect of getting live feedback immediately is so important.
Yeah, especially if somebody's stressed or they have some anxiety or depressed. They don't want to get an app which tells them, okay, download this app and read 500 pages. And then when you're finished with these 500 pages, you'll be better, right? And a lot of times people need you to put your hand out and actually be there for them. And this is the advantage of what we have today with digital online feedback in medicine, is that you can actually interact with people online. We've got a fully integrated CBT program where you, together with your health coach or your psychologist, you can break down your thoughts and your feelings, behavior, values, and conflicts that you might have with your insecurities. So there are lots of different things, all really with one purpose, in helping people to feel good.
Yes,
You know, a happy person can produce and can work and can participate in life and work, and that's really what it's about. Improving somebody's ability to partake and to take their place in whatever environment they might be in.
definitely. So in terms of the platform and working with organizations, have you found any difficulties in terms of getting organizations to really take on board the mental health aspect of their employees?
Well, there's difficulties. No, not really. Because when we can show them what we've got, and we can show them the advantage that a company has by signing up with us, they get aggregate data. Obviously, everything's integrity based, but the aggregate data which provides the company with a lot of information about the risk or that you can say the distribution risk for burnout, anxiety, depression, and at what levels the departments are at. Indicates a huge risk for a company, especially since the employee costs are the largest costs that you have. And so making sure that you can maintain a good, healthy environment is so important to productivity and the company's bottom line. So it's well proven that for every pound that they spend, they're going to save between 7 to 11 pounds, depending on the type of company.
Yes, well, the statistics don't lie.
No.
Yeah, they don't lie. So all of these issues do really affect the workplace. Productivity, number one, definitely directly affected by mental health of employees.
That's right. And so if you're looking at a mental health and really the classical modern day environment, it's not like as 20 years ago, as we said, when we send a letter and you waited for the response and there was no fax machine or things like that. Today, we've got really the implosion of time and space, which I think I've spoken about. And by everybody demanding everything so quickly, what happens is that, and the lean effects within the organization, the biological human being is caught between these two environments. And technology is increased, everything, the demands are increased, but our capability as humans have not increased. We are still the same types of humans. We're trying to multitask, we're trying to live up to those images that we create. And it's becoming more difficult. And mental health has just exploded around the world, and it's just because our biological body is telling us we just can't do this. We can't run 50 kilometers an hour or 50 miles an hour, right? We can only run 7 miles an hour. And trying to make ourselves run 20 miles an hour or faster is just crazy. It's not going to work. So part of the support that is important is to help individuals to improve their self-awareness and to realize that, you know, I'm running out of gas. My batteries aren't recharging. And then identify them and help them with the coping skills necessary to help to recharge those batteries on a continuing basis, right? Otherwise, they burn out, or they turn to alcohol, or they turn to drugs, and all sorts of other things happen when you get caught within this this implosion area, we can say.
Yes, definitely. And in terms of mental health issues in the workplace, so your platform caters to all different types of mental health issues and also different levels of severity.
Absolutely, and that's the advantage of having our platform and having us as a partner, is that we can see the severity and that actual risk. So we know whether you have a high risk to burn out or a moderate risk or low risk. And if you're at low risk or no risk, then there are other things we can always help you with, things like nutrition and exercise. All sorts of, you could have some issues problems at home that you can't switch off when you come to work. So all of these things are about how to improve engagement and lower that presenteeism cost within the workplace.
Yes, brilliant. So in terms of any last comments or anything that you would really like the audience to know, do you have anything else to say?
Well, we would like people to contact us if you would like to know more about how we can partner with you and look after your workforce. We'll be there 24/7 to be there for the employees. If you can prevent an employee from burning out or turning to drugs or turning to addictions in any way, then you're saving the company a lot of money, and not just money, but also the team dynamics and the productivity within your environment. So absolutely, we want to partner with whoever's out there that's interested in their employees.
Yes, prevention as well is one of the most important things before progressing in terms of mental health as well. So really preventing and trying to accommodate for the workforce is so important.
That's right. The prevention is 9 times of the cost of retroactive models, and most other systems out there today are retroactive in nature. It means that if you're already sick, or you've got the symptoms of and you've burned out, or you're depressed, then you go to the doctor and you treat those symptoms. But what you need to try to do really is to find those symptoms and the causes to those symptoms before they become a symptom. And if you can find those and your distribution risk, then you can proactively treat these things way before through coping skills and other mechanisms that we do online.
Yes, speak to me more about your speaking, your accommodating for the skills, say handling how, your sessions for helping the people, these potential patients, or to speak to us more about coping mechanisms.
About coping mechanisms, well, it's individual again. There are lots of standard coping skills and coping mechanisms, you can say, but everything is individually based. What's affecting, you can think of a simple way, what's affecting your bubble? Everybody has a bubble around them, right? And there are lots of different types of things that are affecting how your bubble rolls down the road. And understanding our psychometrics help us to understand you within your framework and to find out what can we do in order to fix these tarnishes within your bubble, right? And everybody has them. There's nobody out there, not one person out there that can't help with some coping mechanisms to deal with situations in a changing environment.
Brilliant. Okay. Thank you very much. That was absolutely excellent, and thank you for coming on board Giant 2020.
Thank you as well, and just reach out. We have a stand. We've got Karina, a psychologist there, and also Magnus, one of our health coaches. I'll be popping in and out of the stand, so we're open to anybody talking.
Yes, please do visit their virtual stand to find out more information and just to talk about what they're offering.
Yeah.
Thank you very much.
You're welcome. Thank you.
Thank you.
Hello, we're here at Hatfield House, which is glorious. In a not so glorious English summer weather. To test this Segway wheelchair. It's called an ad seat.
The ad seat creates a new level of mobility, allowing you to reach places that in a normal wheelchair would perhaps be exhausting. It's been created to give both the user and the family freedom to live a richer life with more independence. And as the rain began to fall harder, some of the less obvious benefits the ad really started to shine through.
I just wouldn't go out on a day like this in a manual chair. I need two hands to push it. So I wouldn't even hold a brolly. It seems like the smallest little thing. But because I'm out, I'm getting fresh air, you know, I can hold a brolly, I can move on terrain that I wouldn't normally be able to move on. It's like, I can't put a price on being able to go places and do like that. It's priceless.
Det är svårt att beskriva exakt i ord, men frihet är det för mig. Jag är i stort sett som boende tidigare.
Det är ju en otrolig livskvalitetsförhöjare. Och just det här, när man går med barnet till dagis, att kunna få hålla dem i handen. Jag blir nästan gråtfärdig bara jag tänker på det.
Fantastiskt framförallt att jag kan åka med familjen i en vanlig bil. Jag behöver inte åka färdtjänstbussen medan familjen åker bilen.
Jag har suttit i rullstol sedan en olycka när jag var 3 år. 2010 såg jag ett fordon som kunde göra mig ännu mer rörlig. Det var en Segway. Och med den som grund tillverkade jag min sittlösning AdSeat. Den blev så bra att jag snabbt insåg att det var flera som skulle kunna få uppleva samma frihetskänsla som jag gjorde. År 2012 byggde jag en färdig och funktionell AdSeat-modell. Nu finns en version som är lämpad för serietillverkning. Produktutveckling det här året riktar in sig på att få AdSeaten C-märkt och klassad som ett hjälpmedel. Nu jobbar vi också på att knyta avtal med intresserade distributörer i Europa och därefter öka tillverkning och börja försäljningen internationellt. Idag säljer jag Segwayen inklusive AdSeat i Sverige. Men för att möjliggöra större marknad säljer jag enbart sittlösningen på den europeiska marknaden för att kunna komplettera den med andra gyrofordon. AdSeat har vid flera tillfällen visats upp på den europeiska marknaden och intresset är mycket stort. Konkurrensen från liknande produkter är begränsad och det finns bara ett par liknande lösningar. Och gensvaret på mässor har tydligen visat att kunderna och återförsäljarna tycker att AdSeat är den bästa produkten.
Användningsområdet är ju gigantiskt och just det här som nu att kunna, när man går med barnet till dagis, att kunna få hålla dem i handen. Jag blir nästan gråtfärdig bara jag tänker på det.
Jag är övertygad om den här AdSeats förträfflighet och potential. Nu har ni möjlighet att vara med på den resan och ge så många fler självständigare liv.
The great thing about AdSeat and Ad Movement is we're looking at products that actually get people out and about and actually make it easy for you to get out and actually take your AdSeat with you. This is a short film showing some of the benefits of the AdSeat. The great thing about AdSeat is it is extremely flexible and makes it much easier for you to get out and about in the countryside, but also in and around town. But one of the key things we've been working with is the Department of Work and Pensions equivalent in Sweden. It's called Arbetsförmedling, and also DWP in the United Kingdom, to see how we can actually use the AdSeat in the work environment. Because one of the key parts of actually what we've seen with people is that if you can give them that confidence to get out and about to work, make it easy for them to do that, then it's much easier for them to actually get into jobs and actually keep their jobs and also be part of the team. There's none of this leaving early or leaving later or arriving later because you've actually come on public transport or some form of taxi. You can actually stay later. A lot of people have actually found that by using the AdSeat, they can actually go to and from work on the AdSeat itself using public transport, whether that could be a train or even a bus or even a taxi that's already arranged for them, because it's very easy for them to get out of their homes and actually into lifts, get out to the road and actually be using public transport. And as you can see in this video, it really shows how easy it is for someone to be in a work environment, a traditional factory floor, picking up parts, going into the warehouse, actually taking them back to where they're working. And that's the great thing about AdSeat. We've actually seen how it changes people's lives, not just in and around their home, but also in and around their work as well. This is where we see the benefit of the AdSeat, and we really hope that you're very interested in continue to work with us and actually help us deliver this into the marketplace.
Hello, Mike. Thank you so much for your presentation. Absolutely brilliant. Thank you for coming on board to Giant 2020. We are now live for our Q&A session. So let me have a look at the question. So first of all, we have a question. We have, one moment, we have, in terms of flexibility, you mentioned, flexibility is so important. Do you believe that perhaps in terms of the market, in terms of wheelchairs and accessibility, that this has been very limited in terms of catering to people who have issues like this?
I think
Yeah, I think the issue really is what sort of type of mobility do people actually want and what do they need?
Thank you so much for your presentation. Absolutely brilliant.
There's some feedback somewhere.
Oh.
There we go. Yeah, that's better. Yeah, basically, as far as actual type of mobility is concerned, I think there's a need for lots of different types of mobility for different types of people, and it's been well catered for by wheelchairs and the traditional scooters and mobilities vehicles. But I think where we're trying to go is this space between where you have a wheelchair, very small platform, and also this ability to get out and about and have some distance, so you actually are independent. And I think where we've found a niche where we're playing is this place where you can be on a wheelchair, which is like our ad seat, and also a mobility of carrying some distance as well. The other part is also this part where how do you go onto public transport? And it's very difficult to get onto public transport. So the seat sort of fits into that space as well. So it makes it very easy to go onto trains, underground, and even buses as well. So you can have this first mile, last mile traveling as well, which is very, very important because a lot of people need to be able to get from their home to the public transport. And then when they get to the other end, what to do then? Well, the seat is for that as well. So I think we did find there's a quite nice niche there.
Yes, definitely. So if I could just ask you about what this product really does increase the confidence of people and also increases the quality of life versus what this product would be centered around.
Absolutely correct. I mean, one of the issues that people have in wheelchairs is this thing with height. I'm going to use my little camera here. So you have this sort of traditional thing where you're down here and sort of all of a sudden you're having this level conversation. But actually, if you change it to eye level, it completely changes how people perceive you and how you feel. And not just that, but also your family around you. Because if everybody can actually be part of the conversation at the same height, everybody's involved, and that makes a big difference, and that's really key. The other benefit of the AdSeat is actually in the core. One of the issues you have with wheelchairs is this upper body. There's a lot of wear and tear in the upper body. The advantage of the AdSeat is actually you're moving the core. So basically you're moving the core to actually move the seat around. And that's actually really really good news for you, actually for your core, especially if you've been sitting in a wheelchair for a long time. So it improves the actual physical part of your body. And then on top of that, you also, dare I say, it's a very simple thing, it actually makes it easier to go to the toilet as well, because you're actually working the muscles in the stomach as well.
Yes, and you find that this part of having the core being available to have the core working is different to other products on the market.
Absolutely, and I think that's one of the key things we've found. We're doing some work with one of the universities in the UK at the moment, and actually researching, doing some clinical trials with that. Unfortunately, due to COVID, that's been put on hold, obviously, but we'll pick that back up again. But actually, the reports we've had from our users and also the reports we've had from the trials have been extremely positive, so we're excited about that. So if we're anything close to the sort of things that are going on with vaccines at the moment, we're 90% positive, then I'll be very happy with that.
So there is positive feedback from your product as well in terms of statistics.
Absolutely. And the nice thing about it is that the users, in a way, they don't buy it for that. They actually just buy it as a mobility device. And what we've had feedback that comes back is that how much it improves their life and how much it improves their physically, how they feel. The other part, which is one of the issues we see with MS users, for example, they use our products as a transition, maybe for 4 or 5 years, where they've have mobility issues where don't want to sit on a traditional wheelchair or buggy. The AdSeat works really well for that, and in fact, it makes their life easier for that period of time when they're using the AdSeat. It is not the solution, obviously, unfortunately, but it does help people improve their life during that period where they do use the AdSeat. And the feedback we get again from customers is fantastic, very warm as well. And the nice thing about this product is that it doesn't matter whether you get an email in Danish or Swedish or in German or in English, it warms the heart every time you see it.
Yes, well, you're helping people worldwide, so...
Absolutely, and that's the lovely part about this. And the exciting part is that the AdSeat was developed by Maris Sundin, who herself is an amputee from the age of 3 years old. So she understands that product, she understands what it needs, and because we've been designing the product in Sweden, it's used to being used in really bad weather, obviously snow, rain, all of those type of things. And of course, it can actually be used on the beach, which is wonderful. So in other words, you get this extreme of mobility where you can go from being on snow to being on the beach. And for most people in a wheelchair, even a simple thing of going to see your child play football, being on the grass, being able to go up and down the touchline and shout at your child even, it gives an improvement into the quality of life. And that's really important, not just for the health of the core of the person, but also this little thing up here as well.
Yes, of course, it must mentally really improve mental health and change things for them in that way, being able to experience all of these things that perhaps a different product could not give to them.
Exactly, and that's one of the key things, and also for the family around them. If you stand at an aircraft and you wait to board it, and you see someone come past with a wheelchair, you won't just see one person, but you'll see 3 or 4 other people with them. That's the family or their helpers or assistants or whatever. And what we're doing with this is if you can get more people, disabled people, and also the elderly out and about, you also bring more wallets with you. And so it's an economic benefit as well. So it's not just a social benefit. There's actually for society as an economic benefit, because all of a sudden there's a whole new group of people who are opening their wallets and spending money. And I think we've all got a much better understanding what it's like to be closed in, locked in, thanks to COVID. It's actually made us realize that what it's like to be actually closed into your home where you can't get out. And a lot of people who are in a wheelchair have that issue. And I think one of the things we've seen with the ADSEAT is it does change that, not just for them, but their family. Because all of a sudden you can have this situation where I've got a good example, a lovely couple that we have in Sweden. They were talking about their holidays. And the year before they bought the ADSEAT, they'd actually get a taxi 150 meters from the hotel to the restaurant they'd go to. When they bought the ADSEAT the following year, she could go on the ADSEAT across to the restaurant. But the thing that the husband turned around and said was, actually, the nice thing is after we've been for a meal, I can go shopping in one direction and she can go shopping in another direction. We have 2 different lives now. And they both really appreciate that, because all of a sudden it's changed not just the person who's using the ADSEAT, but also the other people around them, the family around them. And that's really, really important.
Yes, it changes the dynamics of relationships.
Absolutely.
Incredible.
Totally fantastic.
So in terms of anything else that you would like to tell the audience, is there any comments or anything that you'd like to explain more about your product?
Yeah, I think now we're in a place where we've been manufacturing product for 8 years now. The idea was developed in 2010, and we're now starting to scale up. We're starting to look at the UK. We're starting to sell a few ADSEATs in the UK, and we're looking for distribution in the UK. So if anybody's interested in talking to us about that, more than happy. And if anybody from the health services are interested in talking to us, we've actually been presented the product to Wheelchairs UK or Wheelchairs England, and we were at NHS Expo last year. So a lot of people know about the product, but if anybody would like a bit more information about what we're doing with the ADSEAT, more than happy to speak with them. It's an exciting journey we're going through. There's a lot more things to come from us, and we're really excited by being on this platform as well and telling more people about what we're doing.
So you just said more things to come. Are you able to discuss the more things to come?
Not at the moment, unfortunately, because there's a little thing called IP that we have to protect at the moment. But there's some really good things that are coming along, and we're really excited about it. But I think the seat in itself and what we've got now is good enough. It's exciting, and that's what's so great about it, is that what we can build on this is more than thrilling enough for not just us, but also our users. I got to say that one of the things I really love is the fact that we keep getting customers who bought a product back in 2012. I've actually bought new products in 2015, and then when we've upgraded, I bought it again in 2019. So it's rather exciting to have people come along for the journey, as far as a bit like actually manufacturing a car. You get people coming back for buying a new model. It's rather fun. And
well, your customers have been very consistent as well, which shows how truly valuable it is to have the wheelchair. Yeah, absolutely. And one of the things that was exciting was when we worked with Arbetsförmedlingen in Sweden. Arbetsförmedlingen is equivalent to the Department of Works and Pensions in the United Kingdom. And we did an 8-month trial with them, and it's now approved in Sweden. So they will actually subsidize that for people to get back to work. And if you look at the cost of the product in relationship to what it costs to actually have someone who's not working, it's actually a significant cost saving. So we're also doing some work with the DWP in the UK as well, about how the product can be used. Oh, amazing, amazing. So it has benefits other than personal, as you said earlier. It really does help lots of things, organizations, companies even. And society, in general, because we've got a CDC in America, 8% of people need a mobility device. Somewhere around, I think it's about 19 million people in the US cannot walk more than a quarter of a mile.
So there's a lot of people who are actually got mobility issues that are over and above those who are disabled, but those who are aging population, or just basically people who are unfit. We can help them. And because the product is not passive, in other words, you have to be active. It's not like you sit in a wheelchair and just get moved around. Here you have to be active. And I think that's the really key part about it. It's not just a passive device. And I think that's the exciting part as far as I'm concerned. We're not just there to make it easy for people. They do have to work a little bit, which people appreciate.
Yes, I think people would appreciate definitely the opportunity to be able to work with it as well. Yes.
So that's a lot of fun. And one other aspect is that we've, all the way through this, we've always worked very closely with various bodies and actually making sure the product is absolutely right for each of the markets. And the good thing about it is the feedback we get from our customers is incredibly constructive and useful. And so all the things we're doing there is actually just taking it forward of what our customers need, whether they're MS customers or whether they're amputees or whether basically they've got short-term illnesses, basically where they actually just need a mobility device for a very short term when they've had a hospital operation or something like that.
Yeah, so this product really caters to what the people are saying, what they truly want. So this is what they want. Brilliant. Yes. So everyone listening right now in the audience, if you could please attend the virtual stand of Add Movement, Mike, and please find out more information about this incredible product. It's very, it helps all these people. It's versatile and it really improves people's lives. So please do ask more questions about it to him. And is there any last things you would like to say, Mike?
No, just thank you very much, and thanks for listening. And
I
look forward to speaking on stands. Thank you.
Thank you.
Hi, I'm Michael from Learning to Sleep. Today I'm going to talk about how bad sleep affects our health, what we have done in Sweden to treat over 2,000 patients with our digital products, and also give my take on how the existing healthcare system is treating people with bad sleep at the moment. I will then finish up by giving some of the best advice that I have for those who suffer from a bad night's sleep now and then. So stay tuned and let's start. So Learning to Sleep is a digital sleep clinic which helps people with bad sleep to get better using a mobile application and a backend system. I will show you later how everything works. But first of all, when I meet people and tell them what I do, a lot of them ask me, why do you do this? And the main reason why I got involved was that I realized that bad sleep affects us deeply and especially affects our health. In UK alone, I read the other day that 46% of the working population sleeps less than 6 hours per night. And that affects our health. It affects the healthcare system and affects the society and of course the individual in a very bad way. Another way to see is the number of people who eat sleeping pills regularly. In Europe alone, 70 million people eat sleeping pills every day. And we know that sleeping pills affects our health, it's addictive, and it has a lot of effects on your body that you don't want, and everybody agrees on that. So that's also one of the reasons why we do what we do. And how has it become like this? Why don't we sleep well enough? Well, I would say that the times we live in and the role models we have, like Elon Musk here, affects us. A lot of people like Elon says that, no, I only sleep 4 hours per night. And those types of role models that we look up to affects us in our daily life, thinking that sleep is something that we could reduce in order to get more efficient during the hours we work. And it's actually the total opposite. My role model is actually Brian here. I stayed for a couple of days in San Diego a couple of years ago, and I used an Airbnb and stayed with Brian, and it turned out that Brian was a Navy SEAL. And when I told Brian what I do, working with sleep, he told me that if you're a Navy SEAL, you actually get sleep training, because they realized that sleep is so important. You need to make a decision in a split second, and having had a good night's sleep is really something that's important for you. So maybe we should look more into how people that make decisions very fast looks on sleep, instead of looking on those people who say that you shouldn't sleep at all. And of course, then there's a cost. There is a cost for society for bad sleep. If you look at the healthcare system alone in Europe, we're talking about 73 billion euros per year, which is the cost of bad sleep, direct costs for the healthcare system. And of course, if we look at the individuals, we now know that bad sleep causes all these types of lifestyle diseases that we talk about, everything from obesity to mental illness, but actually also cancer or high blood pressure is connected to people with bad sleep. And if you sleep less than 6 hours per night, the risk of getting one or two of these lifestyle diseases is much higher than if you had a good sleep. So what we work with is people with chronic sleep problems, not people who sleep bad now and then. And when do you have a chronic sleep problem? Well, if it takes a long time to fall asleep every day, if you wake up during nighttime and you can't fall asleep again, or if you take pills to fall asleep, if you're worried about your sleep and start worrying during daytime, or if you have cravings for sweet, that's all signs for signs that you have which could be related to a chronic sleep problem, and it's something that you need to do something about. So and also if of course if you try to regain sleep during weekends, that's another sign. Our sleep clinic is based on a mobile application, and now I will show you a short film with Lina, our Chief Medical Officer, who will talk about sleep and learning to sleep and exactly how our method works.
Hi, my name is Lina, and I'm a licensed clinical psychologist with Learning to Sleep. We offer cognitive behavioral therapy for insomnia, which means that we help individuals who experience sleep problems that interfere with their daily functioning or overall quality of life. CBT is a scientifically proven and well-researched method and is also considered the gold standard treatment for insomnia. And this is how it works. By downloading our user-friendly app, clients can schedule an initial appointment. In order to provide an efficient treatment, new clients are asked to provide information about their sleep pattern and overall health. Our treatment is completely online-based, including weekly video sessions, making it more time efficient than traditional treatment. In between weekly sessions, clients are guided through assignments based on scientific methods. And to measure the sleep improvement, clients use a sleep diary. Both the client and psychologist can easily monitor progress, and adjustments can be made to optimize treatment results. To further ensure the best treatment results, clients can easily ask questions at any time by using the chat.
So that was Lina. Now you got a glimpse of Learning to Sleep. We have been commercial in Sweden for about 4 years now. We have treated over 2,000 patients during our 5-week program, and of course it consists of the mobile application and the backend. And we have fantastic results. 94% of the people who do our sleep treatment actually gets a sleep improvement. We measure all patients using ISI before and after treatment. We also only have 10% dropout rate, so more than 90% of the patient that we treat actually goes through the whole 5-week treatment. And of those who eat sleeping pills, when we start, 80% of them stop during the treatment, which are fantastic. We are backed by science. Everything we do is, of course, science-based. CBT and sleep restriction are evidence-based methods. Back in 2015, 2016, we did a clinical evaluation together with Pfizer in order to see if the system works, the method works, which is that it does. And we are starting off now doing a full-scale randomized clinical study together with Karolinska Institute in Sweden. So we really know what we are doing. I promised in the beginning to say something about why the traditional healthcare system doesn't really use these types of digital products as much as they could. And I do have some thoughts about that. It takes a long time to implement things into the traditional healthcare system, and this is probably one of the reasons. I mean, the consumers, the patients, are taking back power in the field of healthcare. The healthcare in general is one of the sectors who have the lowest degree of digitalization today compared to a lot of other sectors in society. And what we see is a growing demand from patients, not only for self-help products, but actually to evidence-based do-it-yourself healthcare solutions, maybe connected to the traditional healthcare system in any way. And why is this taking so long time to implement? My take on this is that it's because it's disruptive, and that means that it's a threat to the people working in the traditional healthcare system and to the healthcare system in itself. And to pick up a very old research report from back in the days, there is a connection between technology, people, organization, and work tasks in most systems. And the theory says that if you change one of these, you actually change the whole power structure for a system. So what is happening in healthcare is that we are using new technology that changes things, and that affects both people, work task, and organization within the healthcare system. And that means that there are a lot of people who tries to work against change and against the disruptive technologies. And we need to understand that this is the way it is in order to make change happen. That was my take on that. I promised you that I will give some more practical tips at the end of the speech, how to sleep better. And I have collected 5 of the things that I think is most important that you can actually do for yourself in order to sleep better. So first of all, try to keep regular sleep times. If we keep regular sleep times, the brain will learn when it's time to go to bed and when it's time to go up. And the brain loves that. The brain loves regularity. So try to go to bed more or less at the same time every day, and try to go up more or less at the same time every day. Even if you were up late yesterday, try to go up within 30 minutes around the normal time you go up. The brain will like that. Then, of course, turn off your mobile and iPads and computers 60 minutes before bedtime. Everybody knows this. Everybody knows about the light that they sent out. It's bad for you. It distracts your melatonin level, and that's not good. But the most important thing is that they start processes in your brain. I mean, what happens when you go to bed and you lay in bed and you look at Instagram and you realize that your friends are partying and they didn't ask you? When then you start to think about that and thinking that, oh my God, they hate me. They don't want me to go out to party with them. And then you start talking to your partner about that. And then you have ruined 2 persons' sleep. So avoid phones at least 60 minutes before, and especially avoid social media, because that is totally ruining your sleep. If you can't fall asleep, if you're laying in your bed, or if you wake up during nighttime, you can't fall back to sleep. If you have been in bed for more than 20 minutes, go up and do something else. I'm not saying start watching TV, but go up and see if there is something else you could do, because that will really be of great help for you. You shouldn't associate your bed with laying awake. You should associate your bed with sleep. So don't stay in bed. Go up and have a glass of water, stare out the window, do something boring. And then, of course, develop a good sleep routine. Try to do the same thing every night. If that is brushing your teeth and listening to death metal music at the same time, do that. The brain will very easily learn what type of activity that is connected to sleep, and it will make it easier for you to go to sleep. And last of all, of course, try to avoid substances that affect sleep. We all know about coffee, but actually alcohol has the same effect on your sleep. So try to avoid those substances. Make a simple test. Stop drinking coffee at noon and see if that helps you, because caffeine has a tendency to stay in your body for longer time that you think. So to round this up, my suggestion for you in order to have better sleep, when it comes to sleep, don't follow the advice from Elon Musk. Be like Brian instead, and take good care of your sleep. Thank you so much for listening to me today. Bye.
Amazing presentation. Thank you so much, Michael, for that. This is Michael from Learning to Sleep. We are now live with our Q&A session. So first of all, Michael, if I could just ask you, could you further explain about giving patients tasks to aid with improving their sleep problems?
Yes, of course. I mean, we work basically with two things in the treatment we do. Cognitive behavioral therapy, where you could say that the main behavior change takes place, and that is also where we give the patient different types of tasks to fulfill during treatment. And then we also do something called sleep restriction, where you bring down the time the patient spends in bed to a minimum. So when it comes to tasks, a typical task is to learn how to handle worrying thoughts. And that is something that is done within the mobile application. So the application will guide you through, you could say, structured way of handling worrying thoughts during nighttime when you're stressed or something. I'm sure that you have experienced that maybe before the conference, having a lot of things to do, and then you suddenly wake up and start to worry about them, and then you can't go back to sleep. And there are methods where you, for instance, write down just on a piece of paper, not on a computer or a phone, because that the light will kind of destroy your night. but on a normal paper, you just write them down and also write down the consequences. And when you do that, you actually start a process in your brain where the brain accepts that, okay, I will fix this tomorrow instead. Another typical exercise or task that patients will do is that before bedtime, they actually write down all the worrying issues they have in order just to have them on paper, because then the brain will accept that, okay, let's deal with this tomorrow instead. Now it's time to sleep. So that's a typical task that you do.
Yes, so essentially brain training.
Yeah, you could say so. Yes. I mean, it's nothing that we have invented. It's part of a normal CBT session. So every psychologist that works with CBT will give their patients these types of tasks. Also, when you attend sessions not focused on sleep, focusing on anxiety or depression or anything else. Yeah.
So you mentioned in the video 94% reported better sleep in scientific evidence. That is an incredible amount. That is a huge difference in quality of sleep from your participants. And you have also worked with companies like Pfizer, huge company. So your platform really does work in terms of effectiveness.
Yes, it does. And we have, so far we have treated about 2,000 patients here in Sweden, and everyone we measure sleep quality through using self-assessment, but still, we measure the patients with ISI before and after, and we see that 94% of the patients also in long-term have you could say, improvement of 3 points or more on the ISI scale, which is regarded as clinically validated improvement of sleep quality. So and when we did our study together with Pfizer, we also measured patients 12 months after treatment, and we could see that there is a continuity in the effect that we have. So the method is also sustainable.
Yes, I think the sustainability and consistency of having a method which is effective is extremely important to participants and people who have issues. A lot of the time you'll see an immediate positive response, but whether this actually continues months after is very important.
Yeah, it is. So we're really happy, and the biggest reward at the moment is actually that I get emails from patients more or less every day that we have helped, and they are happy, but also thankful that we have kind of giving them their lives back, which is fantastic. So we are so happy and proud working with sleep and helping so many people, and hopefully we will be able to help a lot of people in the UK as well.
Yes, amazing. So also in terms of sleep, sleep affects mood, it affects memory, general performance as well. Do you believe that people truly realize this?
More and more. I would say that the past year, sleep has kind of gone upwards in the agenda. So we see a lot of stuff in media right now, and a lot of also researchers talking about sleep. I think it was, it began kind of with Matthew Walker and his book about sleep. And then it has continued going from there. But of course, still, if I go out on a dinner with friends, I still meet people who think that no, but I sleep 6 hours per night. That must be enough. Or in general, people don't know. And what I would say is more frightening is actually that a lot of GPs doesn't realize that sleep is so important. So if somebody turns up complaining about high blood pressure or something else, where we know that bad sleep actually affects that type of chronic diseases a lot. Still, GPs tends to just prescribe a pill instead of asking the patient how they sleep and how much sleep they get every night. I mean, if you have a population in the UK where 46% of the working population sleeps less than 6 hours per night, I can imagine the number of people who suffer from obesity or diabetes or high blood pressure or other types of mental illness just due to the fact that they sleep too little. And it is not really, I think the general population knows a lot about sleep today and actually knows more than the average GP, I would say, which is, I mean, that's kind of the biggest challenge for us and other actors who works in the field of sleep, that we need to get more impact into the traditional healthcare, because there's a lot of money to save for NHS if they address this problem properly.
Well, yes, if they address this, they limit and they reduce the physical repercussions of lack of sleep, like you said, high blood pressure, all of these really important things that do affect the healthcare system.
Exactly.
And yeah, I think also in terms of frame of thinking, let's say, of people in general, I think people have an attitude sort of that if you get 6 hours of sleep, you'll be more successful in life. But however, that's, as you're saying, it's not actually the case.
No, it's not. I mean, there is a general opinion, especially amongst people who have kind of high stress, knowledge intense jobs like yourself, that you think that 6 hours is enough because then you can spend more hours at work. But the truth is that you're actually less productive. If you sleep only, say, 6 hours, you are in average 12% less productive than someone who has slept 8 hours. So you kind of lose, you gain some hours, but you will lose some efficiency. So I'd say that for the employer, it's better to have employees that sleep their 7.5, 8 hours per night instead of pushing people to stay at work until 1 o'clock in the evening and sending them home and expecting them back at 7 o'clock the next day.
Yes. You gave some brilliant advice actually in your video, referring to if you cannot sleep, you should actually get up and do something.
Yes.
Could you explain that a bit further, please?
Yeah, I mean, our brain is fantastic, and it also very easily adopts new things. So what happens when you lay in bed and don't sleep? Well, the brain will actually very fast learn that it's okay to be awake in bed. That's why you should avoid laying in bed watching TV or doing other stuff. I mean, you should use your bed for only two purposes, and one of them is sleep, and the other one you have to figure out by yourself. But and if you stay longer periods in bed without sleeping, the brain will associate the bed with not sleeping. So then it's actually better to stay up. So if you wake up at 3 o'clock in the morning and you can't fall back to sleep, then it's better to go up, do something else. Of course, not start to watch a horror movie or something, but just go up, sit in your sofa instead, have a glass of water or a glass of milk or something, and stay up for 15 minutes And then if you start feeling sleepy, just go back to bed and try to fall asleep again, because that's better than just laying there and trying to get back to sleep. So it has to do with the brain's ability to learn things fast. So by avoiding being in bed and for other reasons than sleep, we will not teach the brain that or learn the brain to associate the bed with other things besides sleeping.
I see. Right, amazing. So, did you have any last comments you'd like to say? I would just like to point out that you did mention in the beginning of the video that 70 million people take sleeping pills and the cost is 73 billion a year. So to the audience watching, this is such a huge problem for the healthcare system. So really do go to the virtual stand, discuss it further with Michael, and really take on this opportunity to collaborate.
Yeah, okay. Thank you so much, and thank you for having me for this.
Thank you very much for coming on board. Thank you.
Okay. Bye.
Hello, my name is Simon Barriga and I am the CEO of VisionQuest Biomedical. Our company uses artificial intelligence to end preventable blindness. Our company vision is to use artificial intelligence in one retinal picture to detect multiple diseases. Diabetic retinopathy, cerebral malaria, retinopathy of prematurity, hypertension, macular degeneration are among the diseases that can be detected using just one retinal picture. And in this presentation, I'm going to show you the three systems at the top that we have developed at VisionQuest. The first system is called iStar, which is artificial intelligence software to detect diabetic retinopathy. Diabetes is a global epidemic. Right now, there are over 460 million people worldwide with diabetes, living with diabetes. And in 2045, it's projected that that number is going to grow to 700 million. Now, diabetes causes several complications, heart disease, kidney disease, amputations. But one of the most common complications of diabetes is diabetic retinopathy, which leads to blindness. Now, blindness can be prevented with an annual eye exam, and that's why it is recommended that every diabetic goes to an eye care specialist and gets an annual eye examination. Unfortunately, there's not enough doctors, there's not enough ophthalmologists or eye care specialists to perform these examinations. And because of that, many people go blind unnecessarily. This is where artificial intelligence comes to play. Our solution is to use artificial intelligence to increase access to eye care. How we do this? By putting the screening locations at places where the patient with diabetes is already going to get their medications, to get their general practitioner exams, to go to retail clinics. There, we can use a portable retinal camera that can take pictures without dilation and using only a technician. And then those pictures are uploaded to the cloud where our system can process those images and within 1 minute get a report back that says whether the patient has diabetic retinopathy or not. In fact, I'm going to demonstrate that system right now. Here it is, our website for iStar, where you can get a username and password, log in, and you have your portal where all the patients that you have created are present there. And I'm going to quickly create a new case and show you how the system works. You select the site ID, the type of camera that we're using, can enter a patient ID and a name. I'm going to use my own name here. And then you have other information that you can enter that is optional, like gender, whether the patient has diabetes or not, and so on. Then you go to upload the retinal pictures, and you can simply drag and drop pictures, upload them here, and then they're going to be sent to the Amazon cloud where our system works. Once all the images have been uploaded, and we need at least 2 images per eye to produce a result, the system is going to start processing it. And what it does is that first, it checks the quality of the images to make sure that there is sufficient information in those images to create a result. Then it runs those images through a deep learning classifier, or neural networks have been trained with tens of thousands of images from multiple ethnicities and races that we have collected over the years. And we've trained our system to detect the sight-threatening stages of diabetic retinopathy. This is all done without the need for dilation, and our system is capable of processing over 98% of the cases. Now the analysis has been completed, and in this case, the analysis says that this patient has diabetic retinopathy that is severe and that needs to be seen by an ophthalmologist. And it produces a report which can be quickly downloaded, and you can give this to the patient or to the physician who is interpreting these images. So our system got a regulatory clearance in Mexico. And since then, we have deployed them in 15 clinics, and we have screened over 35,000 patients with diabetes. And we've saved over 5,000 of them from going blind by detecting sight-threatening diabetic retinopathy. This system will be available in Europe in 2021. And the cost of the equipment, which is sold by different retinal camera manufacturers, is between $6,000 to $10,000. And the exam, the software, it's a $5 fee per exam, or we can bundle it as part of an annual subscription. Our next product is Aspire. And for this product, we are detecting cerebral malaria. Cerebral malaria is an epidemic in Africa. There's over 10 million children per year that are infected with cerebral malaria, children under 5 years old. And this results in over 100,000 of them dying. One of the reasons why they die is because there is a misdiagnosis of the disease. And we have created a system that helps doctors diagnose cerebral malaria with high accuracy. And the way that our system works is that we take a retinal picture using a smartphone and a smartphone attachment, and then use artificial intelligence to interpret those pictures and detect cerebral malaria by detecting lesions in the retina that are very specific to the disease. We are already clinically testing this system in Kenya, Malawi, and Zambia, and we expect to be in the market very soon. The system is also cloud-based, and the operation is very similar to what I just showed you with iStar. But we will also make it integrated with a smartphone so that you don't need internet connection to use the system, because in many countries where this system will be used, there is no reliable internet connection. The cost of the equipment here is about $1,500 to $2,000. And that is the smartphone that takes the pictures plus the attachment that goes with it. And our software is sold on top of that equipment at about a $500 annual subscription. The last product that I wanted to show you today is NeoScan, which is intended to use artificial intelligence to save sight in premature babies. NeoScan detects retinopathy of prematurity, which is the leading cause of blindness in children. Children who are born premature under 32 weeks need to get ROP examinations so that a retina specialist can determine whether the retina has developed correctly and if it's not a risk of getting hemorrhages and traction and leading to blindness. So the way that our system works is that it has been integrated with a headset called the Mobile Indirect Ophthalmoscope, which is has been developed by Geer, a UK company, and that uses a smartphone to take videos of this baby's retinas, as you can see there in the picture. And then our software takes those videos, selects the best images from the video, and then produces an interpretation of whether the baby has a sign of advanced retinopathy of prematurity. The cost of this headset is about $1,000, and it comes included with our software. And it's now available worldwide. So I want to thank you for your attention. And if you want more information about our products, please feel free to contact me at my email or via our website. Thank you very much, and I'll be happy to answer any questions that you may have.
Thank you, Simon, so much for your video and welcome. This is our live Q&A session. You are doing brilliant things to help people around the world with their eyesight. Let's talk a little first about using AI to prevent blindness. Through this, you will save the healthcare system a huge cost by preventing blindness. So we really, really want to emphasize the point of this as a means of prevention. Would you like to speak a little more about that?
Sure. Thank you, Jerry. Yes, the cost savings for the healthcare system are enormous because a patient that goes blind, not only there are problems with the treatment, then the blind rehabilitation that they have to go through, but also the impact on their families and the impact on their capacity to provide for their families. Diabetes and diabetic retinopathy affects people who are still at stages where they are very productive. So if they're not able to have good eyesight to be able to do their work, not only is them who suffer, but also their families, and then the whole healthcare system spending a lot of money in trying to help with the rehabilitation or the treatment. There are very good treatments for preventing severe vision loss right now, but they can be very expensive as well. So if it's detected earlier, the disease can be stopped and the cost of it can be lowered much.
Yes, of course. Amazing. So you have Aspire. So talk to us more about cerebral malaria in terms of Aspire and what you offer.
Right, and that's a very interesting project that has a huge also human impact to it. Even though we are going through a terrible pandemic right now, some people in Africa experience this year after year, and there is 100,000 children under the age of 5 in Africa dying from cerebral malaria. And unfortunately, a lot of them die because there is a misdiagnosis of the disease. They are treated for cerebral malaria when they have maybe other complications that are causing the death. So several years ago, a group of doctors based who worked in Africa, but who are from the US and the United Kingdom, worked on trying to see what the effects of cerebral malaria were in the retina. And they found that there were very interesting signs of the parasite sequestering blood vessels and and then creating lesions in the retina. So now there are equipment that we can take a picture of a child who goes into a malaria ward, and we can analyze those pictures using AI, and within minutes we can give a doctor treating that patient a very good idea of whether that patient has cerebral malaria or not, and that will help save at least 20 to 30% of those children's lives. And we're really excited about that project because of the huge impact that it will have in saving the lives of children under 5 years old.
20 to 30% is a huge improvement. Absolutely brilliant. So let's talk about statistics a little. You mentioned, I believe, 5,000. You prevented 5,000 people from going blind. Speak to me more about that.
Sure. Several years ago, we partnered with a network of diabetes clinics in Mexico. They're based in northern Mexico, and what they do is that they have these clinics where they care for people with diabetes, and they do all these different types of exams, and they don't have any particular specialties like an ophthalmologist or an endocrinologist, but what they do is they do a lot of preventative services, and towards the end of the visit, a general practitioner will look at the patient and see all the test results, and we give them a care plan. So what they're doing is to use our system kind of at the beginning of the visit. They take a picture of the retinas, and then they send those to the cloud, and we provide a result to them within a couple of minutes. By the time that the patient finishes all their tests and sees their GP, the practitioner knows whether the patient has the likelihood of severe diabetic retinopathy and they're at danger of going blind. So then they can send them to a specialist. And the key part here is that we want to make care more efficient. So instead of sending all the patients to an ophthalmologist for a regular eye exam, which there's not enough ophthalmologists to do all these exams, and they are trained to do things that are more complex, like treating the patient or managing the patient. Instead, they only send 10 to 20% of those patients. And those are the ones that we're saving their sight, because otherwise they would have gotten these exams and they wouldn't have found out that they have a very severe condition that could lead to blindness.
Yes, and also, well, we have, as you said, it saves time and it takes only a few minutes to do a scan. I really, really want to pinpoint that. That is amazing. It takes only a few minutes. That would help the healthcare system dramatically.
Absolutely. And also, if you can put these systems in places where the patients are already going to do other things. For example, if they go to a pharmacy to pick up their medication and they can get those pictures taken within 5 minutes without an appointment, without needing having to wait for your place in line, and you get your results right away, then it's a more opportunistic way of getting these screens done, getting them faster, and accessing a wider segment of the population.
Yes, and also in terms of saving time, I mean, time is essential with things like going blind. So really in that way, by being able to have an instant scan, to be able to, refer people straight away, it would be so amazing to just prevent blindness and also save money to the whole healthcare system in that way.
That's right. And one of the key things about the diabetic retinopathy is that you don't get any symptoms until it's kind of late and you're already losing your vision at a point where the treatments are not as effective. So it's very key to catch the disease early. And a lot of people don't go to their annual exams because they see fine. So they say, well, I don't have a problem with my eyes. Why should I get my eyes checked and having to go to a specialist and having to get an appointment and all of that? So what they do is that they skip the exam. And then they go to the ophthalmologist when they start seeing some spots in their vision. And at that point, the disease has already progressed to a more severe stage. We want to catch it earlier when there's no symptoms yet. And in order to do that without having to get appointments and all that, you have to be opportunistic about where you are you're performing these exams.
Yes, definitely. So let's talk a little about NeoScan as well. So you do provide a service for infants, and it is a lot harder to provide a service for infants as well. So talk to us a little bit more about NeoScan. Yes,
that's a very interesting product. We're working with a company in the UK, Geer, which is it's a 100-year-old company based out of London. And what they do is that they develop a lot of the lenses that ophthalmologists and equipment that ophthalmologists use to do exams for adults, for children. And what's happening is that for a number of years, ophthalmologists look at the retinas of the babies who are born prematurely and who need to get these exams done because the retina may not have developed correctly. And they do an examination. It takes a few minutes. And then they write down on a piece of paper what it is that the baby may have. And then they communicate that to the parents who, don't really understand what's going on because they have no way of seeing that. They communicate that to the neonatologist, who then has to make a decision of whether to change the levels of oxygen that the children will have and things like that. They have to make complex decisions out of just handwritten notes from the ophthalmologist that may not be well communicated. So what Geer has done is to develop a way to image these views of the retina that the ophthalmologist is getting And you can do it in two ways. One is with the system that I showed in the presentation, which is basically a smartphone attached to a headset, and then you put the lens in front and you record what the doctor is seeing in the lens. And what our software does is then to process those images, because those are images that can be of very low quality and then need to be integrated into a full view of the retina. So our software integrates all that and presents the doctor with the best quality views of the retina, presents the doctor with a wide field view of the retina so they can make a better interpretation. And then most importantly, they can communicate that now to the parents and show them a picture and say, look, your baby is having these issues. I'm going to need to do some treatment. Or after they are discharged from the neonatal unit, they need to follow up with the ophthalmologist. And sometimes that's hard because these babies may have a lot of other complications that are going on and that the parents are worried about or the doctors are worried about. But it's important to save their sight and to not, have that long-term effect in their life. So this product is going to help us do that. The product that we show there is aimed more towards developing countries. We're also developing another product for the US and Europe that has a little bit of a more complex equipment that is more standard of care, and that should be in the market next year.
Brilliant. And also, I think we need to remember babies, they can't talk, they can't communicate about their eyesight. So this is really, really important.
Absolutely.
So let's also talk about comfort of the product. Some people may be a little nervous about going through the scanning process. So in terms of comfort and ease of use, if you would like to explain a bit more about that.
Yeah, it's very easy to use, very easy to take the pictures. The cameras that we use are manufactured by different companies. We don't manufacture the cameras. Our product is the software to interpret those images. The nice thing about those cameras is that you don't have to dilate your pupils. So if you've ever had to go get an eye exam, you have to get dilating drops, your pupils dilate, and then for hours, you see everything very bright, and it's difficult to focus, so it's difficult to drive or to do anything for a few hours after that. When I get my eyes dilated and I go in front of my computer, I cannot work for hours because I cannot focus my eyesight. So in this case, we don't need any of that because our software is very robust. It works very well even when there is low illumination, where the pictures are low quality. We've make sure that the software still works. So it would only take about 5 minutes to take the pictures. You don't have to get your pupils dilated. And the only thing that you see is a little flash of light, as if somebody was taking a photo just up close in a flash of light. And you'll see a little bright spot for 30 seconds or so, and then that's it. And the pictures can be taken by a technician, so it doesn't have to be anyone that is medically trained. We can train a technician to take these pictures in a couple of hours and to get pretty good at it. And there's even now cameras that are fully automatic, so the operator, the only thing is have to press play, and then the camera takes all the shots that we would need. So it's even more convenient.
Yes, so very highly efficient, very easy and accessible.
Complications that are affecting millions of people worldwide, and that with just one retinal picture, we can detect many of them. So we hope to bring even more products in the future to the market. And I'm happy to speak to anyone who'd be interested in that.
Amazing. Thank you so much for your time. Amazing company, amazing products. Everyone, please do head over to their virtual stand. This is Simon. Thank you so much for your time. And
thank you very much.
Yes, thank you. Have a lovely day.
You too. Bye-bye.
Hello, I'm Daniel. I am the CEO of Flow Neuroscience.
And I'm Nikki, and I help with clinician partnership efforts here at Flow Neuroscience.
And if you're interested in a new way of treating depression, then you come to the right place, because we offer an at-home, medication-free treatment that could work as an alternative to the standard model of care.
Yeah, and today we'll explain to you who we are and what we do, and how you can best support your patients with our treatment.
Okay, so let's start with who we are. So we are a health tech company specializing in the neuromodulation field, trying to bring a new wave of mental health treatment to the public. And our first product, Flow, is a unique solution for unipolar, or what we call regular depression, of mild or moderate degree, based on brain stimulation and virtual behavioral therapy. So in this treatment solution, we bring brain stimulation home to the patient by combining a medically certified TDCS headset with the Flow app. And our solution ensures that the patients and the clinicians have a very powerful treatment solution that is free from severe side effects and that can be combined with medication or talk therapy or used as a standalone treatment. So the brain stimulation technique that we are using can be described as a safer version of TMS, transcranial magnetic stimulation. And it has decades of research behind it. Numerous double-blind RCT studies published in, for example, the New England Journal of Medicine and the British Journal of Psychiatry show that TDCS is almost as effective in treating depression as a larger dosage of SSRIs. So in our internal data, we see that 81% of our users decrease their depression symptoms in just 3 weeks. And what's even more important, about 35% go into remission. This is a truly remarkable number in a real-world setting. So to get you to understand us a little bit better, we're going to take you through some key use cases for where Flow might fit you. So Nikki, take it away.
When clinicians come to work with Flow, they come with specific patients in mind. One of the most common types of patients are the ones who come and say, I am suffering from depression, but I do not want to take antidepressants. Often patients do not want to take medication as they worry that they will be on it for a long time if they start. And patients are also worried that they will become dependent on it. And as you know, they are particularly anxious about well-known serious side effects of antidepressants, such as weight gain, insomnia, sexual dysfunction, and even potential suicidal risk. However, what we hear from clinicians often is that they find it very hard to know how else they can treat these patients and what they can offer as an alternative to medication. At the moment, they either suggest lifestyle changes or low intervention methods like meditation. However, clinicians often do not have an alternative option that can fundamentally tackle the imbalance in lowered activity in the brain regions of these patients. And this is where Flow comes in. Now, with a solution like Flow, clinicians can bring a medication-free, safe, and effective treatment. Unlike antidepressants, patients do not have to go through the risk of serious adverse side effects. Patients now can treat their depression first with Flow. For these patients, Flow brings a neurological effect as well as a behavioral effect with its brain stimulation headset and app-based behavioral therapy. And then there are patients who have already been on medication. And this is a second type of patients that clinicians see Flow fit in their treatment journey. As many people with depression know, being on medication can be for a long haul. This leaves many in a position where they've relied on a substance for years that has an effect on other parts of their brain and body. To cope with tolerance, emotional blunting, and other long-term side effects, many of these patients want to lower dosage or come off medication altogether. But it can be very hard to go completely cold turkey or even start to lower the dosage without having another option that provides similar effects to their brain. So with a solution like Flow, you can provide another tool in your toolbox as a clinician to help long-term depression patients reduce their medication or come off it altogether. Recently, Flow has been featured on BBC. BBC featured Mike Story, who successfully managed to reduce his antidepressant usage with Flow. Clinicians long to help their own patients with Flow, as Flow had done with Mike. The third type of patients that clinicians introduce flow to are the patients who cannot or do not want to see doctor regularly. Many patients and clinicians alike struggle with the amount of visits required to handle and manage depression. This can be tough, especially as you work to maintain contact with your patients and provide them with the appropriate care in between when you actually meet with them. With Flow, you as a clinician can introduce a treatment method that reaches your patients at home and creates a big advantage to reduce the barrier to your patient getting better. As you know, our Flow treatment combines a brain stimulation headset and an app-based virtual therapy program. And it is this combined nature of the treatment that allows you to treat your patients effectively at home. First, patients can access our treatment very easily from home. The Flow headset can be delivered directly to their doorstep, and your patient can download the app for free. Secondly, the app guides them through how they can stimulate with the headset, monitors their stimulation usage, tracks progress over time with a self-reported matter scoring. Thirdly, the app also provides them with virtual behavioral therapy sessions. So with our at-home solution, you can better support the patients who cannot meet with you regularly or as often as you wish to. Lastly, Flow can be a great option for the patients who have already been treated with other brain stimulation techniques such as ECT or TMS, but now looking for a more accessible, safe maintenance option. There are many depression patients who are well aware of brain stimulation and have tried this treatment in clinic, seeing great results. However, it can be very difficult if they wish to carry it on as part of their regular treatment plan. If they continue with ECT or TMS, people have to invest a large amount of time for ongoing in-clinic stimulation sessions, and the cost will be very high if the type of stimulation is not covered by their healthcare. Flow brings brain stimulation to your patients, but in a safer and more accessible form. With a more mild current making it safe for at-home use, Flow provides a convenient, safer, and more cost-effective solution for your patients as part of their long-term care plan. So the question is, how can you as a clinician and your patients access Flow? Great news is that patients can directly access Flow right at the moment through our website. As we are medically certified as a Class 2A medical device for patient at-home use, we can offer our solution directly to the patients. On our website, they can either choose to buy and own our device or rent out a Flow solution. And as a clinician, you can work with us to decide what works best for you. Right now, we offer different options. First, you can choose to get a demo device and test it out in your practice right away. For these clinicians, we provide a special healthcare professional discount offer for the demo. Secondly, you can choose to work with us as a clinician node. As a clinician node, you will be working with patients interested in Flow or using Flow in your area. For these clinician nodes, we will provide all the relevant training and materials so that you can best support these patients. No other financial commitment is needed, just the commitment to help the patients coming your way. Thirdly, you can choose to refer your patients to a clinical trial program using the Flow solution. For example, there is an ongoing independent study run by University of East London at the moment. And lastly, through our Expert Spotlight series, you can share your story of innovating mental health care. Our Flow team will work with you to create content to share with our own Flow patient community as well as your patients at no cost. We believe that you know how to best support your patients in your own context. So we work with each of our clinician partners to identify how we can best work together. If interested, please reach out to us and we look forward to bringing our solution to your practice.
Thanks for joining the talk, guys. If you like to hear more about Flow, then you can just come and join our booth.
You can also reach out to partnership@flowneuroscience.com to continue our conversation. Thank you.
Science, Nikki and Daniel, welcome back. We're very sorry, earlier we had some technical issues, so we are back here with another Q&A live session. We're very sorry, earlier we had some technical issues, so we are back here with another Q&A live session. We're very sorry, earlier we had some technical issues, so we are back here with Right, we are ready to start the live Q&A. So Nikki and Daniel, if I could start talking about TMS. Let's speak about TMS. So you mentioned earlier about ECT, TMS being very, very expensive for healthcare systems, and this device is a lot cheaper. So how is this device actually better than ECT and TMS aside from the costs?
It's like, excuse me. So, sorry about that. Just had a very strange echo in the room. So the TMS device would do magnetic stimulation. Excuse me. And this is current. So it's similar in efficacy. You have to go up. Sorry about that. So TMS would be magnetic stimulation, and this is current, similar efficacy, but a lot safer. So TMS would be, for example, if you stimulated the wrong position on the head, you could potentially stop the breathing mechanism. But with TDCS, it's a lot more. You don't have this where you can get the neurons to actually fire if they don't want to fire. So with TDCS, it's possible to just push them in the right direction, but not to force them to activate. So it's a lot more safer. I'm sorry if that didn't answer your question. We had a very funny discussion here before we started. We're a very happy bunch of people.
No worries. Thank you for that. So in terms of providing support to patients, you mentioned about clinicians working with clinician partners. So in this way and in this product, you have an option to rent and demo the device.
Yeah.
If you'd speak more about that, please.
So we imagine that from the beginning that this is supposed to be a very accessible treatment, right? This is one of the most important features of it, I would say, besides the efficacy and so on, and few side effects. So we wanted to do something that could offer the patient the ability to test it in a very fast way. And therefore, we need to do some innovation when it comes to the business model also. So we started out by the patient buying it, and then it becomes quite expensive because it's a medical device and so on. But then we quickly introduced the rental model. So people can rent it, they can test for a month, 2 months, and then basically if they don't have the need for it anymore, they can just send the device back and you stop the kind of subscription or rental, and they can go on with their lives. And then if there is another episode, we know that many people have new episodes. So if they want to continue doing that, they just start up the rental model again and they will get a new device sent out to them. So we take care of all the problems connected to ordering pads and all of these things that needs to be done in order to use it if you buy it with the rental model.
Amazing. So in terms of statistics that you mentioned, 81% of the participants had a decrease in their depressive symptoms. That is a huge amount of decrease, and also 35% remission statistics. So in terms of this product and this device that you're offering, this is a really, really effective way to help treat with depression.
It is. We are surprised ourselves. Actually, I'm a clinical psychologist myself, and I've been meeting with many patients through the years, and it's very difficult to treat depression. And in this population that we're now measuring from, and those 35% that go into remission, that's
That's from mild, moderate, and severe depressed patients. And some of them are treatment resistant. As I mentioned in the previous talk, some of them are on benzodiazepines, which would decrease the efficacy of the treatments and so on. So these are real-world data, and 35% remission after only 6 weeks in that group. That's I mean, I'm from the company, of course. I started a company, so I'm a little bit biased, but I think those numbers are amazing.
Yeah, incredible. You mentioned also that there are little side effects.
Yeah, very, very few side effects with this method. There was one study, for example, published in 2016, looking at many different ways of measuring safety. For example, you look at biomarkers in the brain. You can see whether a neuron has been destroyed or so, and so on. And we see absolutely none of those markers, but we can also see that in over 33,000 sessions in that particular study, there were no serious adverse events whatsoever. So it's a very safe method. As I mentioned before, there are side effects like redness in the skin that goes away after you stop stimulating, and mild headaches and so on, but nothing serious, no.
I think, oh, I'm sorry.
No worries.
I think something which is very appealing to a clinician with this product is that you could tailor using this product with other methods for, let's say CBT therapy alongside this device. So in terms of that, could you just explain a bit further how this could be used in the same time as other treatments?
Yeah, I think we have kind of understood many of the clinicians that we talked to, and we understood it early on that there is no, at least right now, no one method that will solve all of the problems. So we need to combine treatments. And the clinicians that are doing a great job when it comes to talk therapies, even if it's psychodynamic therapy or it's CBT or some other kind of talk therapy, or if you're doing primarily antidepressants, they can be all combined with this in order to get this extra boost and extra knowledge, I would say also, because in the app we have collected a lot of information from the field, from the big studies showing that nutrition, for example, helps. If you change your eating habits or what you eat, we know that can decrease depression also. And we also include exercising, meditation, and basic knowledge about sleep in order to reduce depression also. So if you combine these things, we can see that we can treat a larger group of patients in a more effective way. So you could see this as an add-on treatment, but if patients don't want to try antidepressants and so on, they can also try this first and then move on to other treatments that have maybe larger consequences when it comes to side effects, but also economic, expensive treatments.
Yes, people do not like taking medication, so this is a very good alternative. So in terms of, let's say, patients themselves, have you experienced any apprehension or slight nervousness when using this device?
From the patients, you mean?
Yes, about wanting to use it?
Yeah, I would say that the field is a little bit divided. Some people see it as a kind of a sci-fi equipment, something that's very strange and different. But when they get the information, when they read up a little bit on the science, they understand that there are other people using it and that it's not painful in any way. Then most people are totally fine with it. So as long as we can talk to them and explain a little bit what we do and how it feels, then we haven't really seen that much of problems with talking to the patients. And the clinicians are even easier in a way, because they go directly to the science and they look at the articles that's been published and they realize that it actually works. It's solid science behind it.
Amazing. So let's say you are faced with clinicians here. What would you like to tell them? Lastly,
I would tell them to look into it. I mean, don't take my word for it. Look at the scientific articles. They're very well done. We have a good collaboration with many of them. East London was mentioned in the talk, but we also have one of the leaders in the field, Andre Bononi, who's a professor in Sao Paulo in Brazil, who's done many of the largest studies, and he's developed the protocols for the device that we are using. So look into that, and happy to answer any questions that you may have after having looked at those studies.
Okay, brilliant. Any last, let's say, research or statistics that you'd like to highlight?
I think we covered most of it, but no, nothing actually. Have a look at the talk again if you're interested.
Amazing. Thank you so much for coming on live again. Please visit the virtual stand. This is Flow Neuroscience, Daniel, Nikki. Thank you very much. Have a wonderful rest of the day.
Thank you. And Nikki says thank you also here.
Thank you.
Thank you.
To the audience, that was our last presentation. Thank you so much for coming and coming on board onto this demonstration stage. Please enjoy the rest of your time at Giant 2020. And if you have any further questions, comments, or would like to speak to any of the people who have demonstrated today, please do visit the virtual exhibition hall where they have virtual stands, and go to them directly where you can have one-to-one conversations. Thank you very much. Have a lovely day.
Right, how do I choose where the sound comes out of then? Can you hear me all right, Adam? Options, default mic.
I can't hear you, James. Yeah.
Can you hear now? Can you hear me now? Hello, hello, hello. Good. Hello, hello, hello. I'll try again. Can you hear me now, Adam?
I can hear you now. Can you hear me?
Yes, I can.
Perfect.
Right, hang on 2 seconds. Let me see if I can get the mic on. Microphone options, default, Zoom. Hang on 2 seconds. Let's try and get this up. Audio interface, stereo mix, PC Mac. Internal mic, Zoom H6. I can hear. Can you hear me now, Adam?
I can, yeah.
Is that better?
It is better. Yeah, better quality.
Right, great.
How's the quality of mine coming through?
Yeah, perfect. I definitely need to just get an easier USB microphone rather than this flipping Fandango H6. It's a great bit of kit, but completely unnecessary for this. Right, okay. So I believe we are waiting now for 444. What's his name? Dimitro. Oh no, so he's here, isn't he? Dimitro's here. Are you there, Dimitro? Can you hear us? He might still be on the other seminar talk, he said, to be fair.
Okay. Well, we're ready and waiting when they are.
Yeah.
Do you know how to stream or share your screen? Do you know how to do that?
Yeah, they showed me that yesterday. So let me just double check I can do that in the back end here now. So if I go into relations group. Let me turn everything else off just in case. Turn that off. Turn that down. Let's turn that off. Off, that off, that off. Right. Application window. Share. Full screen. Are you seeing that now?
I can, yeah.
Great stuff. Okay. Just the only slight issue with that is that, and is it flicking through?
It is, yeah. It's a little bit pixelated in some areas, but that might just be because it's reduced size.
Okay. Yeah, I now can't see. If I take it off there, actually, can you still see it?
I can still see it, yeah.
Oh, but it's showing you the whole...
Yeah, you're seeing the browser, so it's not on slideshow mode.
Okay. So if I go back to here, now I'm presuming it's just taking you to the whole thing again.
Yeah.
Right, it doesn't allow me to see the rest of the screen. That's a bit annoying. What about now?
That's fine, yeah.
Oh, but then I can't actually click through, can I? No. Right, okay. So I'm going to have to share the screen like that, but then I can't see anything else that's going on, which is fine. It might just be that we'll get Dimitri to show us how to do, how to see where comments are, or where to see where comments are. So you might have to give me a nudge if you see anything, because I won't be able to see the screen at all.
That's right. Yeah, and then I can always respond to any questions or anything, because unless it changes when we actually go from the lobby area to the main presentation, but if it's in this format, then I can respond to questions or chats or...
Okay, great. You can't see me now, can you? You can just see the slides.
Have you got your camera switched off?
No, it's on.
Okay, so I can just see JB. So I can see your initials, but I can't see your face.
But you can still see the preview of the slides?
Yeah.
Okay, cool.
So it may be that if the audience is seeing what I'm seeing, then they won't actually be able to see us. They're only to hear us.
Gotcha. Okay.
So in which case it might make sense if that is the case, and you can check with Dimitri. It might be if we start without sharing the screen, we just talk a little bit about our background and then start sharing the slides. So that
great stuff. Let me just check it's in the right place. Application window. Yeah, okay, cool. We can do that. All right, we'll double check with him. That's fine. I'm getting a WhatsApp call now. Hello, James speaking. Hello, is that Dimitri? Hello, mate. How are you? Yeah, good. Yeah, good. Thank you. Right, Adam, I think we're good to go. Are you good to go?
Oh, indeed, I'm all ready.
Cool. And is somebody going to give us an introduction, Dimitri? Is that how it's going to work? Okay, so is somebody else going to speak before we start speaking, or are we just going to literally go live? Oh, okay, cool. No worries at all. Hang on, let me get rid of my chewing gum then. Yeah, go for it. We're ready to go then. Thank you. So good afternoon, everybody, and welcome to this keynote presentation by myself, James Burtt, and also my colleague Adam Cox, live from the Relations Group. Thank you very much for being here. We appreciate your time. Thank you for jumping on and joining us here at the Giant Health Summit. I know last year the guys had their conference at, I think it was Stamford Bridge, the Chelsea Football Club. So it's a bit disappointing that we can't run onto stage on the pitch, which I imagined what was going to happen, and some fireworks and stuff going off. But hey, it is what it is. 2020 has been what it's been. We will make do with what we've got. I believe we are now live streaming to the Giant Health community, which I know is up to 177,000. I don't know, might be 177,000 people online, but I like to imagine that maybe there are. But appreciate all of you guys who are within the Giant Health community for taking the time to be here today. As I mentioned, my name is James Burtt, and I am one of the team at the Relations Group. We're going to be talking to you guys today about how to explode your brand utilizing the power of audio. Now, you might be thinking, well, hang on a second, this is a health tech innovation summit. How does this relate? Well, basically, podcasting is one of the biggest platforms right now for creating, generating, and becoming the authoritative voice leader within your marketplace. So in terms of how important podcasting is as a medium in general, it's getting more and more important, but especially in terms of certain market sectors such as healthcare technology, it's mega important to be that authoritative voice, and podcasting can give you that format. Myself and Adam today, we're going to run through the talk in kind of two different sections. We're going to look at what a brand is first and foremost, because that's the most important thing. You know, what is a brand and how can you then explode that brand utilizing the power of a podcast? And then we'll actually talk you through some of the tactical and practical elements of podcasting as well. So that's a little bit from me. We're going to go to some slides very shortly, but I just thought I'd leave you for a couple of minutes to be introduced to my colleague, Adam Cox. Adam, if you'd like to explain to everyone who you are and what we're here to do today.
Hi, my name's Adam Cox. I'm Managing Director of the Relations Group. The Relations Group is a cluster of media relations specialists, but also a content creation arm. And one of the areas of content that we create are, of course, podcasts. So alongside James, we've helped launch over about 129, 130 podcasts for brands to enable them to get all the benefits that you're about to hear in this presentation. My background is that not only did I found the Relations Group, but I'm a podcaster myself. I have 2 podcasts that are regularly featured in the iTunes chart. So we'll be talking about how content can actually leverage your brand, access new audiences, and lots of other benefits that you might not expect from podcasts.
Absolutely. So I'm going to jump on now and share some slides with you guys, which has got some practical and tactical information about, as I mentioned, branding, the elements of branding to start with, what a brand is. And we'll talk again a little bit about sort of the sort of work that we've done with brands before previously. I won't be able to see the screen. So if you've got any questions or queries, we're very much wanting this to be a very sort of engaged back and forth conversation. So if you guys have got questions and queries, I believe there's a chat box and there's also a questions tab. But I believe if you click the chat box, you can ask your questions in real time, and Adam will jump in as we're giving the presentation and we'll share some of those questions that you guys have got. So as I say, if you've got any questions or queries, stick them into the chat box and we'll cover them off either in real time or as close to real time as possible. We're also at the end of the session as well, we will be sticking around to be doing up to 30 minutes of Q&A as well. So if you guys have got any questions or queries and you want to hold them back till the end, stick them on a pen and paper, give them us all at the end and we'll cover them off one by one. But we want to make sure that today is as practical, tactical, tangible and usable for you guys as possible, with the theory being that by the end of this presentation, you should have a knowledge on podcasting that will put you in the top 1% of podcast experts in the world. Will this give you enough to start a podcast? Well, in theory, it actually could. Will you? Probably not, but you'll get the idea of what goes into the making of a podcast. So let's just jump into some of the slides now. I'll start to walk you through some of these practical and tactical elements of how to explode your brand using podcasting. So you guys might not be aware of who we are, but chances are you've already heard our work. So we were actually the team behind the Giant Thinking podcast, which was created by Barry Schreier, the founder of the Giant Health event, and some of his senior team. So we actually created the podcast back in, God, must have been in the summertime now. Originally, I think the concept was going to be, face-to-face interviews in London studios, which is all very nice. But due to COVID lockdown, etc., we had to sort of work within the parameters that we had. So we ended up actually creating a mini studio setup for Barry which he just ran out of his home up in Oxford, and we just connected virtually to all of the guests during the series, and we had an 8-episode series where we could share the leading thoughts of health tech innovation. The podcast reached dozens of countries, thousands of downloads, so chances are you guys might well have been one of those people who listened to the podcast. If you did, thanks very much for downloading it, and we'll talk to you a little bit more about how that all came about, as well as obviously massive credibility for the Giants Health brand in terms of having their own podcast, which, as I say, was listed as multiple top 50 positions in the iTunes top charts, which is fantastic. It puts it in the top sort of 5% of podcasts globally. We also were able to have some very, very esteemed guests on the show. So Professor Shafi Ahmed, Dr. Abdullah Albietti, Peter Ward from Humanity, who I believe is talking on this stage after us this afternoon. So we like to think of ourselves as Peter's warm-up man, which is no bad thing, given what Peter's done. Dr. Ali Parser from Babylon, Neil Daly was doing some incredible stuff from Skin Analytics, Dr. Ben from Sierra, a fantastically beautiful, warm human being who's on a mission to just change the healthcare sector, which is very exciting. And then obviously Samir as well from Zillico. Now, why do I show you, these names and the esteemed guests that we had on? Well, it's to show that one of the biggest things about podcasting is to extend your network or to increase the depth of your network. So obviously, Professor Shafi is very aligned with what Giant's all about anyway. But Dr. Abdullah, Peter, Dr. Ali, Neil, Dr. Ben and Samir, these are people who are in and around the ecosystem of the Giant Health sector. But what we were able to do with that podcast was to really, really deepen and strengthen that relationship. I don't think it's any coincidence that all of the people that we spoke to on the podcast are going to be leading speakers over the conference over the next couple of days. So we touched on a bit about who we are a minute ago, but just to give you guys sort of an understanding, because I think it's really easy to be invited to seminars, sessions, Zoom calls, etc. And you can hear some information from the keynote speakers, etc. But I think it's really important to understand the credibility of behind the people who are giving you guys the information. So I'm James Burtt, as I mentioned before at the beginning. I help business owners and brands and experts to stand out in a noisy marketplace through the work that I do with the Relations Group. We help brands and companies to build audiences, raise their profile, and attract new clients by harnessing the power of audio to scale their business. We've worked as the Relations Group. We've worked with the likes of BMW, Nando's, Thomas Cook, Nissan, Xbox, Stella Artois, Tailors of Harrogate. We've worked with healthcare providers. We've worked with NGOs. We've worked with not-for-profits. We've worked with some of the biggest conglomerate brands around the world, providing not only podcast services but also broader broadcast PR and communication services as well. So we're one of the top leading specialist agencies in communications for the broadcast PR space. And as Adam mentioned, fast becoming Europe's leading experts in podcast launches. We've done 100 and I like the fact that Adam said around 129. No, it's exactly 129. It's around 129 launches that we've done to date. We've done 2 last week for various brands and clients. And as I say, we've got a very fast growing reputation, which we're very, very proud of. And we're very, very territorial over, because it's been hard fought to gain it. But we have got 85 to 90% of the clients that we work with into the iTunes top charts. So not only have we launched these podcasts, but we've launched them successfully, which I think is really important to understand. Because again, there's lots of seminars out there. There's lots of talks. There's lots of, you can go and get some information about podcasting on Udemy if you wanted to for a $5. But what we're going to be sharing with you guys today is fundamentally the stuff that really, really works in the real world. Not only does it really work in terms of from a sort of an art perspective of creating some beautiful content, but these are podcasts and created branded audio creations that drive a bottom line revenue outcome. One of our things, we're not artistic, whilst we are practitioners of our craft. And yes, we are podcast and broadcast geeks, and we love production, and we have got some fancy audio engineers, etc., etc. At our core, we are creating content that drives a business outcome. I did a talk a couple of weeks ago for the Great British Entrepreneur Awards. And they said to me, the first question that they asked me, it was a seminar they were doing alongside BT. They said, what's the business case for doing a podcast? I said, well, fundamentally, the audience is exploding right now. And if you haven't got your own branded audio podcast chances are that your competitors will. So we always come at the content creation methodology from a place of wanting it to have a genuine addition to the bottom line, have an outcome driven purpose rather than just being sort of art for art's sake. So, very much the case with when we're talking to Barry and the guys at the Giant brand before we launched their podcast, we were to understand what those outcomes actually were, which was to raise awareness of the event, which has obviously worked because there's a lot of people who are here today, or over the next couple of days, which is fantastic, and to strengthen those relationships with their experts and to make them a more deeper member of the community. I think we can safely say that worked as well. Adam also he sort of alluded to the fact that he's a podcaster, as am I. Adam's currently a podcaster who's getting over 1,000 downloads a day from one of his podcasts. So he's not a small fish in the game. He's big in the game. You're talking alongside a podcast celebrity. I'm sure I can't see his face. I'm sure he's squirming at the mention of him being a podcast celebrity. But also Adam, as well as founding the Relations Group 20 odd years ago, and going from a place of being a one-man band to having a team of 30, 40 people, and becoming a multi-million-pound business. He's also a qualified clinical hypnotherapist, I believe is the right term. So he comes at branding and marketing from a standpoint of having a real deep understanding of the psychology of what makes brands work, which is what we're going to talk about in part today as well. So this is not top line thinking that's just scratching the surface. This stuff and the tactics that we deploy for our clients are based on the psychological principles of what it takes to actually build a brand. Adam, is there anything else to add before we crack on?
I don't think so. I think, I wasn't squirming. I was actually quite pleased for the acclaim there, James, on the 1,000 downloads a day. My passion, and really it was James that kind of got me into podcasting, because I was already a radio presenter, and it just seemed very obvious to kind of take that content and the idea of audio content and leverage podcasts. We've had a message from Barry in the chat area, just thanking in particular you, James, for all the work that you did on Series 1 for Giant Thinking. It's worth mentioning for anyone listening right now that if on the left-hand side of the actual main menu on the event, if you click more, you can actually see the podcast zone, where you can actually hear all 8 episodes of Giant Thinking with the kind of guests that James has mentioned there. So hopefully that gives you a bit of reassurance and credentials that we know what we're doing, because we've actually created the podcast alongside Barry as host, and James will talk a bit more about the formats and the layout later in this presentation. But yeah, thank you, Barry, for acknowledging what we've done for Giant Thinking. And my kind of real passion is helping brands to communicate their message in a way that changes how people think. So obviously the concept of Giant Thinking, which is the podcast for Giant Health, really delivered on that.
Absolutely. Let's get into some of the tactics then. So as I say, we're going to break down this talk into 2 areas. What we don't want this to be, I understand that there's going to be people at different levels of the sort of the business journey, but I know there are a number of students, there are a number of startup founders who are within this community as well. So I think it's useful to, as well as, massive billion-dollar companies, I think it's useful to touch on branding. Again, if you already have a massive, big, well-established brand, just listen to this information with open ears. If that's the right phrase, it's probably not. I'm not going to teach Granny how to suck eggs here. There's probably people who've built very, very successful businesses and brands already. But again, it's useful we're looking at this as an overall brand exercise, but also the elements of branding that we'll talk about fit in really nicely. We're going to launch a new podcast. So when you think of a brand, you might think of this, or you might think of this, or you might think of this. You might even, chances are, you may even be watching this presentation on this device. You may even be thinking of that. That's what you might think of as a brand, one of those elements. But a brand isn't all of these. But a brand isn't any of those things. It's not surprising there's a lack of clarity, because even the dictionary definition of what a brand is and what a brand isn't is very much outdated. So I checked this literally last week. And if you put in brand meaning into Google, the dictionary definition, according to Google, is a type of product manufactured by a particular company under a particular name. Or point 2, it's an identifying mark burned on livestock. and that's kind of where the ethos or the messaging behind branding, I guess, originally comes from. It was about, you know, putting your identifying mark on a thing which you have ownership to. A brand isn't any of those things these days. That definition, you know, you know, I think it probably shows you the age of that when this was sort of given as a dictionary definition by the fact that the example they give is a brand, a new brand of soap powder. I haven't heard anything to refer to as soap powder since the 40s, to be fair. But branding and brands have moved on since this dictionary definition was created. I'm about to give you the only definition of branding that you will ever need. I haven't frozen on the screen, by the way. I'm building the tension in case you're wondering. Your brand is your reputation. That's it. Nothing more, nothing less. And I say that half facetiously because obviously there's nothing more. Whilst it's only your reputation, it's your reputation. In the world of business, in branding, there is nothing more important than your reputation. That goes for brands and businesses and organizations and charities and companies across the board. But I would profess to say that, especially in the health tech innovation space, that's probably as applicable, if not even more applicable than sort of generalized businesses. This brand being your reputation, I think, is super important to understand. Here's the thing, though. You don't have control of what a brand is because the brand only exists in the mind of your consumer. Now, I know we've got a lot of very intelligent people here, but even still, a few you might be scratching your heads right now going, hang on a second. So it's not the product or service, it's not the logo. It's now, I can't control it. What's this guy talking about? So let me give you an example. The brand exists in the mind of the consumer. So, for example, a minute ago, I showed you a bottle of Coca-Cola, and I did that intentionally because that imagery will have made you think something, and what you thought is what the brand means to you in your mind. So when I see Coca-Cola, I think, rightly or wrongly, probably wrongly, I think best ice cold drink to have on a hot summer's day. I'm sorry, I know we're at a health event, and I know that sugar and processed sugar is fundamentally probably one of the biggest killers on our planet, but I love Coca-Cola. I love original full-fat Coca-Cola, but only on a hot summer's day. Rest assured, especially if you're in the dental world, I don't drink it all the time, but I love it. So when I see a Coca-Cola, especially the glass bottle, you know, the ones you get from bars that you don't really buy in the supermarkets, that's what I think of. So I think of best ice cold, lovely, beautiful, refreshing drink on a hot summer's day. Equally, if you're in the health tech innovation space or you're a diabetic, a bottle of Coca-Cola represents sugary death. Now, I know I've got a little bit dark there straight away, but that's the reality of it. You know, what I think of as Coca-Cola and what you think of as Coca-Cola, both of those things are correct. The brand exists only in the mind of the consumers. So it's normally, by the way, the first thing that you think about. A lot of people think that a brand is, you know, like the swirly Coca-Cola writing, or on a like a trainer, it'd be the word Nike, or it might even be the tick, and the tick has even got its own name, which is called the swoosh. But even that's not the brand. The brand is what you think or what the consumer thinks in their mind. That's what a brand actually is. Think of your brand like a story. So you can't actually, and go back to the point I made a minute ago, you can't actually control what the reader pictures as they read. You can only give them the information, and then they have to utilize their own imagination, and then they fill in the gaps, if that makes sense. That's what you're doing with a brand. So let's give you a practical example. It sounds a bit of a weird one, but why was 50 Shades of Grey such a smash hit? It definitely wasn't because of its literary brilliance. It was because it enabled people, a whole section in the market who've been maybe needing some form of emotional stimulation. It allowed them to utilize their mind to create pictures in their mind of what it stands for. That's why the film is never as good as the book, because ultimately the film creators, despite how incredible they make it, with the exception of Harry Potter, which apparently is better than the book or as good as the book in the film terms, they're never going to make it as exciting as you make it in your mind, or as that person makes in their mind. So that's what you're doing with your brand. You're telling the story, but you can't entirely control what the reader pictures. But you can curate the narrative. So you can't control what goes into people's brains, but you can curate the narrative and give yourself, or give your brand, or give your company or organization, your charity, your NGO, whatever it may be, the best opportunity for people to receive the information that you want to give them in the right way to curate that narrative. That's building a brand. By the way, you are already building a brand. You might not consciously be aware of that fact. So for example, let's say you're a startup and you're on Instagram, and you're using Insta stories to document the birth of your exciting new health tech innovation startup. Whilst you might think, well, I'm just in the pre-seed fund, phase of building this out, or I'm just getting started, or we're just getting moving with it all. We are, we've just put together an MVP, a minimal viable product before we take it to market. We're just in the testing phase. Anything that you put out is still building your brand. If I follow you on Instagram and I'm watching your stories and you're going for a run and you're saying, oh, I always like to go for a run before a busy day. We've got loads of testing for our new health tech innovation brand that's coming up today, but I'm just got to get out of the house, get some cardio done in the morning. I am the message that I preach, health over, health is wealth, or whatever it may be. That's your brand. I'm buying into you before I'm buying from you. So everything you put out is adding or potentially taking away from the brand that you're trying to create. So again, just to touch on that fact, you are already building a brand. You might just not consciously be aware of that fact. And by the way, all kind of like posting, whether consciously or subconsciously, adds to that brand. So for example, if you are a leading investor in the health tech space, but on a Sunday you put out that you were in the park having ice cream with your kids, I don't know why you'd have done that on Sunday because it was freezing cold, but if you were, then that also adds to your brand. Oh, he's a family man. Oh, he spends time with his kid. That adds to your brand. You might not have consciously done it. Conversely, maybe you did consciously do it, but that adds to your brand. So if brand is just reputation, and when I say just reputation, I've already mentioned how important the reputation part of it is, then what is the first step? And again, I'm being very mindful of, I don't want to teach granny to suck eggs here. I appreciate there might be very big, well-established businesses and brands that are already, that are watching this presentation. But if you are just starting out, it's really, really, or if you're launching a new product even, it's useful to go for this basic branding exercise to make sure you're still aligned with the overall mission and vision of what you set out to do. So if brand is just reputation, what's the first step? Sounds overly simple, but the first step is just simply deciding what you want that reputation to be. What do you want your reputation to be? What do you want people to say about you when you're not in the room? What do you want people to say about you behind your back? Again, you can't control the pictures in the mind of the consumer, but you can definitely curate the narrative. Who are you? If you're deciding what you want that reputation to be, who are you? What do you stand for? Really important in the health tech space. What do you stand against? Also really important in the health tech space. Had some fascinating conversations where we were producing the Giant Thinking podcast, when we were talking to, who was it? It was Dr. Ben from Sarah, or Sarah. I always got the pronunciation of it wrong. He's very much, they stand against people being left in their homes. They stand against people being in hospitals where they don't need to be because there's not that backup care in the community. That's what they stand against. They stand for becoming part of the family. They stand for being an extension of the family in the community. They stand against, as I say, beds being wasted in hospitals because they just haven't got the capability to put people back into the community and look after them there. I think they very much stand against, healthcare being, it's almost like pain care or ill care, sick care. It's not health care. You're only going to practitioners, your health practitioners, especially in the UK, you're only going to those people at a time of crisis or chaos. You're not going to them to stay healthy. You're going to them to help them stop being sick. So that's important to understand what you stand for and what you stand against. Who do you help? Again, mega important in the health tech space. Who is it exactly that you're going to help? We take all of our clients through something that we call the brand overview questionnaire. So I thought it'd be useful to run through this for you guys. So the brand overview questionnaire is going to look at the basics of building out your brand and what it stands for. And by the way, I learned the most about this process from working with Nando's. Now, this might sound like a strange analogy, but when Nando's came to the UK for the first time, you could obviously only get their sauces in Nando's restaurants. And about, it must have been 12 or 13 years ago now, I'm showing my age, myself and Adam in the relations group team worked with Nando's to help bring those sauces into retail. And this brand overview that we've created has been based on a lot of the stuff that we did for that process of taking a very well-established brand and put it into a new sector. So the stuff that we're going to teach you here, again, it's not just sort of theoretical, it's very much been practical with some of the biggest brands on the planet. So core values, this is point number one. Think of this as your North Star. And again, if you are a startup, doesn't matter whether you're in the health tech space or any other space for that matter, these are the fundamentals of building a brand that you need to understand to get started. So core values, think of this like your North Star. Keeps you on the straight and narrow. What do you really stand for? Who are you? Like what gets you out of bed? What's the core values? I mentioned a minute ago, Sarah, Dr. Ben's company. You know Dr. Ben anyway. You know, what are the core values of that? Helping people in their homes, keeping people in their homes. That's what their values. They want to keep people in their homes for as long as possible, to give them the life that they want to lead in their homes, to give them genuine world-class healthcare in their homes. That's their values. That's their North Star. That's their kind of like the end point. That's kind of what they're aligned with. That's what they want to do. Think of it like your North Star. I like that analogy. USPs, this is really important. What's the unique selling point of your brand? Now, when we do this exercise, in a lot of instances, we'll hear clients and customers telling us SPs. That's our selling points, not USPs, which is the unique selling points or unique selling proposition. What's the unique part of what you do? And again, when we ask people this question, quite often it's like, oh, well, you know, we really care. That's not unique. It's nice, good selling point, but it's not a unique selling point. No one's going to buy into that above and beyond anything else. Oh, we deliver faster than anyone else. So does everybody else. Everyone says they deliver. Oh, we look after customers better. So does everybody. So you've got to look at what are the USPs, the genuinely unique parts of those selling points. Mission statement. I love this. Now, I often encourage clients to have an internal and an external mission statement. So the mission statement is a line or a sentence or maybe even a paragraph or a couple of paragraphs about what is your mission? What are you here to do? We talked about a minute ago, you know, that North Star from your core values. You could kind of combine it all together. What is it that you're here to do? In a sentence, what are you trying to do? Why are you trying to disrupt the health space? What's your mission for it? A great friend of mine, a very successful entrepreneur called James Sinclair, says, start with the end in mind. Build it as if you're going to try and sell it, even if you've got no intention to. So what's the mission statement? The day that you hand the keys over, what have you done? What impact have you had? What mission have you been on? What difference have you made? And I think it's really important to have an external mission statement. So what you're telling, you know, the marketplace and clients and customers and patients, that's really important. But it's also internally, it's really important to have a mission statement. It's one thing to say, you know, this is what we're going to do. It's another thing to almost say to the team, we're going to do it, but this is how we're going to do it via an internal mission statement. Value proposition. So why would I buy from you as opposed to somebody else? We talked about USPs a minute ago, and a USP and a value proposition is kind of similar, but it's sometimes useful to look at it in a slightly different way because it might give you some different outcomes or some different answers, especially if you're sort of brainstorming this stuff at the start of your sort of brand building journey. What's the value proposition? Why would I buy from you as opposed to somebody else? What do I get more from you? Why are you better? If there's another competitor, like-for-like competitor in the marketplace, why am I giving you my cash? Custom, trust, whatever it may be. Ideal listener profile. Obviously, from the audio world that we're in, for me and Adam, we're always talking about ideal listeners. But you could look at, you know, ideal listener could also be ideal customer, ideal client, ideal patient profile. This was really the one that we learned, that especially I learned from Nando's back in the day. I remember sitting in this meeting, and I was probably 23, 24 at that point. Thought I knew it all. Turns out I didn't know it all, but I thought I knew it all. So I was sitting in there. There's a digital agency, an outdoor agency, an ads agency, a buying agency, straightforward PR agency, digital. There's all these different agencies, and then there's this brand agency. Then there's another one who'd built an avatar. And probably not an avatar in the way that you guys are thinking. It wasn't like sort of AI-based technology. But they created this persona of a person. I think it was Julie, and she was 34. So they came up with this, you know, this is our ideal profile, this avatar. And they made up this whole story about her. They had a picture of her. They had information about where she shopped, where she lived, how she interacted. You know, so Julie's 34. She shops in Sainsbury's, but she really aspires to shop in Waitrose. She buys best of or Taste the Difference when she can, but then she'll buy much cheaper products, day-to-day items such as milk, to make up for the cost of the more luxury items. She got 2 children in public school. But she would aspire to put one of them into private school because they need more assistance with their learning, blah, blah. They made up this whole person, basically. And I was sitting there at 23, 24 going, what a load of absolute nonsense. But the more I looked at it, the more I thought, actually, this is really, really, really genuinely quite clever. Because if you understand who you were after, if you're only after one person, so not looking at the broader target market, not looking at the sort of the broader marketplace for it. In this instance, just at this point of the brand building process, who would you attract if you could only get one person? That exact one person. The reason why you want to know that is because then you can make sure your marketing messaging hits exactly that one person. So rather than go, right, is this going to reach our audience? You can go, right, is that going to hit Julie? Is that message going to hit Julie? Is that press release going to hit Julie? Is that radio advert going to hit Julie? Is that podcast going to hit Julie? Is that leaflet going to hit Julie? Is that email campaign going to hit Julie? Is that ad going to hit Julie? If I retarget Julie, what's she going to think about it? So it's really, really important to understand who you are speaking to and how you'd speak to them if you are only after one absolutely ideal client, customer, or patient. Stakeholders. So this is also really important. Obviously, you need to make sure in the majority of cases that your communication is being best understood by your end consumer, the end client, the end customer, the end patient, whoever it may be in the instance of your business. But you also need to be mindful of how communication is understood and portrayed by stakeholders. So, for example, let's say you've got a, in the instance of providing care in the home, your stakeholder, the client, is the person in their home. That's the customer. That's the person paying you for your service. However, you've got to be very, very mindful of, their kids, of their grandchildren, of their neighbours. So you need to be, mindful of how your messaging is communicated to that group of people. You've also got to be, mindful of how your investors, your bankers, your staff hear your message as well. So there's lots of stakeholders as well as your sort of end consumer or client that you've got to be mindful of. Now, this doesn't mean you have to be different things for different people. Absolutely not. But it does mean that you don't have to, as I say, you don't have to change the communication depending on who you're talking to, but you do just have to be mindful of it, just to make sure that it's reaching the right people. For example, if you were putting out press releases about, you've been taken on by, a new district of the NHS, what you wouldn't want to be saying, behind the scenes, you might be saying, well, they've done a terrible job of it and we're going to improve it, blah, blah, blah. But you maybe wouldn't want to communicate that, in forward-facing press releases or something like that. So you just need to be mindful of all of the stakeholders who are around you and your business. Then you need to have a target market. So we talked a minute ago about Julie, this ideal avatar, knowing exactly who you're speaking to if you're speaking to that one person. But obviously, in the majority of businesses, you can't just speak to one person. You need to more broadly speak to a marketplace of people who look like that. So, for example, with Julie, let's say she's 34, so she's between 30 and 44. She's female. She lives in the Southeast. She works in the city. She's a member of David Lloyd Gyms. She watches Joe Wicks on social media, blah, blah, blah. You make this sort of assumption of the target market based on that ideal profile. And that means for marketing purposes, you can target more of that broader reach of people. Once you've done all that, once my slides catch up with me, if you think you know all this stuff already, then you can do my amazingly titled Who, What, Where, How, Who, What challenge. Obviously, it's not actually amazingly titled. That is semi self-effacing. But hopefully, this is useful for you guys. In one sentence, can you summarize who you are, what you offer, where you offer it, how you provide your product or service, who are your clients right now, and what are you famous for? If you can answer all that stuff, that's great, because that exercise makes sure that you're on the right path. So it's super important to get that stuff correct. But what a lot of people misunderstand is that communication, the value in communication is how it's received by the person that you're trying to communicate with. So, for example, you might have a fantastic website, you might have a great press release, you might have an amazing PR department, you might be spending hundreds of thousands of pounds a month on Facebook ads. Oh, it's brilliant. All of our stuff looks fantastic. It looks really polished and professional, etc. But the only value in that communication is if it's being received by the ideal person in the right way. Now, if you're saying a message and the person doesn't get it, whose fault is that? Is it yours in communicating it to them, or is it their fault in not understanding it in the right way? Fundamentally, it doesn't matter who's at quote unquote fault. The important part is to get it right so that the communication is being received in the right way. So it's great if you can go through that exercise and do the who, what, why, how, what challenge. Great. If you want to take it one step deeper, double check your brand message is being received properly. Get a client to do it for you. Obviously, you want it to be a client who knows you relatively well, but put out a little survey to them. Who do you think we are? What do you think we do? Where do you think we offer it? Who are we? Because again, the value is in communication, is in how it's received by that end consumer, that end person. So once you've crafted a brand, how do you spread the word? One of the things that we get all the time when clients come to us at the Relations Group, but as I say, we're working with some of the biggest brands on the planet, and we're very humble, is that the right word? Grateful? Proud. Let's go with proud. We're very proud to work with those brands and businesses. We're also very proud because they come to us for a consultative overview. So they know us well enough to know that we will tell them what they need to hear, not necessarily what they want to hear. So, for example, our background is, for the last 20 years, we've been helping people get editorial coverage in places that have been traditionally very, very hard to get your communication heard. So the likes of Radio 4, Radio 2, XFM, Capital FM has been our background in the radio space. We place CEOs, marketeers, brand directors onto TV programs. We get people that blogs and online traffic via articles, all through editorial elements of what we do as a company. And now we do the same thing via podcasting as well. But what we won't do is just allow our brand to release a podcast that's just about their brand for the sake of it being about their brand. There has to be some form of value exchange with the listening audience, or else ultimately it's never going to get any traction. So it's really important that once you've got this brand overview in your head, how are you going to spread the word? Social media, obviously mega important. Social media, I like to break down into two elements as well. There's organic and then there's paid for. So social media, we talked about a minute ago, you're either consciously or subconsciously building a brand with every single post that you put out. If you're on LinkedIn, TikTok, Twitter, Facebook, YouTube, what else is there? I'm not that down with the kids. I'm sure there's some more. Did I say TikTok? Yeah, probably did. Or whatever the next one's going to be in the next few months. You could be on those platforms and still communicating your brand message organically by yourself. I mentioned earlier, if you are the CEO of a brand, then people are looking to you as a representation of that brand. So if you're out and about with your kids on the weekend, that says something about your brand. If you go running every day, you train really hard, that says something about you and your brand. So again, you've got to be mindful of what that thing is saying to people. To start with, one of the best things for those of you who are starting businesses right now, I cannot overemphasize the power of this enough. Document the journey that you're on. Too many people show the shiny end result. They don't necessarily show the journey or what's gone into making that journey happen, if that makes sense. When you float on the stock exchange, you get that $1 billion valuation. That's great. And a lot of people are going to be interested in you. A lot of people are going to want to be your pal. But even more people would buy into you if you've taken them on the journey. If you'd have shown them the days when you'd done it, on your mum and dad's kitchen table, then you moved into your first little flat and you took over the spare room, and then you moved into your first, WeWork office, and then you took on your first member of staff. Then you lost your first member of staff. Then you took on your first non-exec board director, which cost you a bloody fortune. You didn't know it was going to cost you money. Take people on that journey. The highs, the lows, the wins, the learnings, the lessons, the losses. Show them all that stuff. I've on a micro level, I've done it for several businesses that I've been involved in. I've gone from a standing start to 7 figures in 18 months. We built those brands via organic social media. It's not for everybody, by the way. It's not for everybody, but it's a very good way of documenting the journey and ultimately creating brand awareness, which is what a lot of this sort of talk is about. Obviously, once you're sort of a bit more established and you've got a bit more brand positioning within the marketplace, paid for ads, amazingly valuable. Again, this is not going to be a social media talk because there'd be a million people who could talk about it better than I could. But in this day and age, you could literally target anyone, anywhere, with anything with laser accuracy. Let's not get into the debate about the social dilemma documentary. Incredible though, isn't it? But you can pretty much reach anybody, anywhere with laser focused accuracy with paid for advertising, which again goes back to the point of why you've got to make sure that you've got your brand proposition so solid and watertight, the foundation's built before you start to do that external outreach. Because with paid for ads, you can get a lot of traffic very, very quickly. So you've got to be making sure you get the right traffic, and that when you get the right traffic, they're hearing the right message from you. Adam mentioned earlier, one of his core passions is to help brands communicate those core messages. It's so important by going through these branding exercises to know what that core message is before you start to spend on attracting clients and customers. See lots of companies doing this. Especially when people come to us from a podcasting standpoint, they're already doing lots of other stuff as well. So we have to look at, okay, well, is this going to line up? Does this correlate? How is this going to fall into the overall marketing strategy? But pay for ads, super powerful when you've got the right message and you know exactly the right market you're trying to attract with it. Website, still mega important. Again, a lot of you are probably like, it's the most basic talk of all time. And maybe it is, but sometimes you need to hear the basics again, because as things grow and progress, the basics don't become so basic. But website, make sure you have a place where you control the platform, where you control the flow of data. Data is the new gold. Make sure you're getting people's email addresses. You're building that awareness. I had it recently, my personal Facebook account got hacked and then it got shut down and I could not get it back. And, for 4 years worth of launching podcasts, I've been sharing it out on social media and stupidly and never I'll put it onto a hard drive and blah, blah, blah. Because every year it comes around, I'll just share it again. So then I've got this sort of like built-in, when you've done 129 show launches, you've got a built-in calendar almost of great content, which social media is your new social proof. You could just reshare that from the year before and the year before and the year before. But that platform went, and so did all of my social proof. Luckily, as a company, obviously, we've got more social proof than just mine that we can just lean on. But ultimately, if whether you're on YouTube, TikTok, Facebook, whatever it may be, you're always playing on somebody else's playground, and at any point they can pick up their ball and go home. So make sure you've got your own website, even if people are telling you, websites aren't important anymore. Put it on Discord. Just have a Slack thing. Blah blah blah. Yeah, don't get me wrong. Again, I'm not going to get into that debate with people because there's probably a lot of people who understand more than me. But just owning that data, getting them on a mailing list still works really well. Mailing lists are so powerful. And then offline traditional media, still mega powerful. So before we go into the talk about, the tactical, practical elements of podcasting, offline media still works. We onboarded a client a couple of weeks ago for a podcast. And it was really interesting because they've got such a strong mission and brand, which we talked about earlier, and such an integral internal mission statement that they wanted to onboard us. They wanted to indoctrinate us into their brand rather than the other way around. They are our client, but they brought us on board to their team. They've got a cool thing. They call it like Team Purple, or their internal marketing department's called Team Purple. And they wanted to make sure that we were aligned with Team Purple. So they sent in the post a gigantic bright purple shiny jiffy bag with all of their latest, the CEO's books, cheat sheets, blueprints, downloads, merchandise, t-shirts, all that kind of stuff to really indoctrinate us we were fully bought into that brand at that point. We already liked the brand before, but now we're fully bought in. Now we're flag waving advocates of that brand because of that, offline traditional media. So all these things can and will work. But again, the most important thing is that you have to understand that you've got to get the branding and the brand message right. You've got to building on a solid foundation of understanding what your brand actually stands for. But thereafter, once you've got this stuff and you're ready to accelerate, there is some fuel that we can pour onto the fire. So here is the secret brand building tool that is smashing everything out of the water right now. How do you spread the word? You use audio. More specifically, you use podcasting. Before we jump into the podcasting debate, Adam, is there anything that you want to add in terms of the branding overview? Because I actually can't see your lovely face. I don't know if you're waiting to jump in at any given second.
Yeah, no, thanks for that, James. I would say overall, audio is very powerful. The way I think about brand is what people think or say about you when you're not in the room. So the perception becomes the reality. I think how I think about audio is that there's two main ways of leveraging audio. If you want to communicate to a pre-existing audience, so audiences that are already there, the way in which to do that using audio is to be featured on radio shows, to be interviewed by radio presenters or get radio presenters talking about your brand or your proposition, because the audience is already there. And just to throw a few stats to the audience here, 90% of the population listen to radio every single week for an average of about 21 hours. it's the most popular media before 7 p.m. So if you want to communicate to a large pre-existing audience, radio is a very effective way of doing that. We've been doing that for about 20 years. If, however, your target audience is niche, and obviously the reason why we're doing a presentation on podcasting for a health tech event is because it's highly likely that your audiences are niche audiences, perhaps even B2B audiences, rather than mainstream mass media audiences. So if it's a mass audience that you're interested in, we've got the expertise of communicating through radio presenters in a very credible way. But for me, podcasting is about building your audience. It's about cultivating that audience and building a relationship, and then that amplifies your reputation. So they work together very well, but they do very different things when it comes to audio.
Yeah, absolutely. Have we had any questions or queries during the talk thus far that we need to answer or cover off at this point?
No, not so far. I mean, what I would say, if you are one of the people watching right now and you do have any questions, feel free to put them in the chat bar to the right-hand side of the screen. So feel free to ask us anything. So although we have got I know a lot of the speakers here are using pre-recorded video for the presentations. I assure you this is live. So if you do have any questions, feel free to ask us, and we don't have to wait to the end. We can touch on those points throughout the presentation rather than waiting right till the end. So if you've got any questions about podcast or audio or brands, feel free to ask us.
Absolutely. There's no chance you do this and say this was pre-recorded. Or if so, you'd be like, what does that guy keep talking about branding for? Right. Okay, let's specifically dive more in depth into the podcasting space then. So as I say, audio is becoming the fastest reputation building tool that there is out there. And podcasting is absolutely exploding. We're going to go through some facts and some stats shortly. It's getting bigger and bigger, and it seems like it's getting bigger and bigger on a week-by-week basis at the moment. It's really interesting. Adam mentioned there the sort of the mass media numbers that radio attracts, and whilst we're not there with podcasting, we are starting to edge towards it. But what I think is really interesting is that whilst I say that podcast is exploding, it's exploding in a very calm and genteel way. So, for example, it's not doing what a Facebook is doing, or it's not doing what TikTok has done or an Instagram. It's not gone from standing start to 500 million people in 3 or 4 months. But I genuinely believe, because it's been building up on a slower basis, it has a deeper footing of credibility. And therefore, in 15 years, will there be TikTok? Yeah, maybe in some format or another. Will there be YouTube? Yes. Will there be Facebook? Yes. Some of these platforms won't exist in 15 years. Podcasting absolutely will, because it's being bought into the marketplace quite slowly. It's not been bought into it slowly for any other reason than it's just the adoption of people are taking it on board quite slowly. It's actually been around since 2003. So sort of, best part of 17 years at this point. But because it hasn't just gone like hockey stick jump from standing start to 1 billion, I think we're going to see it being here for a very, very long time. So it's definitely worth focusing some serious attention on, because this is going to be a platform that's here for a long time and is going to get more and more powerful as we go. Even at the moment, though, it's already getting very, very powerful. Even Gary Vee's talking about podcast and audio being the next big thing. So therefore it must be true. And Gary Vee, to give you an idea, because I know we've got a lot of investors on this call, Gary Vee is an early stage tech investor, and he actually had a stake in one of the podcasting platforms called Anchor, which was recently sold to Spotify for a reported $275 million. So there is money, focus and attention going into this space right now. Let's start then by looking at what actually is a podcast, because there's a lot of misconceptions. My big bugbear, I'm just going to get off my chest now, guys. I feel like I need to air it with you. I feel like we're all friends now. When people do a YouTube video, they say, oh, that's a podcast. Even if you're doing a video on YouTube, unless you make it audio, it's not a podcast. It's a YouTube video. But anyway, I'm glad I got that off my chest. Thank you for allowing me to recover from that. But why I wanted to say that is, what is a podcast? Well, a podcast is a downloadable file. Downloadable to a computer or mobile device, typically available as a series, new installments of which can be received by subscribers automatically. That sentence there highlights one of the massive underutilized so far benefits and powers of podcasting. So that final part there, new installments of which can be received by subscribers automatically. With a podcast, you have the ability to get onto the mobile device of your ideal target audience. Not only do you have the ability to get onto their device, depending on their settings, they'll actually get notified on their home screen that your latest episode has gone live. So not only can you get them on the most important format of media that they've got in their hand, but you can also notify them with a pop-up. Amazing. Now, obviously, that depends on the settings that people have on their phone. But for example, every Monday morning, I get a pop-up notification goes, Chris Evans' How to Wow podcast has just gone live. So I straight away, I start listening to it by default. What an amazing call to action media that is. So what's the big deal with podcasting? So it's a downloadable MP3 format, audio file. Great. What's the big deal? Well, the big deal is in September 2018, this is a screenshot from Ofcom, which is the Office of Communications. They look at all sort of various communication stuff, including listening audiences. So in September 2018, they cited that podcast listening booms in the UK. Podcasts are booming in the UK with nearly 6 million adults tuning in each week. So bear in mind, that's September 2018. September 2019, that had jumped up to 7.1 million people in the UK. So just in a year alone, that's 1 in 8 people, an increase of 24% over the past 12 months. Now, Ofcom get a lot of their information from an organisation called RAJAR, which is the Radio Audience Joint Audience Research. Radio something. It's to do with radio audience listening, basically, anyway. So RAJAR are the people that go and get the statistics on listening audiences. Obviously, because of COVID and restrictions of movement, etc., they haven't actually released, I don't think, a RAJAR in the last 6 months. But there have been online studies that have been done by Midas, which is also part of Ofcom. And Midas reckon there's now 10.1 million people. Now, because that hasn't been verified, I'm not going to utilise that statistic in this presentation. But if that is correct, if that is to be believed, then from September 2019, excuse me, till the 1st of December, as I'm talking to you guys today, we've added 3 million people onto this platform. And again, when you look at the fact that it started in 2003, and from 2003 to 2018, 15 years, a decade and a half to get to 6 million people, and now we've added another 4 million people in theory in 2 years, is insane. It shows you where it's going. But equally, as I mentioned a minute ago, it's not that standing start to 1 billion people hockey stick that you get with tech startups, which again I think is why it will be here for a long time. So what else is the big deal then? Well, in June 2018, there was something called the WWDC, the Worldwide Developers Conference. And this is a conference that Apple has every single year. And in June 2018, they released their first sort of bunch of stats on the podcasting space. Up until that point, they'd been very, very tight-lipped about how big the podcast space actually was. And I'm taking this data from Apple because they are the biggest game in town as it stands at the moment, despite what you might be reading about Spotify. But in June 2018, there was 18 million episodes and 525,000 active shows on the iTunes Apple Podcast platform. So that's June 2018. Fast forward again about 18 months to January 2020, and there are now 30 million episodes. In January, there's 30 million episodes, 900,000 active shows. Again, another stat that I've heard is that as of today, there is now 1.8 million active shows. So we've doubled the number of active shows in 11 months, 12 months, which is massive. But again, if we just go on the stats I've got for you guys here, 40% increase in shows and 42% increase, 48% increase in episodes and a 42% increase in the number of active shows. That's just in 18 months. So again, it shows you what's happening in this sector right now. So the question becomes, I guess, has the bubble burst? This is something we get asked by clients all the time. If it was 500,000 people in 2018 and now there's, best part of 2 million episodes, that's an increase of what, 300-400%. Good maths today. So has the bubble burst? And the answer quite simply is no. I know that obviously the Giant is the biggest European conference for the health tech space, so I'm going to be mindful to not speak too specifically just about the UK audience, but I know there's a huge amount of people from the UK who are looking at the podcasting space now, from the people I've spoken to before the session today. So we just look at the UK for a minute here. If you look at that graph on the left hand side down the bottom, you can see that 21% of the UK, which is up 3% year on year, have listened to a podcast in the last month. So they're not regular listeners, they're not weekly listeners, but they have listened in the last month. So the global average is about 36%. So if we look at that, even just to get in line with the global average, we've still got another 15% more to go than we have got right now. This is quite incredible, really. So again, 7.1 million people in September 2019 jumped up to over 10 million in just over a year. Staggering. So what's driven the growth? Well, fundamentally, it's your phone. It's the device in your pocket. Now, back in the day, I started listening to podcasts in 2011. I loved it. As soon as I heard them, I was like, oh, this is the future. This is incredible. But it's actually quite a difficult listening experience at that stage. You know, if you liked a show, you still had to, because 3G was a bit ropey. You couldn't always get the internet on your phone. God, doesn't that feel like a million years ago now? But you'd have to, if you liked a particular show, you'd have to download it before you left the house, before you left your Wi-Fi. Even before that, it might have been you had to connect an Ethernet cable and then connect your iPhone. Do you remember you used to have to connect your iPhone to iTunes and all that kind of good stuff? Download podcasts from there, and it'd take ages to do it. So it's quite a difficult listening experience. And still, there was an audience there for it, which is staggering. But these days, with the increasing quality of 3, 4, and 5G, let's not get into the 5G debate, but with the increasing quality of connectivity, you can pretty much stream a podcast wherever you are around the world in real time. So that's what's been driving the growth of it. You can see there 157% increase between 2014 to 2017, which was the latest stats that this report showed up. But I can't even imagine what it's done now. So it's been, really, really been driven through the smartphones. What is going to drive the growth is going to be these little bad boys. Now, whether you love these or hate these, or whether you think that it's great that Jeff Bezos can listen to every conversation, which he is, by the way, or you hate them, smart speaker and voice control technology in the home is going to be a massive new space for the podcast market. 22% of homes in the UK that have a smart speaker use it to listen to podcasts. You might go, okay, well, that's cool. That's, like 1/5-ish of people listen to podcasts via their smart speaker. But how many people have actually listened have got a smart speaker? Well, it turns out 1 in 5 homes has got a smart speaker. And I think it's about 28 million households in the United Kingdom. So 1/5 of those 28 million households have got a speaker, and 20% of those people will utilize it to listen to podcasts. So I think I'm sure I did the maths. I think it's about 1.6 million potentially. How big could this be then? Well, let's have a look at our pals in the United States of America. I know we might have some of the American audience here, so you guys are way ahead of us in terms of us over here in Blighty. So if you can see there on the left-hand side, the United States at 35%. So they're just around about the global average of podcast consumption. So let's have a look at America. The reason for that is because podcasting began, the birth of it was in the United States. In fact, podcasting is so Silicon Valley related that the actual phrase itself, podcast, was so that the MP3 downloads would work on an iPod. Remember those days? Now we're getting heritage based. So that's why I call podcasts, which again shows why Apple is so dominant in the marketplace, because this thing was made to work on Apple devices first and foremost. But anyway, Edison Research and Triton Digital, 2 massive companies over in the States, have done a lot of in-depth research. So we're going to look at some of the stats now. This slide here shows you the percentage of people who are familiar with podcasting and what it means as a term. So 70% of the United States audience now understands what a podcast is or what podcasting is about. So that's 70 million people. So, sorry, 70% of people, which is an estimated 197 million people who understand what the medium actually is. This here is the amount of people that have ever listened to a podcast. So 51% of people in the States have ever listen to a podcast. So again, they're not monthly or weekly or regular listeners, but at some point they have listened to a podcast. So 51% of people, so that's an estimated 144 million people. Percentage of people who have listened to a podcast in the last month in the United States, 32% of people when surveyed. So that's 32% of people, which is 90 million. This is quite interesting. So this is a gender split in terms of podcast listening in the last month in the United States. You can see there's a bit of a spike in 2019, from male and female. But you can see there's starting to be a bit of a split between male and female as well. So this is quite interesting. We'll touch on this in a little while, but actually traditional media has been more female focused. So the fact that you've got a sort of a mainstream media that's actually targeted more towards males means that if you've got a male focused brand, it's very, very powerful. Other thing, this is interesting. So if you look on the left-hand side of this slide, the increase of growth in that 12 to 24 category. So traditionally, traditional media, TV, radio has been very, very bad at getting to the younger marketplace. Even social media, the main place to get hold of them and to communicate with that group of people is via social media. The issue that social media has is that as it becomes more mainstream and more applicable, then the youth market don't want to be involved in it anymore. As soon as your mum goes on Facebook, you no longer want to be on Facebook, etc. Got to be terrified if my mum was on Facebook. But realistically, with podcasting, we don't have that same issue. So it's increasing in audience in the most hard to reach or age demographic, which is really useful. This slide here should have a little box, on the left-hand side. But this is the percentage of people who've listened on Spotify between 2018 and 2019. So Spotify has obviously traditionally been a very, very music-focused platform, but now podcast listening is getting bigger and bigger. I think in a lot of the Scandinavian countries, actually, there's more people listening to podcasts than they are listening to music on Spotify now. So it's gone from 32% to 53%, so a 21% increase in a single year, again, amongst that really, really hard to reach younger demographic. People that have listened to a podcast in the last week in the States, 22% of people, so 62 million people. So there's more people in the States who are listening on a weekly basis than are in the UK that are listening on a monthly basis, which again, if you're in the UK, should really excite you about how big the opportunity is here. US weekly podcast listeners will averagely listen to 7 podcasts a week. So not only is it a fast growing audience, but they're also really content hungry. They'll listen to a show every single day. Key sign of where this is going is obviously money. So the future of podcasting in the advertising business, this was a stat pulled from 2019, and they estimated that they were going to get to 600-ish million pound in ad revenue by the end of 2020. It's actually going to get up to about 850, 900 million. So into 2021, podcasting will become a $1 billion a year business. And given how big it is, it's staggering how cheap it still is to advertise on podcasts. It's a real growth market. I think, the explosion of podcast, of Facebook ads, Twitter ads, social media ads in general being very, very good value for money. I think you're about to see the same thing happen for the podcast space. Highest earning podcasters. So last year, Joe Rogan earned $30 million just in ad revenue. Now, what I'm not saying is, start a podcast and make $30 million, because that'd be a little bit incongruent as a title of a presentation. I mean, don't get me wrong, it'd be great for traffic, but I think it'd be a bit incongruent of me to say that. But it just goes to show how much potential there is as a content creator to create content that's that valuable. Advertisers will spend money with you. Now, don't get me wrong. What we're not talking about here, especially for sort of the majority of you guys who are watching, what we're not saying is, create a podcast and take on sponsors and monetize your content straight away, because that's not what this is about. There's much more value for you guys to raise your brand, raise your awareness, raise your profile, raise your expertise within the marketplace via your podcast than there is in taking a few quid via sponsorship. But again, it's just worth seeing that the marketplace is moving in that direction. Fundamentally, where money goes, the attention flows, and vice versa. Where the attention flows, the money goes. And that's what's happening at the moment. So why is podcasting so powerful for brands? Well, not only is it a growing audience, but it's a very valuable audience as well. Something like 70 to 80% of the podcast listening audience falls into this ABC1 socio-demographic profile. So these people tend to be more educated, more affluent, and have a disposable income. So depending on the business that you're in, obviously, they tend to be the sort of people that you want to reach with your marketing and communications, because they have got the money to buy the stuff you want to sell. Touched on it a minute ago, but it's a slightly male biased audience as well. Not, we're not looking at like 80-20 in favor of guys, but it's slightly male biased. And as I mentioned before, traditional media is slightly female biased. So this is actually a growing marketplace where you can reach a very targeted audience. 37% of people who listen to podcasts fall into that 15 to 34 age range. And obviously we touched on the stats from Spotify. There is a growing audience, a hungry audience of youth listeners who are traditionally very, very hard to get to. It's almost the opposite, as I mentioned, of strong existing media such as radio. However, there's also a powerful multiplier effect. One of the things I thought we would see, and especially of huge interest for us because we've got such a history and a heritage in broadcast, in traditional broadcast, was the fact that, well, surely as podcast listening goes up, radio listening has got to go down. But as it stands at the moment, I think it's still something like 89% of the UK population listen to radio on a weekly basis. So it hasn't cannibalized the audio market as of yet. I think it will at some point to a certain extent, but at the moment, it's actually multiplying the power of both platforms. I actually did a podcast for my own show this week with a guy who's created a podcast radio station, a digital radio station in London, Surrey, Kent, Glasgow, and Manchester, I think it is. So with the potential reach of 14 million listeners on a weekly basis. But he's like, what I'm trying to do is I'm trying to give, I've covered off the weakness of podcasting, which is the audience at the moment. And then I've combined that with the most strong part of radio, which is its mass media reach and appeal. So it's a massively powerful multiplier effect with podcasts at the moment. 37% of people have discovered a radio show via a podcast, and 48% of people have listened to a show via YouTube. Now, you might have heard me go on my little YouTube rant earlier. It was half in jest, only half. But, a lot of people are consuming podcast content on YouTube. Why else is podcasting so powerful for brands? Well, it's a proactively niche audience. There's 19 top line categories, and then there's sort of 4 or 5 subcategories in each top line category. We'll go through those in a minute. But people are actually proactively looking in those sectors for that content. So people are proactively looking for the content that you could make. So as I mentioned to the Great British Entrepreneur Awards, BT, when I did a seminar for them last week, people are there. And if you're not putting that content into the earbuds of your ideal listening audience, your competitors potentially will be. It's an engaged audience. We talked about a minute ago, 7 shows a week get consumed by podcast listeners. That's 1 a day. Strong socio-demographic audience, ABC1, making up 70 to 80% of that listening audience. Content hungry audience. And it's also a growing audience as well. We're going to go into the categories quickly. Is there anything that you want to cover off there, Adam, before I jump into categories and such the like?
Only that that you can choose, obviously, as you know, James, up to 3 different categories that you're listed in as part of the distribution. So you're not limited to only one category, that you can have a choice of few to kind of hedge your bets as to where your audience is going to find you.
Perfect. So I'm just getting a message from the guys at Giant Health going, what time are you finishing? I thought we would go for 2 hours. So I'm just double checking that we're not going to be overrunning a very important seminar. We are doing 2 hours, right? Got to love this technology, haven't you? Bring back face-to-face, I say. Bring back stages and hugging people.
So just while you're looking at that, James, we had a couple of questions. Fiona asked about listener profiles. So I know that you're going to, obviously you've covered an element of that. And Simon was asking about the leads, actually generating leads, and whether or not podcasting generates a better quality or value of lead compared to video content like YouTube and that kind of stuff.
Interesting questions. It's very difficult to answer that, not because I'm trying to be intentionally evasive, but it depends on what you're trying to do. From an authority standpoint, right now, podcasting, and it's organic as well, podcasting is really sort of trumping a lot of other media and mediums that are out there. But in terms of, advertising straight onto YouTube, you can literally put your 30-second B-roll in front of the video of your competitor. So will that bring you a more beneficial ROI? Difficult to say. Almost with that question, Simon, we're not really comparing apples with apples there, but a very valid question. I would say, again, for podcasting, I've actually had this debate with a client earlier on today, actually. The podcasting is very, very, very valuable for overall brand awareness building. So in terms of, and it drives, and we'll talk about call to actions in a minute, but in terms of, video versus podcast is kind of 2 different battles there. I'm going to crack on really quickly.
Just to kind of address that point as well. Obviously, there's a big difference between paid audio content like adverts on podcasts compared to adverts on YouTube or Facebook videos that you're paying for the adverts, and then organic reach. Personally speaking, I'm a big fan of organic client acquisition rather than paid client acquisition, just because I think it has more credibility, and over time the cost goes down, but you do have to build that audience. So personally, I build audiences through YouTube and podcasts, and a lot of that content could be repurposed. So one of the things I don't think is in the presentation, but it might be worth talking about, James, is audiograms and spectrograms. So how you can turn highlights of podcasts snippets into video content, and then you can actually use the video content to again generate leads and engage with audiences in a more visual way.
Yeah, absolutely. We'll cover that off shortly. The other thing I was just going to quickly say, Simon, sort of finish off that point, is the Joe Rogan podcast is a great example. So Joe Rogan gets about 190 million downloads a month, and he gets and he's only got, and I say only, it'd be nice to have, but he's only got 6 million subscribers for his YouTube channel. So his reach via podcast is much, 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 much higher. But again, in terms of a sort of a, will it acquire him more, clients, or would it acquire more people going to see his comedy shows as opposed to an advert that's, placed as a B-roll ahead of a piece of content? Hard to say, really. In terms of the categories, we talk about sort of niche audiences. In terms of the categories, these are the 19 top line categories that iTunes have got at the moment. Now, all of the other platforms, Spotify, Google Podcasts, TuneIn, etc., all take their lead from Apple. They might just call them something slightly different so it doesn't look like they're directly copying, but all of the fundamentals fall into these categories by and large. They might just have a bit of a different name. So you've got news, comedy, sport, history, true crime, society and culture, arts, business, education, fiction, government, health and fitness, kids and family, leisure, music, religion and spirituality, science, technology and film. So obviously for the audience that we have here today, business, education, potentially sports, I guess, health and fitness, science, and obviously technology, really, really specific. So there's 5 top line categories that would work really well for the majority of your brands and businesses, depending on what you're doing within the health tech space. And also within those categories, you've also got subcategories. So for business, for example, you've got a subcategory of entrepreneurship. What's you got? Entrepreneurship, health, entrepreneurship, marketing, not-for-profit, and a couple of others which are eluding me right now. But on the back end systems that we tell people to utilize, you can actually make your content go into specific categories and subcategories. And that's something that a top hack that I would share with you, is to make sure that you could choose up to 3, as Adam mentioned a minute ago, when you're setting up your back end system. So make sure, if you can, and if it's relevant, you put them into 3 subcategories, not just 3 categories, because it gives you more opportunities to get organically found in various curated platforms. So most of the charts and the categories and the subcategories will have a top 50 new shows list of shows in those categories and subcategories. So, for example, one of my podcasts is called Building the Brand, and because I put it into the subcategory of entrepreneurship, I featured in the entrepreneurship chart, and I also featured in the business chart with the same listing, if that makes sense, because entrepreneurship is a subcategory of business. We'll talk about that a bit further down the line, actually. The other reason why podcasting is mega powerful is because it gets to people at times when other mediums can't. So they did this survey, and people saying, yeah, I listen in bed, a bit weird. I listen when I'm taking a break or out walking, doing chores. Me personally, I've got a 12-week-old baby, so if he needs to go out for a bit of fresh air, I'll always stick a podcast on, take him around the block and not listen to the crying. And that's what 12-week-old babies do, though, isn't it? So I do that, doing the laundry, doing the washing, cutting the grass, etc. All those times where other mediums can't really get to you. The other big one that I think is, it's twofold. Commuting is a big part of the listening audience, and so is like training, exercise, gym, etc. In theory, touch wood, fingers crossed, you're not watching a YouTube video in the car. Hopefully, you're not reading a blog in the car. Fingers crossed, if you're training hard, you probably shouldn't be, reading a post while you're on the treadmill. So audio can get you at times where other mediums can't reach you, which is mega, mega powerful. And it's powerful because obviously you are almost like the collaborative friend on the journey with the person who's driving the car, but equally there's no other distractions. Well, I mean, other than driving the car, but there's no other media, for example, with TV, as soon as the advert comes on, what do you see? Most people now pick up their phone and they go on to Insta, Twitter, TikTok, wherever it may be. So having opportunities where that medium is the only thing that people are consciously or subconsciously focused on, very, very powerful. This slide here shows you the proportion of people that are listening to podcasts based on their age, so sort of under 35s or over 35s, and where they're listening. So you can see there, big percentage, 52% of people in the younger category, and 61% in the over 35 category are listening at home, which I find really interesting. So that to me says that these are people that are genuinely concentrating on the content that you're putting out. So let's say, for example, you've got a relatively complex concept that you need to clarify, you could do it in a podcast. You know, by all means, you could tell people, you know, take a pen and paper out. I'm going to run you through this. You could coach people, mentor people, educate people utilizing this as a platform. And then this is the proportion of people that listen to podcasts based on the market or the genre of the podcast. So you can see there's quite a broad spread. This was a stat at the beginning of 2020. I've got no doubt that news and politics would have had a bit of a spike given COVID, etc. I wouldn't be surprised if health has had a bit of a spike as well. But there you can see sort of broadly 15% across the board. So there's quite a broad spread of interests across the podcast. So people listen to a lot of content, average of 7 shows per week. We've already touched on that. They're listening at times when no other media can reach them. And that audience is super valuable, not just because it's ABC One, not just because it's growing, but again, because no other media can get to them. So you are the focus of people's attention. And it's also an amazingly powerful call to action medium. So this might touch on your point earlier, Simon. 56% of people will click a link when told to do so. And there's some stats that were released a couple of months ago that said 59% of people have bought or would buy a product that they heard advertised on a podcast. Because it's one of those sort of new-ish mediums, even though it's not actually that new, people are very much willing to sort of support podcasts and podcasters. You hear podcasters saying it all the time, you know, please support the show by supporting the people who sponsor us. So it's a very, very powerful medium for people to click a link. 56% of people, as I say, so you can drive them to click a link in the show notes. When you look at the online industry average is about 4% click-through rate. That's amazingly powerful. 14 times more likely to use a call to action in a podcast than any other marketing. So, for example, if you were listening to my Building the Brand podcast and I said to you, hey, blah, 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 I've got this product or service, click the link, you're 14 times more likely to do that than if I told you via a Facebook ad or, you know, on Instagram or whatever it may be. So that's a lot about the audience, but let's have a look at what podcasting is related to for you. So a podcast is for you. And it's not for everybody, by the way, but it's for you if you want to create expert positioning within your marketplace, be recognized as a thought leader in your space, use your brand to generate revenue, be considered as an influencer, generate organic traffic for your business, pull business opportunities to you, network with global business leaders, create global attention, generate leads, turn fans and followers into paying clients, and ultimately monetize your content. Now, I can say all of these things because I've done them. Personally, Adam's done them, and we've done them for clients as well. So none of this presentation is sort of theory about this could work or this might work. This is stuff that we've done day in, day out. Is what a couple of clients recently said about what podcasting had done for them. Because obviously me and Adam are going to say that podcasting is great because we're in the audio space. But it was really, before we did this presentation, we asked a couple of clients. James Sinclair is a very successful entrepreneur. He's done £100 million in sales. Generally does sort of between 10 and 15 million pound a year, has 450 staff, mainly across business development and leisure, actually. But he said that it got him clients and it built his personal brand. Building personal brand, I genuinely believe, is one of the fastest ways to build a business brand. I really do. It's the fuel on the fire. Investor Dan Holbert said that it helped him to build his profile. I actually asked Dan, because Dan's a good friend of mine as well, actually. I've helped him to launch a few podcasts. I said, in terms of like build profile, what do you mean build profile? He's taken on investment money for joint venture partners because they heard him on a podcast. They heard him on a podcast. They had a meeting with him. They clicked a link in the show notes. They booked on. They started following his content, and ultimately, he's borrowed JV funds via a podcast. Expert coach Will Polston. We asked him, and he said, "I've got leads that I wouldn't have ultimately got." Will likes to over-deliver, so he then went on to say a number of other things, including what I thought was really interesting. On the right-hand side, you can see there, I've had cold leads sign up for the most expensive services out of the blue. Now, the interesting part there is obviously the sign up is out of the blue to Will because he didn't know it was coming. But signing up was not out of the blue for the client, because the client has now become warm traffic or even hot traffic that would ultimately have started as a cold lead otherwise. The whole process these days of know, like, and trust, it still exists. I know we're living in a fast-paced time with, you know, ongoing social media, etc. But the fact there are you still have to take people through that know, like, and trust process. There's no way to shortcut it. You can accelerate it by having more touch points with your client, by being seen by more clients, by having a podcast, targeting them with advertising, pixel targeting and retarget marketing them, all that kind of stuff. So you can accelerate the process, but you can't shortcut it. know, like, and trust still works, and podcast, again, is one of the biggest authority building tactics that there are out there. You'd be pleased to know, guys, that podcasting isn't rocket science, but there is a systemized approach to getting it right. We've launched 100 well, see how these slides were already done a couple of weeks ago. We've done another 9 since then. So we've done 129 iTunes top rated podcasts, including the giant. If you've just jumped on board, you didn't see the beginning part of the presentation, chances are you've already heard our work. You just might not have known about it, because we were the guys behind the Giant Thinking podcast. So we launched that with Barry, and we did interviews with the likes of Peter Ward and Professor Shafi Ahmed, Dr. Ali Parsa, some of the real tastemakers within the space. So we were the creators of that podcast alongside Barry and his senior team at Giant Health, which was a privilege and a pleasure. And I, as the exec producer, sat in and had some conversations that I knew 1% of what anyone was talking about, but I thoroughly enjoyed myself. But if you do want to launch podcasts, so it's not rocket science, but if you do want to launch podcasts, you have to know the A to Z of how to plan, produce, launch, grow, and monetize what it is that you're doing with your audio creations. We want to make sure that you get some actionable value from this presentation, and we're working towards sort of wrapping up now, so we're going to get through this a bit quick, so we allow ourselves some time for Q&A before we've got to finish at 4:30, because I think Peter Ward actually and the guys at Humanity are due on at 4:30. But here's some top tips of what you need to sort of consider before launching a podcast. So we'll rattle through these as quick as we can. Your show. So you've got to look at the format. First and foremost, before you start to press the record button, before you start making content, before you get fancy voiceovers and graphics and all that kind of stuff, and audiograms and spectrograms and quote graphics and lead magnets and click-throughs and blah, 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 you need to understand the show. You need to think about the show first and foremost. What's the format going to be? Is it going to be interviews? Is it going to be solo rounds? Is it going to be one-to-one? Is it going to be face-to-face? Is it going to be potentially round table? Is it going to be a mixture of all of those things? The great thing with podcasting is that it's good to have a format. It's good to have kind of like a rough idea of what the show is going to be about, but it doesn't have to be formulaic. So let's say, for example, you normally do one-to-one interviews, but then off the back of attending the Giant Health event, you've met 5 peers, and you're like, oh, do you know what? I'd love to get around a table. When we're all allowed to touch wood, when we're all allowed to do it in person, or I'd love to get on Zoom and, have this conversation with peers. If you've done traditionally a one-to-one or interview-based format, you're like, oh, I've never done round table before, do it. It's your show. I like to think of a podcast as a pre-recorded radio show that you control. So back in the day, if you wanted to get your voice heard, you'd have had to have, sent off a demo to someone at the BBC and hope that you ticked all the right boxes and they were looking for a new show, et cetera, et cetera. Podcasting gives you the ability to just bypass all of that. You can make the content that you want, reach the audience that you need to speak to with your own content that is, controlled by your own narrative. But think about that format: one-to-one, face-to-face, interview, groups, coaching, mentoring, whatever it may be. Frequency. We used to give clients the option with this. We now don't. You've got to be putting out podcast content on a weekly basis. However, that doesn't mean that you need to be doing it on a weekly basis for perpetuity, i.e. forever. So we do a lot of like season and series-based launches for clients because they want a start and a middle and an end. So with the Giant Thinking podcast, for example, we did an 8-week series about 8 weeks out from the seminar, the event, because we're using it as a brand building tool for the event itself, if that makes sense. Then we'll stop for a few weeks, and then we might take a lot of the content from what you're going to be hearing from the keynote speakers. We might repurpose that content for series 2. But what we won't do is just do a sort of a weekly, ongoing, forever podcast. We'll do it as seasons or series, between 8 and 12 episodes in a series, then have a break, then come back. It also enables us to batch record content and then have a sort of a full launch process again as well with for our show. Length of show. I always get asked about this. How long should your show be? It sounds a bit facetious. I don't intend it to be, but it's as long as it's interesting. If, for example, you normally do 30 minutes, but you get in a conversation with someone and you're like, oh my God, we spoke for an hour and a half, put it out. Put out an hour and a half show. It's your show. You can do what you like with it. Bear in mind, a lot of people have a sort of, whether it's because traditional media has been in a sort of 30-minute segments or chunks, people like 30 to 45 minutes, the majority of podcasts fall into that gap. But equally, it can be as long as you want it to be. The shortest podcast is about a minute, and the longest podcast is 5 hours, 15 minutes. So anything between 1 minute and 5 hours, you're good to go. Final point with considerations of your show, especially when you're getting started, is what access do you have to guests? Now, what you don't want to be thinking is, oh, well, I used to know the babysitter of the dog walker of Jermaine Genius from Tottenham Hotspur, so I reckon I could get Jermaine Genius on the podcast. I use him as an example, weirdly, because he was going to be one of my first guests, but I couldn't get hold of him. because of this exact issue. But what guests do you have in your immediate network? And also with those guests, what relevance do they have to that audience? We talked about, it seems like hours ago now. Hopefully it doesn't feel like hours ago for you guys as well. But, we talk about the brand of your show. What's in it for them? What's in it for the listening audience? You're going to bring on, me onto your podcast, for example. You go, oh, that guy's quite a good speaker. I'll get him onto my podcast. What can I give your guest? If you've got a health tech show, what can I talk to your guest about? If it's not branding or podcasting, I'm not going to be a very good guest. Don't get me wrong, I will definitely give it a go, but I will be a very poor guest. So just make sure you're, number one, what sort of access do you generally have to guests? And I would say, look inside your inner sanctum, inside your network, people that you can generally get hold of quite easily. And then number two, with guests, what are they actually going to bring to the listening audience? Because it's all well and good. We've talked a lot about, it's your show, you can control the narrative, you can do what you want, blah, blah, blah. But the show has only got value if there is value for the listening audience. It only makes sense if the listening audience get value from that podcast. When you set up a show, you're going to need what's called a syndication software. So when you download it from Spotify or Apple Podcast or Stitcher or Google or wherever you may get your podcast from, I'll be really interested, actually. Could you put in the chat, where are you listening to podcasts? Because I'm really interested when I do sort of big talks for people. I'm always interested to understand where people are actually listening. So yeah, put in the chat box, where do you listen to podcasts? Is it Apple? Are you on your phone? Are you on your desktop? Is it Spotify? Is it Google Podcasts? Let me know. That'd be really useful to understand. Thank you. But yeah, wherever you download your podcast from, you're not actually getting it directly from that place. You're getting it from a third party, so a syndication software. Now, there's loads of them out there. I mentioned Gary Vee earlier. He was an investor in Anchor, which was a syndication software. You've got Podbean, Buzzsprout, Acast, Audio Boom. There's a plethora of them out there. And fundamentally, by and large, they kind of do the same stuff. They're not doing anything that's too clever, side by side from anything else that's out there. But the one that I would suggest is Libsyn. Libsyn is fantastic. It stands for Liberated Syndication. It's been around since 2004, so it's been around for 16 years. It was the first syndication software of its type. It's got very close links to Spotify, to Apple, to all the other major platforms. And when you set up the back end of your system, when you set it up on Libsyn, it sets it up on all of the other platforms. So it's a bit chunky, and a bit clunky, and a bit hard to use the first time. But once you get it right, if you get your back end system set up, you choose the categories you want to be in, you put your launch dates in there, you put your artwork in there, etc. Again, for a lot of the people watching this, is not rocket science. I'm sure you've done much more complex things just today, probably, frankly. But once you've done it on Libsyn, all of those settings that you create work across all of the different platforms. So thereafter, every time you go to upload an episode, you just upload it to one place and it spits the content out effectively to all of the other platforms. So that's Libsyn, libsyn.com, I believe it is. And it starts from like $5 a month. So it's really, really cheap as well. One of the big questions that we get very, very regularly is, I'd love to start a podcast relations group. I'm just a bit worried about, the cost of it. I'm going to have to go into a studio every time. I'm going to have to buy a 5,000 quid microphone. No, my friends, you're not. The thing that you're seeing on the screen there is the Rode NT USB. It's a USB microphone. It literally will sit on your desk, will plug straight into your laptop. You can use it for Zoom or Zencast or Squadcast or Riverside FM or whatever podcasting platform you're going to use to record with your guests. Or maybe you're going to do a solo show, plug it straight into your laptop and you can record straight away. Gives you a great quality sound. It's about 150 quid. You can get it on Amazon Prime. So it'll literally turn up at your office next day. I actually got turned on to this microphone by a client who had to narrate his audiobook. He's supposed to go into a fancy studio to go and narrate this book. Then obviously COVID lockdown version 1 happened when everyone was still taking it seriously. And he couldn't go into the studio. So the sound engineer said, look, second best thing is get a Rode NT. And I listened to the quality of the content and it sounds phenomenal. So yeah, for 150 quid, you can't go far wrong. In terms of software, so once you've recorded your podcast, you're going to need to do a bit of editing. Potentially, you might need to make it sound a bit louder or a bit quieter. If there's you and the guest, maybe you're a lot louder than the guest is. You need to level up the sound. Basic software is Audacity, Audacity. So that's Audacity. And that works on PC and Mac. Also, if you've got a Mac, you've already got editing software built in. So there's editing software called GarageBand, which is free of charge because obviously it's already built into your platform for you. But I always encourage clients to use Audacity just because it's so easy and simple to get up and running. Obviously, for the clients like Giant that we work with, they didn't need to know any of this stuff. They just needed a microphone. They did the talking and that was it. And we handled all the rest of it. Did the editing, the production, the audiogram graphics, the countdown graphics, the marketing materials, the promo. stuff, anything that got posted out via social media about their podcast. We created episode artwork, clips of the guests, all that kind of stuff. But it's useful to know we utilize various softwares, but one of which would be Audacity. So if you're getting started, check out Audacity. Final couple of points then. So to make your show stand out, and obviously the same rules apply as they do on any marketing platform in general, that you have to stand out and you have to grab and capture your audience very, very quickly. So one of the ways you can do that and sound like a polished production, because again, there's 1.8 million shows that are now registered to Apple Podcasts. You've got to stand out from the crowd. One of the easy ways to do that is to have a great theme music. So I always recommend premiumbeat.com, which has just been bought out by Shutterstock. They've got thousands and thousands and thousands of license-free tracks where you buy the rights to that, the royalty-free music. And it's, back in the day, 5-10 years ago, royalty-free music was either like panpipe Beatles or terrible elevator music. But Premium Beat's got, Emmy award-winning producers who literally make license-free tracks, because there's actually more money in that, ironically, than there is in licensable music you try and sell to the audience these days, which is a sad fact, but is the reality. So premiumbeat.com, and for $49 you can buy a track that you own the license to for podcast purposes, and you can make your show really stand out. I think online you've got about 3 seconds to stand out or get somebody to engage with content if you put it in front of their face. I don't think it's quite as short a time span or attention span on podcasting, but it's probably not far beyond that. When we're creating podcast intros for clients, it's got to do quite a lot quite quickly. It's got to engage that audience, tell them what sort of entertainment, education, or information they're going to get. It's got to make them excited to listen to the content, and it's got to do it ideally in under 30 seconds. So once you finish watching this, if you want to, there's a podcast hub. If you click on the giant logo in the top left corner, and then you scroll down and you click more, there's a podcast hub. All of the Giant Thinking podcasts that we created is actually on that podcast hub. So go and check it out, and you can hear how powerful podcast intros need to be quick. But that's one of the ways to really stand out. Great intro and outro music. The outro is also really important, because obviously we mentioned earlier, 56% of people will click a link in the show notes when instructed to do so, but you need to instruct them to do so. So having a voiceover artist potentially over the back end of your theme music could be a really really impactful and powerful way to make people click that link in the show notes. And finally, then, the most important part of a podcast, all of it's obviously very important, but one of the essential parts is the launch process. I've seen a lot of very, 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 very good podcasts get absolutely zero traction because they were not launched in the right way. Apple gives you a much higher weight of importance to any activity that happens on a new account. So I think and this is based on launching 129 podcasts at this point in time, with 85 to 90% of those end up in the iTunes top charts. We know a thing or two about how Apple works, and I reckon for every one rating, review, download, subscriber that you get on Apple, is probably, as a new show, it's worth 50 times that. So 50 downloads for a more established show. And I say that as someone who's getting 25, 30,000 downloads a month consistently. And then once you become an older show, getting the same numbers doesn't get you the same results in terms of chart positioning and organic awareness. So when you do go to launch your podcast, you need to drive all the traffic to one specific day and one specific time to get the maximum traction of how the algorithm works. And then you need to launch ideally 3 shows. So episode 1 would be a pilot episode, so between 5 and 15 minutes. Again, credibility, who you are, why should people listen to you, what kind of content you're going to be sharing with them, what education, information, and entertainment are they going to get. And then I'll give them 2 full episodes. So for example, if you're going to do roundtable conversations and you're also going to do solo episodes some weeks, give them 1 of each. So on launch day, there's got to be 3 shows there, pilot episode, and then 2 full episodes of content you intend to make for your listening audience. That, my friends, is how to explode your health tech brand in 2021, utilizing the power of audio. I really hope that was beneficial for you guys. I really hope that was useful for you guys. I appreciate there's a lot of information in those slides, and I've talked at you incessantly, but I hope there's been some serious value from that. Have we had any other questions or queries in the meantime?
Fiona just said that she tends to listen to podcasts while dog walking, which kind of makes sense. I listen to podcasts while I'm going for jogs and that kind of stuff. So certainly relate to that. If you're out and about, walking, jogging, podcasts are great. And I guess the other key thing to say is that although a bit of technology is useful, it isn't that complicated, and one of the things that myself and James do through the relations group is we actually do a one-day consultancy to teach you all this kind of stuff, to actually teach you exactly what equipment you need to buy, how to set everything up, how to think about the format and that kind of stuff. So it might feel or sound a bit overwhelming that you're thinking, wow, there's way too much information here to kind of process. But actually a single day of intense consultancy is actually a really useful way to kind of get all the information that you need there. And I'd also say, with many of the 129 podcasts that we've launched, for many of them, their intention is to do it themselves. But what they want to do is they want to minimize the risk. And a lot of them actually get us to launch their podcast for one season, normally about 8 episodes, so they can learn how we do it for them. And then at that point, they've started to build their audience. They have already got their intros, their outros. They know the basics of editing because they're watching it. And then at that point, they bring it in-house. And that is a fantastic way to learn all the skills and reduce the risk so that you can actually have a long-term podcast rather than constantly outsource it. But the reason why we recommend that rather than starting it yourself to begin with, as James quite rightly says, if you get the launch sequence slightly wrong, actually you might not get any chart position. You don't get the assets to leverage to then acquire more high caliber guests and things like that. So my kind of way of thinking is, if it's worth doing, it's worth doing properly. And if you're going to launch a podcast, particularly for some of the brands, featured here at this event, you might as well do it well, so that it comes across very slick, very prestigious, and gives you those thought leadership and credibility benefits that you really want. And the final thing I would say before we look for any questions, and if you have got any questions, start putting them in the chat box now, because I think we've got about 5-10 minutes before they need to prepare for the next speakers, is that one of the things that we're more than happy to do completely without charge is a feasibility audit. So if you're watching this and you're weighing it up, look, you're not sure if a podcast is going to work for your brand or not, in the chat link is my email address, James's email address, and a link to a Calendly appointment scheduler, where you can schedule a 30-minute consultation call where we can do a podcast feasibility audit. We'll ask you the questions to figure out if a podcast works for your particular niche, what kind of format would work well, just does it even make sense to do that kind of stuff. So if you are interested in that, then we can certainly do that completely without charge. And it might be at the end of that feasibility call, we figure out that a podcast doesn't work for your brand or your niche, but at least you would know within 30 minutes, and that's completely without charge. There's a question here, and thank you, Gil Rabbi, for the compliment there on the show. Glad you liked it. Simon Hooper, question, is there a best place to look at a library of all available podcasts, a directory, and what's been launched today? So yes, there is. Apple, if you download the Apple Podcasts app, there is a section on there which is new shows, so you can see the most recent new shows. And the launch sequence that James talked about actually increases the probability that your show would be featured in the new shows section of Apple Podcasts because of the algorithm technique that we use. So not every new show is going to be in the new show section of Apple Podcasts, but we can increase the likelihood of that. And actually those categories that James mentioned on Apple Podcasts, you can actually then see them, and then you can scroll through. And it also has a search bar. So if there's certain keywords that you're interested in, you could put those keywords and then see things that come up. And Spotify have a similar system. In fact, all the major podcast platforms. And there are podcast search engines like Listen Notes and things like that you can put details in. I don't know if there's anything for you to add there, James, on the directories. Okay. Yeah. So there's a picture of the that's very small on my screen there. Okay. Yeah. So you can browse. You can browse on Apple Podcasts, any of the podcast platforms, and just look. And then you've got the artwork, which normally gives you the title, and it also gives you the category that it's in, and that kind of stuff. Yeah, you've got the podcast audit there. Videos available. Let's see if there's any more questions. Simon would like the podcast suitability, so we'll email you a link and then you can schedule the time there, Simon. And I think that's it in terms of any questions. If you do have any last minute questions, feel free to put them in the chat box, but I think we're about to wind up. I would just like to say thank you for your time, for everyone that's been watching. I would like to thank James. He's done the majority of the talking. I've been here basically watching and learning some even more stuff.
Same presentation that you had to watch yesterday, just as a backup. So I'm sure you were delighted of 4 hours of the same stuff in 2 days.
Yeah, my podcast IQ has gone through the roof. Do you think there is a market for, we've had another question from Nicola Kartner. Do you think there is a market for NHS produced podcasts for condition specific information? I think there would be, but the way in which I would think about that isn't by creating the content around condition specific information, but more the problems and then the solutions that are connected to that. So we know that the health and fitness category on Apple Podcasts is really popular. But if someone has insomnia, for example, the keyword really is sleep. It's the solution rather than the problem that you tend to make the keyword or the title of the show about. So, you know, it's worth thinking about. But again, if you're not sure, then schedule that 30-minute feasibility call, and we'll go into a bit more depth so we can understand what kind of conditions you're thinking about, and we can look into that. So again, James, I think, has put that link for the podcast audit, and I think there's also going to be a link to that on our stand. So if you want to find out more information, you can track us down on LinkedIn. You can go to our stand for more information, or you can just gather more information by reaching out to us. Hopefully this has been useful for you. I couldn't agree more with, I mean, I was a skeptic. I was kind of on the fence, probably even as much as a year ago when it came to podcasts, and I'm a complete convert now. You know, I would describe myself as a podcaster. I love podcasts. I love listening to them. And they are fantastic as a very cost-effective way to get you the kind of benefits that you get from speaking at an event like this, from authoring a book, from being featured on radio and TV. It gets you those kind of benefits, but it's completely within your control. But the important thing is that if you are going to launch a podcast, that you do it right, and we can certainly help with that if you are at all interested. I think that's it for me. Is there anything to add there, James?
No, absolutely. Thank you very much for your time and your attention, guys. Thank you very much to the team at Giant Health for putting this together. I know that this has been a technical mammoth task to make this happen, so I very much appreciate all those guys as well. Thank you for being here. Nicola, just to touch on your point, actually, with the NHS produced podcast, one of the most, and to sort of further back up Adam's point, one of the most popular podcasts in the health and fitness category, has been in the top charts for 3 years now, is the Couch to 5K, which is produced by the NHS. Really, really simple. Really, really, like it's not rocket science. It's really, really just a simple podcast which helps people go initially, like takes them on that whole process of going from the couch to 5K. Super, super popular. But again, I think the point of it there is it's solution focused rather than issue focused, if that makes sense. But it works really, really nicely. I think we've had another question though. Thanks, fascinating. Thanks very much, guys. Very much appreciate it. As Adam mentioned, there's a link in, I'm not sure if the links are clickable. If not, just copy and paste it. Go to calendly.com and you can find out more information about how to book one of those podcast audits. And me and Adam are very, very honest as podcasters ourselves. You know, we've done thousands of episodes as a company. We've done thousands of episodes, which has generated millions of downloads. If the idea that you are thinking of doesn't hold water, we will tell you. We'd rather be right than be your friend. And ultimately, if you've got a great idea, because we get all the time, clients come to us and go, can we talk about our branding this way or that way? But quite often with a couple of tweaks via one of these podcast audits, we can take a very, very corporate commercial message, make it interesting content that will make people want to listen to it on a weekly basis. Podcasting is exploding, guys. It really is at the moment. And again, as Adam mentioned, it's the fastest way to add fuel to the fire of solidifying your position as the expert authoritative voice within the marketplace. When is the best time to do a podcast? Right now. when it would be, the second best time? Tomorrow. So don't leave it too long. I know there's a lot of stuff going on in the world right now, but feel free, book up for that podcast audit call, and myself and Adam will walk you through the process and find out what, if anything, would work for you within the podcasting space. Thank you for your time. If you are tuning in thinking, hey, where are the guys from Humanity? That's not us. Fear not. They're going to be talking about wearable technology in the next 10 minutes. I think they're on at 4:30. But for myself and from Adam, thank you for your attention. Genuinely appreciate it. Enjoy the rest of the seminar on the show.
Good afternoon and welcome to today's Giant Health Conference session supported by Humanity, as we are going to talk about extending Healthspan in the age of digital health, AI and COVID-19. We've got one hell of an agenda lined up for you over the next couple of days. And so I'm going to be talking through what we have lined up today in conference room 1. And then I'll hand over to my partner in crime, who will tell you about day 2. So just in case you're wondering who we are, so I'm Pete.
I'm Mike.
And we're the co-founders of Humanity. And we're going to be taking care of you guys this afternoon, this evening, and throughout tomorrow afternoon and tomorrow evening as well. So thanks for tuning in and enjoy the show. So first up, day 1, it starts pretty much straight after we finish talking. We're going to give you guys an introduction into the subject of extending Healthspan. So we're going to kick things off, and then we're going to jump straight into an opening panel or conversation with none other than the legendary Aubrey de Grey, the founder of SENS, who many of us regard as really the kind of founding father of the aging science movement. That will be followed by another session, which Mike will be partaking in, which is the Biomarkers of Aging Part 1, looking at the pharmaceutical longevity interventions. That includes Kristen Fortney, the founder of BioAge, which is an Andreessen Horowitz-backed tech startup, Pete Fedichev, who's the co-founder of Geer, and none other than Aubrey de Grey once again. We then have a follow-on session talking about the early detection and prevention of cognitive decline. So you'll be learning about how medical experts, researchers, AI and novel technologies are joining forces to help empower and reduce the risk of dementia. That will be led by Sylvia Piquet, COO and co-founder of SharpTX, Ivan Koichev, who's the consultant neuropsychiatrist at Oxford University Hospitals NHS Foundations Trust, and Rhoda Au, who we're delighted to have part of that session, who's also advising us at Humanity. She's the director of neuropsychology at Framingham Heart Study. Then we have a third session, the Biomarkers of Aging Part 2, where we're going to be looking at the usage of wearables and digital biomarkers to improve Healthspan. So if you're interested in understanding how they can be used to predict disease and mortality risk, this is a session for you. That will be joined by Christine Lemp, who's the co-founder and co-CEO of eHealth. Peter Fedichev from Geer will be joining that one again. Peter Joshi, who's our Chief Scientific Officer at Humanity, and Thomas Olivier, who is the founder and CEO of Omnos. We then have the fourth session of the day, which is biohacking. Is it a niche market or is it the new norm? Maybe this is the start of a big mass market opportunity. Who knows? That will be led by none other than Emilian Popper, who's the co-founder and CEO of Elara Health. Edward de Wilde, who's the founder of Live Healthy, and Nord Code, who's also a coach and biohacker. Timu Arena, who's a founder and chairman of the Biohacker Center, a speaker and futurist and even author. And then Sim Land, who is the founder of Simland and is also an author and biohacker. I'll be then rounding up the day with the notes from the day and just the highlights and just teeing you up for day 2.
So I think it's a good thing to note is that each of these subjects that we're touching on, we're really lucky to have the absolute, worldwide expert on it or experts on it when we're talking about it. So that's the real treat that we have in store. So we're going to start day 2. You'll have me and Pete give you the welcome address. Then we're going to dive right into the market. How big is this market? And so we have the utmost expert on this, Andrew J. Scott, who's a professor at London Business School. He's basically going to tell you why this longevity is the next $1 trillion market. Then we're going to dive straight into a panel led by one of our great friends, Tina Woods. And so it's going to be healthy longevity for all. We're going to talk through all the points around this, the equality points, the delivery points, all the nitty gritty of this. Tina Woods is a social entrepreneur. She's the author of Preventative Health healthy longevity in the open health data AI. You got Keith Comnato, who's been a good friend for a long time, runs Lifespan.io, one of the biggest evangelists for the space. We got Adrian Berg, who's the director of the Cataly's Institute. And we have Tonu Escu, who's a professor of human genomics and one of the directors at the Estonian Biobank, which is kind of key to a lot of the research that's going on. And you got yours truly rounding out to that panel. Then at 6 p.m., we're going to go into how the coming age of longevity will change everything. And we have an amazing person who's really turned on a lot of people to this space over the years, Sonia Arison. And then we're going to go 6:30, we're going to jump straight into Smart Health at the Dawn of a New Healthcare Architecture by Thomas Olivier, who, as Pete mentioned, is the founder and CEO of Omnos. At 7, we're going to go into the path to preventative genomics by an amazing person who hasn't just talked the talk, but has actually walked the walk and brought genomics to tens of thousands of people and shown the best practice around that, Robert Green. He's a professor of medicine at Harvard Medical School. And then at 7:30, we're going to jump into bringing healthy breakthroughs direct to consumers, because this is what it's all about, right? Is bringing all these breakthroughs, actually getting it to people and saving lives. That's going to be led by Robert Green. And we also have, so really, top people on that. And we have Sanjay Pingle, who's the CEO of PWN, who's bringing a lot of things direct to consumer in the States. You have Neil Ward, who leads Illumina here in the UK, who's one of the biggest, genetic sequencing machine makers. And you got our very own Pete Ward talking about what we're doing with humanity and bringing all these breakthroughs directly to people. And then rounding out the day, we have 8:15, starting with session 5, investing in health, because all of this needs investment. And as you heard at the beginning of the day, Andrew Scott saying what a massive industry this is going to be. And so who are the investors that are looking and investing in this industry now? You have Julia Hawkins, who's an amazing London-based partner at Local Globe, who's leading that panel. You got Dr. Andy Richards, OBE. He's a founding member of the Cambridge Angels, which does a ton of investment into early stage startups. We have James Wise, one of the top health investors at Balderson Capital. And you got Pam Garside, who's the co-chair of the Cambridge Health Network. And you got Andrew Fider, who's the partner at Albion VC. So pretty stacked panel on that one.
We actually also have Ben Merrill joining that panel as well, Mike. So it's going to be a really...
Oh, wow. we've packed the hell out of it. And so, yeah, so then that panel is going to be awesome. And then we'll round out today, basically kind of, what have we learned throughout this amazing 2 days? And then, yeah, that will be that.
So without further ado, it's time to get on with the show. So let's find out if we can extend Healthspan. And thank you so much for joining us. It's going to be a wild ride. Why we're here today is because, frankly, there's been a huge breakthrough in the science. And so all right, well, welcome back, ladies and gentlemen. Again, this is Pete Ward.
I'm Mike.
And we're the co-founders of Humanity. And so we're going to kick things off with our first presentation of the day, which is Extending Healthspan in the Age of Digital Health, AI, and COVID-19, which is the name of the track here at Giant Health. So let's start with the context. Let's set the scene for you. Why we're here today is because, frankly, there's been a huge breakthrough in the science that's leading us to essentially understand what is actually causing us to age and how we can measure it, which is something that wasn't possible just a few years before. And so this breakthrough science really led us to, come up with a new mission for the rest of our careers, which is really to extend the health span of all humanity, as we believe, given our skill set, that we have the opportunity to bring this amazing science and technology to millions of users around the world. So I'll just start by giving you a brief introduction on myself. So I'm Pete Ward, I'm the co-founder and CEO of Humanity. And my backstory is I've always been obsessed with entrepreneurship. Set up a travel social network back in 2002, where we got to 1 million users before Facebook. Managed to sell that in 2016 to lastminute.com group after it became the largest travel social network with 25 million plus users. And I also co-founded an entrepreneurs network called ICE, which has been a huge part of my life over the last 10 years. And actually, Mike used to be my COO and helped us do great things when we were both at Wayne. And of course, we're now great friends and colleagues.
Yep, and I'm Michael Geer, co-founder of Humanity with Pete. So trying to be an astronaut. I basically found myself creating being on the founding team of creating one of the largest dating sites in the world. So learned consumer tech from the ground up, and then went on to become very focused on protecting the internet and anti-censorship and growing Anchor Free and then selling it. And we had about 700 million users around the world.
And so really just to kick things off, Mike was the inspiration for me really in terms of how we came up with the idea for humanity. So Mike, why don't you give a bit of the backstory?
Sure. So as Pete and I just told you, we had this huge success with our consumer tech businesses, but all of a sudden it was around 2010, got hit with the reality of had a few people close to me over those years got late stage cancer. And so even though in our late 20s, basically feeling invincible, then felt completely helpless to do anything for these people and really learned the mantra that if you don't have your health, you don't have anything. And so what that led to is me being struck by that, feeling completely helpless, and basically started to think about, okay, what can I do? I need to start focusing on something here. And so started talking to all the doctors in New York. They were saying, okay, yeah, I was asking them, like, why aren't we just screening everybody for cancer? Why aren't they finding out? Why are they finding out so late? And the only thing that I could get out of that is that, some of these new technologies of like DNA and RNA sequencing would allow us to screen more people and find cancer earlier. So what that led to then was basically going and starting to talking to geneticists. And if you want to show the next slide, started to talk to all these people, and this kind of led me through this progression of going through, meeting amazing people like Kristen Fortney and, all the other people you see on the slide, and starting to see that not just early detection was possible, but these people were working on actually detecting and being able to see this slow progression of loss in the body that then made us susceptible to all these diseases. And so I think it's worth taking a step back and really kind of explaining, why is this so important? Why is aging the thing that we need to all be focused on? And so what happens, this loss of function in the body over time, is that as we get older and as our body loses this function, as you can see from the graph, this is when all these, chronic diseases start, killing us. I think if Pete, if you want to go to the next one, putting this in like real-time contemporary sense, we're seeing that with COVID, it's our loss of function in our body that has made many of us so susceptible and has caused such a tragedy, because people's natural abilities to fight off disease are getting less and less through time. And this is something that we need to first find out how to monitor and then find out how to change.
And so you might be asking, well, what is aging in the first place? Well, there's different definitions of it, but in essence, it's this loss of function in the body that happens over time, hence aging. And there are different ways to quantify that into categories. For example, there's a 7, or if you talk to Aubrey, he'll say there's 7 hallmarks of aging, there's 8 or 9 according to others. We like to whittle it down into these 4 main areas so that it's easier to distill for most people. So the first thing is the body needs to be able to create and produce new cells, create new and differentiated cells such that it can keep the body from functioning properly, its organs and so on. Secondly, it needs to remove non-functional cells or dead cells, such as senescent cells, because that can cause inflammation in the body, which then leads to mutations and problems as well. Thirdly, and this is a big category, but one that sort of captures, I think, a lot of it, which is the body needs to produce the right quantity and quality of proteins. Those proteins signal to the organs and the body what they should do. And so that's something that's super important. And then finally, it needs to be able to remove the metabolic waste buildup, which is why sleep and things like that are important as a way to sort of help the mind and the body rejuvenate through the course of time as well. But it really, to sort of put things into perspective here, because often it's not well understood. If you look at aging in comparison, or if you just look at cancer as a disease example here in terms of risk factors, you'll see here on the left that there are a number of different factors that can cause an increased risk in cancer. However, if you put that against aging, essentially all the stuff you see in color is what you see on the left. But then when you add aging, which is not technically categorized as a disease in and of itself, then you see that actually the biggest cause for age-related diseases is aging itself. And this is a huge, huge cost to society and humanity as a whole. And so this is really, it's quite tragic numbers really, just to put things into perspective, but I think it's really important to highlight this. So first of all, every single day around 100,000 people on this planet are dying every single day. To put that into a sense of over time, that's 36 million people that are dying every year. And they reckon that's going to increase based on the current sort of trajectory to 52 million by 2030. A lot of this is caused by changes in lifestyle, environment, and that's having a precipitous effect. And in terms of financial quantum, this is a huge amount that we are losing to, economic livelihood of humanity as well. Total cost of 47 trillion in the next 20 years. So it's a huge problem, and it's something that we should try to do something about.
So I think whenever you start talking about Healthspan and trying to expand it, it's always important to be very, very clear about what we're talking about. I think what people see with what many are now calling today sick care is that basically when we talk about extending life, we're talking about getting a sick person and then we just keep them alive by artificial means, and basically their sick state just extends. And so that's not what we want. That's not what any of us want, right? What we're talking about with the actually being able to measure your rate of aging and then slow it down is that what you effectively will do is, if you look at the bottom of the graph, you'll actually make that healthy, active, having the fun time of your life, make that very long. And then the end will be just as short as it should be now. And so that's the thing that we need to concentrate on, is that most of society wants to actually, live longer, healthier. And so that's what we're focused on.
So the real question here is, can we extend Healthspan? It's a nice picture of a C. elegans, which is what's often used in the labs to try and see what effect one can have on different species. And really that's a sort of early indication as to what might be possible for humanity.
So the space, why is this different than, most of history where people also, wanted to stop aging? When real scientists and, investors and everybody really started to pay attention, including Google and others, was this kind of breakthrough that happened in Cynthia Kenyon's lab, was that for the first time ever, when she was doing this experiment on C. elegans, a human was able to actually physically change something in another animal and then actually extend its life. And that had never actually occurred before. We had never, we might have seen things in nature that seemed to do that, but we had never actually been able to be the one that intervened and actually extended that life. But there was this curiosity for years, because people would look around, and even though there's so many different, hypotheses, but people would just look at these animals, look at the mouse, the bat, and the naked mole rat, and they're like, okay, these seem like similar animals. These seem like they're the same size. Why is the mouse living 2 or 3 years, and why is the mole rat living an average of 28 years? There must be something mechanical that we can find that is making this difference. And so some of the most amazing stuff that's caught the attention lately is, as Pete kind of touched on, one of the things that we need to do to stay healthy and keep ourselves functioning is we need to clear out these non-functional cells. They're called senescent cells. And so one of the things that's kind of been a breakthrough in the last few years is we've been able to start physically actually doing this with mice, is we've been able to clear the senescent cells and then see what happens. And what happens is they become healthier and they live longer.
So what can we do now, i.e. what's practically feasible for us to start thinking about now rather than way off into the future? Well, it's thanks to these guys, the biobanks, that we're able to really build a framework from which to do a number of things that would otherwise just simply not be possible. These biobanks have been set up all around the world. For example, we have the Estonian biobank, which is one of the leading edge ones. Antonio Escu, who runs the show there, is on one of the panels tomorrow. But also the UK biobank and Genomics England. These are some of the big ones too. And then Haynes in the US. They have been tracking these participants, in some cases for 10, 20, 30, 40 years, and have their health records and different biomarkers, including digital biomarkers, and they're able to actually extrapolate that against real world health outcomes to see what actually happened to these people, who got sick and who died. And really, this is what is now enabling us to build models that allow us to see today how people are aging. And so what we need is a way to measure this rate of aging as well as the biological age, so that we can actually give, humanity a real sense of what's working and what's not. Because once we do that, we can better understand what actions are working for you or people like you, as opposed to simply general population studies, which could work for some, but not for others.
Yeah, I think a very quick way, and this is what we see every day, is you get the study that comes out and says that, red meat is good for you, no, red meat's bad for you. So if you look at this chart, it's basically the list of, all the things that might cause cancer. And then the dots, when you go left to right, are showing the people, the population in the studies that say that wine is good for you, you'll see on the right side, and the ones that say that wine's bad for you, you'll see on the left side. And so what this proves, and then you can all kind of think of it, because every year you hear a different thing, is that it's important to actually monitor yourself. The individual needs to be monitored to see how their rate of aging actually is affected by each of these actions, each of these, nutrition, movements, recovery, all these things that they can do. If we're not monitoring the individual, there's two really bad things that happen. One, you don't know what's actually working for that person, or for yourself for that matter. And the second is that we never actually learn the differences between people and why some people might react differently to other things. We need to do that on a mass scale, and we need to do that, directly to consumer.
All I can say, Mike, is I hope I'm one of the dots on the far left on the wine one, because that's hard to enjoy.
I'm sure we all are, Pete.
And so, yeah, this is what humanity is going to be designed to do. It's going to help you understand what actions are working to slow your aging. And we just wanted to give you a bit of a sneak peek of what's coming, because we're launching it next quarter. As consumer tech entrepreneurs, we recognize that we need to provide a platform that is easy to understand, that users are going to engage with on a daily basis to really move themselves in a positive behavior change direction. And then for us to then use this Waze-like effect to really understand what's working for those who have the slowest rate of aging and the best biological age. So here's a sneak peek of what you can expect when the app is out in the App Store. It will connect to your health. So any device or information that you've shared on the Apple Health system, super powerful. It could be things like your heart rate, your steps, your meditation from services like Calm and Headspace, and as well as your sleep. That will be automatically pulled into the app. You can connect your wearable device so that it's seamless. And then you have this daily humanity score that's a real-time score that, as I mentioned, is a function of your movement, your nutrition, your mind, and recovery. And on the other side of that same coin is really your rate of aging and biological age. So the idea here being, first, let's see where you actually land when it comes to your current rate of aging. And then, more importantly, whether you can slow or even reverse that over the course of time. And so the idea is we help you to actually take action, gamify that experience, make you feel that you're taking a positive step forward. And then when you hit certain thresholds, you can see that you're moving in the right direction. And these are extrapolated against scientifically validated models that measure your aging, which is thanks to those longitudinal data sets that the biobanks have been tracking over many years. So that's it. We're going to start the show off with a bang. Thank you for tuning in, and we look forward to taking you through the rest of the journey. Have a good one. Good evening. Well, I'm delighted to welcome the legendary man that is Dr. Aubrey de Grey, Chief Science Officer of the SENS Foundation and wearing many, many hats. I'm delighted to have you this evening.
Well, thanks for having me.
Yeah, so first of all, how was Thanksgiving? Was it good?
Yeah, perfectly good. Yeah, getting a little chilly here in Silicon Valley, but yeah, the weather's lovely.
Very good to hear that. Well, listen, we're going to have a great chat about whether we can slow or even reverse the aging process. But before we get into that, I'd love to just know, how you're aging.
I'm doing all right, actually. I mean, I am chronologically 57 years old, but I seem to be surviving. I have this very lucky body where I can more or less eat and drink what I like and nothing happens, and I don't even need much exercise. And whenever I have my biological age measured in whatever way, I always come out way younger than I actually am. So I'm like, riding my luck, so to speak.
I think that's one of the most interesting parts of it. Once you can measure your aging, a lot of the preconceived notions of what's causing us to age faster are not necessarily what people think.
There's some truth in that, yes. I mean, people have struggled for many, many years to develop ways to predict how soon somebody is going to start to suffer the progressive chronic conditions of late life. These are called biomarkers of aging, of course. And it's been a very frustrating time. It's changing now with the advent of big data and the ability to look at the whole proteome or metabolome, or of course the epigenome. And we're developing now clocks that are getting to be more useful than what we had before. But of course, there are still some things that we've known for a long time that are still true. It's generally good to have good glucose sensitivity, for example, especially if you have it despite having very low levels of insulin. It's good to have low levels of triglycerides in your blood. It's good to have relatively low blood pressure. There are various physiological parameters, like, for example, gait speed, how fast you walk, grip strength. These things, have stood the test of time as pretty good indicators. But of course, they're only indicators of certain aspects of aging. So we need things that are more comprehensive.
Absolutely. Well, I'm glad you touched on a few really topical subjects. I thought before we delve too much into the specifics, we'd just get a bit of a sense of how you think the macro environment is affecting this subject. People are becoming a lot more health conscious these days because we live in a world of, a mass global pandemic. So what have you seen in terms of any changes to the sort of focus in this particular subject matter?
Yeah, it's definitely been changing. Let me actually answer the question in two ways. One of them, what's been going on over the past maybe 5 years or 10 years before the pandemic, and then secondly, what's happened this year. So I think that basically what's been happening is that the general public have been in this kind of dilemma of, on the one hand, being terribly excited with the advances that are happening in laboratories and clinics that seem to be bringing the defeat of aging closer. But on the other hand, being terribly scared of getting their hopes up and, still wanting to maintain some kind of emotional distance from the whole thing, because they really know that there's still quite some way to go. And so, every little advance that happens, or even every report of something that might be an advance, tends to get a huge amount of press. And that's kind of okay, because it means that experts get to talk to the media and so on, and generally keep improving the level of knowledge and the level of debate. But at the same time, there is still a sense of clinging to this ambivalence and trying to pretend that actually aging doesn't really matter very much, as a kind of way of tricking oneself into not being preoccupied by it, when in fact it matters more than anything else. So, you know, I think what we're seeing is that incremental progress translating into a growth in the number of people who are willing to embrace, you know, to aim high and to dare to dream, shall we say. And of course, over the past 5 years or so, that has started to extend into the private sector, with an increasing number of investors being willing to actually place bets on the possibility of things doing well enough to actually be effective, and obviously therefore to make money. This year, during the pandemic, as you say, people have become more health conscious, and a number of other things have happened. But a lot of this actually has arisen from the fact that COVID-19 is so preferentially damaging to the elderly. I mean, of course, infections in general tend to be affecting the elderly more because the elderly have a compromised immune system.
Yeah, those with comorbidities, or those who are not just chronologically old, but biologically.
You got it, absolutely. But the disparity between the older and the younger populations is particularly extreme in the case of COVID. And I think one thing that we have seen from this is the remarkable fact that the young are willing to put up with these really, you know, extraordinarily onerous restrictions on their life, just in order to protect the elderly. You know, so this kind of tells policymakers and decision makers that there are votes in this, you know, that the elderly do actually matter to the young, which is something that has not necessarily been so obvious until now, because the elderly have this irritating habit of not complaining enough about their own condition. And so, you know, it's been kind of quite difficult to get elected representatives to believe that taxpayers' money should be spent on research to improve the health of the elderly.
Are you actually trying to say, Aubrey, that people are getting a sense of humanity?
That's definitely one way of putting it, yes. And I believe that what we're going to see going forward as we move out of the initial pandemic itself and into a world in which people are focusing their minds on how to prevent the next pandemic, you know, what we're going to see is a willingness to spend a lot more money on research that will rejuvenate the immune systems of the elderly, and what I'm hoping, of course, is rejuvenate the elderly in general, because that's what you need in order to rejuvenate the immune system a lot.
Terrific. Well, let's actually use as a bit of a backstep to rejuvenate our listeners and viewers on actually how you got enthralled into this space in the first place. So what was it that sort of captured your imagination way back when you thought, you know, I think we can do something about this?
So really, the first thing that happened, which was more than 25 years ago now, was that I had a terrifically awful realization. Something that I had not understood, that was a really bad news thing, which was that other people did not think that aging was the world's most important problem and the world's most important thing to work on. I had spent my life until then, until the age of 30 or so, happily getting on with my life doing what I was already good at, which was software, and essentially working on another problem for humanity, the problem of work. In other words, the fact that people have to spend so much of their time doing stuff that they would not do unless they were being paid for it. You know, so I felt that, you know, it would be useful to use my skills in software to work in artificial intelligence research and develop better automation. And I was doing perfectly well at that, happily grinding away at that kind of thing. But then I met and married a biologist, and she was a lot older than me. She was already a senior professor, and through her and the people I was meeting through her, I first of all learned a lot of biology by, you know, just informally over the dinner table and so on. But also I began gradually to realize that these people were just not interested in aging and didn't think it was very important. And I was astonished by this. It just made no sense to me. But eventually I came to terms with it and decided, well, I've got to switch fields because clearly the problem of aging is even more important than the problem of work. And there are just not enough people trying to actually deal with it. So the rest is history kind of thing. It was about 5 years into my switch of career that I kind of realized, had the big eureka moment that was good news, namely a realization of how to go about defeating aging and what the people in the field were missing, which was essentially that repairing the damage of aging is going to be a lot easier than stopping the damage from being created in the first place. And that's kind of become a pretty mainstream concept now, and here we are.
So is that what led you to write your first book that you authored, the Mitochondrial Free Radical Theory of Aging, back in '99?
Well, kind of, yeah. I mean, that was when I was still harmless, when I was working on particular aspects of aging and just trying to understand it better. And that book essentially became my PhD thesis. But it was written for a very expert audience. It was definitely not written for a general audience.
I was going to say, mitochondrial free radical theory of aging doesn't really roll off the tongue, does it?
This is true. And besides, it was also written specifically focusing on one aspect of aging, which was the aspect that I happened to fall into and get seriously in depth into first. But even by the time I was writing that book in '98, I was beginning to realize that mitochondrial mutations were definitely not the be-all and end-all of aging, and that really it had to be viewed as a divide and conquer problem, in which that was one of the components, and other components had to be addressed in parallel. And by the year 2000, I'd kind of put all that together into an understanding of this kind of classification of the types of damage that we need to address.
And so we, of course, now know them as the hallmarks of aging. And some people argue there's 8, some say there's 9. We at Humanity like to whittle it down to 4, just because we think that people find it difficult to understand what mitochondrial dysfunction really means. But are you comfortable with the sort of broad definition of the hallmarks of aging that people refer to today? And maybe you can touch on what they are for the audience, just so they understand.
Sure, yes. So, I mean, one thing it's important to understand is that the differences between different people's classifications are not as significant as they may sound. For example, the Hallmarks of Aging paper that came out in 2013, and which gets so much attention, talked about 9 hallmarks, whereas I only talked about 7. But that's not because the authors in 2013 came across and identified things that I'd overlooked. It was just a different way of doing the subdividing. In fact, to be honest, they overlooked things that I had talked about. So yeah, it's just a different way of saying the same thing, which is that in order to address aging medically, we need to develop a panel of damage repair interventions that are all applied to the same people at the same time. And the classification really is a way of structuring our thoughts and our strategy as researchers to develop, to optimize the speed of this development of these therapies. Essentially, it allows us to identify particular kind of emblematic therapies that can be used as illustrative examples of what needs to be done. And then we can modify those therapies a little bit to address other similar types of damage and end up with a full portfolio of repair therapies that will do the whole job.
And would you say that your thinking on what the most sort of interesting areas to concentrate on has changed? And if so, what particular areas are you mostly focused on now, if you think about the research you're doing for SEND?
Right, yeah, the good news is that no, there have not been any change to speak of. The classification that I put forward nearly 20 years ago now has very much stood the test of time. We haven't had additional types of damage identified which somehow do not fit into the pre-existing classification. And we also haven't had anything happen that shows that the damage repair strategies that we talked about back then are in some way not going to work, and we need to start from scratch and think of something else. And that's, of course, fantastically good news. It constitutes really good evidence, albeit only circumstantial evidence, that we have a pretty good understanding of what aging is, because 20 years is a long time to find nothing out, and therefore it's likely that this will continue to stand the test of time. So of course, we have had surprises, but they've all been good surprises. new techniques, new technologies that have enabled effectively shortcuts that allow things to be done more easily than before. So, for example, CRISPR for gene editing. There were gene editing technologies in existence 20 years ago as well, but they were much more laborious and expensive, and so now we can do things a lot more quickly and easily than we could before.
Exactly. And so when you were getting to the point of co-authoring your next book on ending aging, a much more snappy title, I may add, which was actually a bit of a huge inspiration for me in the early days when I was trying to get my head around this aging damage or rejuvenation sort of way of thinking. And I like the way you use the analogy of the car and how, you know, a car, call it a Chevy or equivalent, and how, you know, we like to do them up and keep them running for many, many years. Have you found that's been a good analogy? Does it still ring true for you in terms of your theory of aging right now?
It is, and it's an extremely good analogy. It helps in a lot of ways. First of all, describing the aging of a car shows that aging is more or less the same thing in the human body or in a living organism as it is in a simple man-made machine. But basically, aging is a phenomenon of physics, not a phenomenon, not an emergent phenomenon of biology like, you know, consciousness or whatever. And the second thing it does is it shows that maintenance works. Damage repair is something that can massively, perhaps indefinitely, extend the fully functioning lifespan of a machine, irrespective of how long that machine was designed to last. You know, the only reason why we only have a small number of cars out there that are more than 100 years old, and most of the cars that were built 100 years ago have long since ceased to be, is because most of us are lazy, and we are happy to replace our cars when they get old, so we only do the amount of maintenance on them that the law requires. But if you happen to be a car that's owned by people who choose to do more comprehensive maintenance, then there you go. And so really the only breakthrough that I had to make 20 years ago in order to put all of this together as a panel of research themes was to identify ways to fix all of the types of damage. Because of course, as with any divide and conquer approach, if you leave something out, then you basically don't get the result. That one thing that you're not fixing can kill you more or less on schedule, however well you fix all the others. So I mean, putting all those things together entailed bringing together research areas that had been developed for other reasons. In fact, some had not even medical reasons. There was one particular area that I stole from environmental decontamination. Turns out to be really important for one aspect of damage repair. But yeah, this is why I perhaps slightly arrogantly call the damage repair approach the common sense approach. It's the approach that we already know works. We just have to make it work for a much more complicated machine.
Indeed, I think that's really well summed up. I don't think I've found a better analogy that's been sort of contributed to the topic. So well done on that. You're also a man of many roles. I know we're benefiting massively as you're a science advisor to humanity. But I mean, just looking at your Wikipedia page, you know, it looks like you really have like 10 people pretending to be Aubrey in the background. So I'd love to learn a little bit more. Maybe you can share with the audience stuff that you're doing for Ajax Therapeutics, because I know that's in the sort of longevity space, quite an interesting company. Maybe you can tell us a little bit about your role there.
Well, so actually, that's a little bit out of date because I haven't worked for Ajax since early this year.
Oh, right. I don't. That's interesting.
Essentially, they changed their business model a bit. They decided to become essentially a technology licensing company, and so they didn't need nearly so many personnel. They let most people go.
Darn you, Wikipedia. So, but what were you doing for them at the time? And maybe it'd be interesting as a sort of segue to the next topic.
Sure, yeah. I mean, so what Ajax work on is, well, essentially a couple of different approaches to rejuvenation, but essentially all around the stem cell space. So one thing that they were able to do was develop a technology called PureStem, which is a really important way to develop lineage-committed stem cells, so adult stem cells that are of high purity. So you have, a very high proportion of the cells are what you want them to be to do a particular job. And this is a very important thing that is very difficult to do in previous existing ways. because if you put in cells into the body that are of the wrong type, then they may very well do the wrong thing. They may, for example, create a type of cancer in the tissue where you put them. So this was a very important thing that they developed, and they're selling that, and they're focusing on developing it for a couple of indications already. The other thing they're interested in is in vivo reprogramming. So this is a very fashionable area right now, but the ways in which other people are doing it, I believe, have a very high probability of being dangerous, of essentially promoting cancer, albeit in a way that is hard to identify quickly because the cancer will take a long time to become therapeutically detectable. And so the technology that Ajax are working on is essentially using different genes to stimulate rejuvenation, which may, again, this is still speculation to some extent, but it may very well be a lot better at avoiding this cancer side effect.
It's interesting because when Mike was bringing me into this space, he was mentioning how he'd meet some of the top researchers in the Valley who, one of which was a stem cell researcher, and how, he was enthralled by the fact that they may have got their grant for cancer or cardiovascular disease, but what they were actually working on on the benches was how to, actually not lose this loss of function in the stem cell cycles, the degradation of that, whether it be the creation of the quality or quantity of differentiated cells. And so idea being, if you can keep that maintenance of that process to be effective, then downstream, all of these end state diseases that get us in the end are the things that can actually essentially be prevented. So this sort of philosophical approach to any area that we're working on the function of the body. And do you think that's where the research and the funding is starting to go? And are you seeing some of that shift, in sort of the conversations and the partnerships that you're having?
So a lot of it is semantic, of course. The distinction you're describing there is one that, the difference between what people write in their grant applications, or for that matter, in their pitch decks, versus what they actually do. And of course, it does make sense up to a point, because there is plenty of money to be made and plenty of suffering to be alleviated just by addressing a particular so-called disease of aging. In other words, a particular condition that some subset of people get just because they're accumulating such and such a type of damage a little bit faster than others. And it can go beyond aging, of course. You can have early onset conditions that are caused typically by congenital problems, by having some gene that's not working, and that greatly accelerates the accumulation of a particular type of damage. Many of the companies in this space are focusing on those kinds of diseases first, just as a way to get their foot in the door in terms of revenue, and eventually, thereafter expand to the more general situation in aging. That makes perfect sense, and I'm very happy with that. But in terms of the actual research that's being done, I don't think there's any sign that there's going to be some kind of emphasis on a single type of damage as the most important one. These types of damage have an enormous amount of bidirectional crosstalk. They influence each other. We're going to have to address them all in a very much a portfolio approach, a diversified panel of interventions. And that applies at the commercial level as well. So, for example, there are now some quite successful companies which work as holding companies that have have controlling stakes in a bunch of small startups, looking at a wide range of different types of damage and how to repair them. So that kind of diversifies one's portfolio in the investment sense and also in the medical sense.
And so you mentioned in your former life, you were a bit of a sort of machine learning expert, or knowing how to apply the software principles to biological problems, which proved to be useful in your second life. So what do you think of the advent of machine learning, AI, and all of the data science that we're seeing an explosion of in the last few years? Has that greatly contributed to the acceleration of discoveries in this space, do you feel?
It's extraordinary, isn't it? I mean, when I was working in artificial intelligence, this was way before the era that we have today of machine learning using neural networks and the systems that have been developed by DeepMind and other groups like that. I was working on the symbolic side of things, trying to actually formalize logic in a way that could be useful, which is an area that at that time was thought to be the only way to go. Neural nets had basically, almost everybody had given up on them. And it was only when we got to be able to work with very much larger amounts of data because of increased computing power that it became evident that the neural net approach was much more powerful than people had thought. Actually, it's interesting that the person who runs DeepMind, Demi Hassabis, was a friend of mine from way back then. We were at Cambridge a few years apart, and so that's how we knew each other. We don't really have any chance to keep in touch anymore. We're both too busy, I guess. But in terms of the application to medicine, yeah, I mean, it's incredibly important already. There are a number of very successful companies, such as in silico medicine. There's a company in the UK called Nuchido, which is doing some very interesting and innovative variations on the machine learning theme in this space. And the goal here, of course, is very multifaceted. There's the development of new drugs, identification of new chemical structures that may have particular effects. There's also very important work being done on the repurposing of existing drugs that may not have actually had their full potential identified in the traditional drug discovery process that may have gone on in the past. So yes, there's masses and masses that can be done here.
And it's interesting because if you look at it from the point of view of monitoring your aging, the data on this is relatively sparse. If you look at the market today, we've been very blessed to have these biobanks that had, these institutions or governments had the foresight to set up many years back, and so we now have some inkling of what's causing us to get sick or die, but we're only really just scraping the surface. Do you think that having a sort of more broader populace of people of diverse backgrounds being monitored for their aging would be help us to accelerate in the discovery process of what's causing us to age?
I cannot overstate how much that is true. I mean, at the moment, you're quite right. We are benefiting enormously from the foresight of researchers in the distant past who set up these longitudinal studies, which now have data on individuals over decades of their lives. But of course, the quality of sampling, the quality of analysis of these things has improved over time. So there's an enormous amount more that we need. And one dimension of this is critically important is diversity, not only in terms of age and gender and lifestyle and diet, but also in terms of medication. Of course, what we want is to be able to have some kind of way to use this data, this large amount of data, to predict quickly whether a drug is going to work, rather than having to wait however long it takes before someone gets sick or doesn't get sick, as the case may be. And that means that one needs to have some kind of markers which we believe are robust, even though naturally those markers have been developed by looking at people who did not get the drug that doesn't yet exist because it didn't yet exist. And so, yes, we need to take large amounts of data from people who have had lots of different types of medical intervention, including medical interventions that didn't work, and put all that data together and figure out which actual markers of, candidate markers of aging appear to actually reflect what's really going to happen in the future in this very diverse range of scenarios.
I know we've got a few sessions later on in the track talking about the biomarkers of aging and the pharmaceutical impact, as well as the consumer and digital side. So hopefully you'll tune in and partake a little bit in those. But I'd just like to switch gears a little bit, maybe just to sort of shake things up, get the audience a little bit more tuned into what they could do really to contribute to this cause. So if there was like a few ideas that you could perhaps sort of seed into the ether that could lead into the next unicorn business or impact oriented platform, what kind of things would you kind of recommend people start thinking about?
So I don't want to give only one answer to that, because there's quite a lot of things that need to be done, quite a lot of areas in which people can make a difference. And of course, different people can make a difference in different areas depending on their own circumstances, whether they're scientists or entrepreneurs or investors or politicians or whatever. So first, let me talk about the research end of things. So a lot of people may feel, well, it looks like the industry is taking off, the private sector, investors are getting involved, so money is no longer a problem, and therefore I don't need to support this thing financially. I want to make sure that everybody understands that the money that's coming in from the private sector is very unevenly distributed. There are some areas of damage repair and rejuvenation which are indeed very successfully moving into the private sector in a variety of startup companies that are getting well funded to move forward through clinical trials and so on. But there are other areas that are just a little bit less far along the path of proof of concept that investors, even the more courageous angel investor types, do not yet believe are investable. And those things are still being funded very inadequately because they're only being funded by philanthropy. And the fact is that donors tend to write smaller checks than investors do. So organizations like Sense Research Foundation, which is a charity, we are not anywhere near to being able to kind of declare victory and shut up shop. I'm afraid that there is still very much a dire need for more philanthropic support for all of this. Second thing I want to say is about the situation with regard to public policy. So, of course, I have not spent much of my time over the years trying to influence public policy. And the reason I haven't is because I understand that elected representatives really only have one goal in life, which is to get re-elected. And therefore, that public policy does not act independently of public opinion. It follows public opinion. Therefore, I've focused on influencing public opinion and getting on the television a lot and such like. And that, of course, has incrementally worked. But public policy needs to be responsive. Sure that it needs to respond to public opinion, but it needs to respond rapidly. And that often is only possible if there has been a bit of thinking in advance, a bit of anticipation of shifts in public opinion. And at this point, we're not really seeing enough of that. In fact, we're not seeing nearly enough of it. So anyone who has decision-making or policy-making power, or who has influence over people who do, and that means quite a lot of people who will be seeing this talk, you guys need to get out there and get the people who have the purse strings and have the influence to, what I like to say, anticipate the anticipation. In other words, to get ready for the point where not these therapies arrive, but rather these therapies become sufficiently foreseeable that the general public accepts that they are coming. When that happens, most people are going to suddenly switch from the pessimistic fatalist mindset of thinking they're only going to stay healthy and live as long as their parents do, or maybe longer, into a completely different mindset of thinking they're probably never going to get sick just because they're old. And that will happen more or less overnight. And it's going to have enormous impact on what people want to spend money on, what kind of life insurance or health insurance they want, what kind of inheritance arrangements or pension plans. And, people had better be ready to service that changed situation. It's really, it's very difficult for me to persuade people that they need to actually do any planning for this, but it's absolutely vital.
It's interesting, isn't it? Because if you're an investor and you're thinking about what is the market opportunity of the possibility of slowing or reversing aging, well, who do you think in the whole world would be interested in that product or service? Pretty much everyone, I think.
The question is, who would not be interested? That's right. I mean, what we can say is that the therapies that are going to work most and work best are going to be rejuvenation therapies, which by definition are not really going to be of interest to the young. They're going to be of interest to people who are middle-aged or older. But hey, that's still a hell of a lot of people, and a rapidly increasing number of people. So this will, without any doubt, be the biggest industry of all time. By a big distance, it will totally dwarf the .com boom.
So we've got Andrew J. Scott talking about the longevity industry and questioning, is it the next $1 trillion industry? I know Jim Mellon talks a lot about this, and and is a big believer and investor in the space. But interestingly, I think it's only just at that inflection point where you look at it from a health tech, life sciences point of view. A lot of people still don't understand, I think, the essence of it. So it's really like those who are tuning in are starting to see the potential. But the thing that really struck me from what Andrew J. Scott was saying in his research as an economist is that it struck a chord. I mean, he's had 600,000 people wrote his book, on aging or the longevity industry, which shows that the consumers are really enthralled by this subject. So I think you've really caught a wave at the very beginning. So I guess you said the research, you said systemic change, policy, which is driven by consumer demand. Is there anything else that you're seeing that's of interest?
Well, yeah, I mean, really, I think anticipating the anticipation applies in many sectors of society. So it certainly applies for investors. Every investor knows that for whatever level of comfort they have of risk, they need to be paying attention to when to get in, how early, whether to work with things that are already fashionable or to work with things that are not yet fashionable, and just get good advice both on the technical side and pick good teams. And that actually is the biggest thing that I wanted to mention in addition to what I said already. There are many, many people out there who are looking at what's happening and wondering whether they can make a difference and not seeing how they can make a difference. And many of those people are wrong. They can make much more of a difference than they may think they can. One of the biggest examples of that is people who have business expertise. Maybe they're not particularly trained in biology, but they have a bit of understanding of how to understand technical things, but they have business expertise and experience. In the rejuvenation world right now, there is a large amount of technical information out there with scientists who are really good at the science, but who have no idea how to run a business. And they see that investors are piling in, so they create some kind of startup company and they try and go out to investors. And the investors, not being smart investors, they realize that actually, even though the technology may be good, there's no way that the company is going to work because it doesn't have the right kind of business expertise. So I am desperately searching for people who do have business expertise and who are willing and eager to come in and essentially partner with scientists to form a team that is actually worthy of seed investment and can take the technology forward to the point where it ceases to be my problem because it's getting well funded and moving forward properly.
I think that's great, and I think if those who are watching and listening at home, have that expertise and they want to make an impact, sounds like they should be tuning in to people like yourself to see how they can help.
Well, right. I mean, of course, I'm the least entrepreneurial person you'll ever meet, and I'm the chief science officer of a non-profit. But because I've been prominent in this field for a long time, I do have the world's biggest network in this thing. So anyone who writes to me, whether you're an investor, whether you're a potential entrepreneur, whether you're a scientist, whether you're a donor, whatever, I can always tell you how to make the most difference. I can put you in touch with the right people. I can, that's what I do.
Be careful what you wish for. You might be getting inundation of requests after this talk, Aubrey, but that's obviously good for everyone to know. Now, one of the things that you're particularly famous for sort of sharing in your various public broadcasts and it's very prevalent in the social channels, is the fact that you believe that the person who's going to live to 1,000 is alive today. Do you want to maybe just talk a little bit about your thoughts on that?
Yeah, it's been a bit of a double-edged sword over the years. So, I mean, it's been completely obvious to me since I was a kid that, longevity is a side effect of health. And I don't work on longevity. I don't work on longevity at all. I work on keeping people healthy, however long ago they were born. And yeah, I mean, most people die from being sick, which means that if you're not getting sick, your chances of dying anytime soon are, of course, diminished. So, of course, yes, there will be this longevity side effect. And I naively, 20 odd years ago, was asked, how long are people going to live who are born in, I think the first person who asked me this asked the question, how long will people live on average who are born in the year 2100?
Yes.
And I said, well, okay, obviously there's a very good chance that aging will no longer exist, that people will stay healthy, and the only causes of death will be things that are not related to how long ago you were born. And so I came up with a number of, I think, 5,000. And it was completely astonishing to me how surprising this was to everybody. Because people just had not thought through the mathematical consequences of rejuvenation. They certainly hadn't thought of the concept of longevity escape velocity that I put forward during, I think, first in 2003 or 4, which is essentially just to say that we don't need to get perfect rejuvenation in place in order to get the longevity consequences as if we did have perfect rejuvenation. We can essentially bootstrap our way and stay one step ahead of the problem. And, so this is why I think that it's very likely that the first person to live to 1,000 indeed is already alive today, or indeed probably already 50 today. It's like, it's still the case, even though the idea of rejuvenation has now become completely mainstream within the expert community studying the biology of aging. Still, almost all of my colleagues run away very fast whenever they hear about longevity escape velocity. Because it's just so politically incendiary. People who are, thinking and fixated on the lifespan, the longevity consequences, and they just forget about the health aspect. Those people just don't want to hear things like this. And that's a real problem.
Well, that's interesting, because in our research, we found that from a consumer or humanity perspective, people often feel helpless when it comes to aging. They just assume it's a foregone conclusion. There's no point worrying about it because we can't change it. So therefore, let's not think about it. And therefore, no one thinks about how they can solve the problem. Whereas that seems to be shifting.
And we have to,
yeah.
Well, that's really, it is shifting, but it's not shifting nearly fast enough. And we have to ask ourselves, how did this come to be in the first place? And to be honest, I've got to say, it's the fault of the scientists, who were too short-termist, too cowardly, and who just, were more focused on making sure that they didn't get accused of saying irresponsible things to the public, because that would harm their chances of getting their next grant application funded. It's just like, and all the balkanization that's happened, the emphasis on the idea that there is some kind of real biological meaningful difference between the diseases of old age on the one hand and aging itself on the other hand. This is completely nonsensical from a biological perspective, but it helps people to bring money in the door in the near term, a little bit of money, not nearly enough. It's like, it's been enormously damaging. It's slowed things down hugely. And yet, it's still very difficult to get people to move away from that, at least in what they say publicly, simply because the system is set up in such a way that in the near term, scientists benefit from that balkanization.
But to your point, I think this, let's call it taboo, is turned into, I think, something that is much more of a curiosity. I think the moment the belief that something is possible to slow and reverse aging exists, is the moment the floodgates can really open. And so if we're coming back to the subject of the conversation, which is, Aubrey, can we slow or even reverse aging? What would you answer to that?
I'm quite sure that in the relatively near future, we will be able to reverse aging. I don't think we should even talk about slowing aging as the same kind of thing. Slowing aging is something that we may be able to do very soon in a very modest way, to a very modest extent. But the therapies that will reverse aging will actually completely overtake and overshadow the ones that slightly slow aging. They will work in completely different ways by repairing damage rather than, if you like, making the body run more cleanly. And the main purpose of therapies that slow aging right now is to help as many people as possible to essentially make the cuts, to bridge until we get the real McCoy, so to speak. It's undoubtedly going to be possible, just as it's already possible for cars and airplanes and other man-made machines.
Indeed. Well, with that, Aubrey, I'd like to thank you for taking the time to have a conversation with me this evening. I think that you've set the scene very well for what
very modest way, to a very modest extent.
With that, I thank you.
Thank you.
Welcome, everyone. This is the first part of the biomarker talks. We're going to talk about longevity therapeutics in this one. I'm Michael Geer. I'll try not to introduce myself too long in every single time that I speak today, but yeah, so I'm the co-founder of Humanity, and as you know, we're making sure that people have a way to find out what actions they can take on a daily basis to slow their aging, and a way to find out if it's working or not. So I have some amazing people, and I always love doing these things because these are the people that actually inspired me and Pete to start Humanity. So surrounding ourselves with those folks is always fun. Just going the rounds, we can start with Kristen, and then Peter, and then Aubrey, and just give a quick intro, and then we'll get into it.
Hey, Mike, thanks for inviting me. It's fun to be here. So I'm the co-founder and CEO of BioAge, and we're a company that discovers and develops drugs to treat aging and age-related diseases. And should I go now into the details, or just, you know?
No, yeah, we'll circle back around, and then, yeah. Cool, awesome, thank you.
Well, my name is Peter Fedyshev. I was trained as a physicist, but ended up fascinated with aging. So we formed a company to solve aging, and we're doing well. Thank you very much.
Nice. I always love that, that there's a lot of physicists in our space. It seems like one of the best backgrounds to have. Cool. Aubrey?
Yeah, so I'm Aubrey de Grey. I was trained as a computer scientist, actually, but I became a biologist in my 30s. And I am the Chief Science Officer of Sense Research Foundation, which is a biomedical research charity focused on developing rejuvenation therapies. We focus especially on the early stage research that needs to be done on the most challenging and most difficult types of damage that accumulate in the body, and figuring out how to repair them. And we're a non-profit, a charity based in Silicon Valley, but our business model effectively is to spin out project as startup companies. We've done that half a dozen times now, so that they can move forward through clinical trials and eventually to the clinic.
Nice, thanks. Yeah, and Kristen and Aubrey, you'll see that I'm representing the Valley by showing up to important events wearing a hoodie.
Critical.
Cool. Yeah. So Kristen, yeah, would be great to kind of, because I think, you know, everybody on this call and a bunch of people watching will probably understand how it works, but I think, you know, Giant is a really mainstream health event, so we want to make sure that we don't jump ahead to the punchline on these things, and actually kind of give people a holistic view of like, what is the strategy for a company like BioAge that's trying to do a therapeutic for aging?
Yeah, thanks, Mike. Great question. And yeah, before getting into it, I'll add too that, like Peter and Aubrey, I also have a quantitative background in machine learning. So you've got a very data biased group here. And that's actually how we're approaching drug discovery at BioAge, in a very data biased way. So what we do is we want to find out, we set out really like in a data first way to figure out the most important pathways for human longevity. And we were able to partner with some really special cohorts that have been collecting samples from healthy people for decades throughout their entire lives. So that means they started collecting samples from people when they were middle-aged about 50 years ago, and that most of those people have passed now. So they have in the freezer these blood samples that were taken longitudinally throughout their entire lives, but also the health records attached to those blood samples with the entire future history of that person, how long they lived, how healthy they were when they were older, like what was their walking speed, their grip strength, what diseases did they get. So really key health span and also lifespan variables. And it's these data sets that are really core for how we find drug targets. And again, what we do is we just go into those samples, and with modern technologies, we enumerate all the different molecules in there. So 5,000 proteins with proteomics, thousands of metabolites with metabolomics, RNA-seq to get at the transcripts. And you've got a big list of items in each sample, like tens of thousands. And you're asking the question, if I'm looking at a couple of people that are 50 years old, could I tell the difference between someone who's going to live 90 plus versus someone who's only going to live 60? And what pathways might I modulate to go from here to there? How can we all get that sort of really healthy aging trajectory? And then for those pathways, and that's kind of step one, right? It's all data-based. And for those pathways that we think are really promising, we investigate them internally. We've invested a lot in mice. We have like 3,000 aging animals at our facilities in BioAge, where we see if, you know, the drug targets that we look at can improve their frailty, can improve their immune systems. And then for those targets that we really believe, we bring clinical stage molecules forward. So my company just in the last year has made the big transition from being preclinical to clinical stage. We've made our bet on our first 2 aging pathways, and we're initiating our first 2 phase 2 efficacy trials in the first half of next year.
Mm-hmm. And so as you're kind of looking at these targets, is what you're judging just simply if you knock down a particular, are you judging by the thing that you're trying to target, or is it you're looking at, you have some holistic biomarkers and you're like a more specific biomarker? Like how do you mix the two?
Yeah, that's a great question, and it's complex, and I of course glossed over all the details. So question one, right? Like for it to be a pathway that we are interested in, it's got to be a pathway that is changing as you get older. In addition to that, in age-matched people predicts healthy lifespan. But of course that's not enough, right? A lot of those pathways are predictive, but if you intervene in them, you're not going to do a thing, right? They're just sort of like signals of what's happening rather than the target you want to intervene in. Yeah. There's a lot of other things you can do to gain confidence that this is the pathway you want to modify. That includes things like certain types of genetics analyses, but also in vitro and in vivo, you know, intervention experiments.
Mm-hmm. Gotcha. Cool. And I think actually this is probably a good time. Aubrey, you were going to talk about kind of like what makes a good set of biomarkers. What kind of stringent you know, process should we have to head in this direction?
Yeah, it's a really, really big and important subject, and you know, we've still got a long way to go, to be honest. So, I mean, let me first explain why it's such a difficult problem. So, I often emphasize that aging is not a difficult concept to understand. Aging is simply the accumulation in the body of a variety of different types of damage, molecular and cellular changes that occur as a consequence of the body's normal operation, and that the body is set up to tolerate only a certain amount of, which means that late in life, when we exceed that threshold, we start to go downhill, and eventually we die, of course. Now, that definition is really useful for demystifying aging, because it's a definition that could equally be used to define aging of a car or an airplane. But now if we think about the predictive problem, we can see where the difficulty arises. In the case of a car, for example, you can predict how long it's going to be before the doors fall off by looking at how much rust there is. It works. You can actually do that because you know roughly, you know, how rust accumulates and how rapidly it accumulates, and you know how much rust you need before the doors are going to fall off. Fine. The problem with a really complicated machine like the human body is that there are many, many different types of damage that are accumulating, and they interact with each other so that the amount of one type of damage may affect the rate of accumulation of another. And on top of all of that, some of these types of damage, the fundamental things that are accumulating that are eventually problematic, are really hard to actually assay, to measure. So we kind of need to look for proxies of them that are easier to measure. And of course, people have kind of known this for a very long time, for decades and decades, and people have been looking for proxies, ways to actually analyze an individual and predict how long it's going to be before they start to exhibit the chronic progressive conditions of late life that we want to postpone. If we have such a marker, then fantastic, we'll be able to use it to make a quick analysis of whether a new therapy is going to work. If it doesn't change the marker, then it's probably not going to delay chronic progressive conditions. If it does, it is going to delay them. Unfortunately, despite a lot of time and a lot of money, there was no progress really in developing such predictive measures until quite recently. You know, basically people had pretty much given up on it actually. And it only became a thing again as a result of big data, as a result of the ability to measure a large number of different things and extract really sophisticated correlations between them based on machine learning techniques that have only really come to the fore in the past few years. And the types of data that we're talking about here vary a lot. You may, for example, measure thousands of different things in the blood. You may, so that's metabolomics it's called. Then you may measure, tens of thousands even of different proteins in different cells, for example, proteomics. You may measure the modifications that the cells make to their DNA. This is called epigenomics. Lots of different things you can look at. And that's all great. But still, there's another problem, which is that even if you can take all these things and measure a lot of correlations, you are only doing it on people whose data you have, right? Now, that turns out to be a big problem, a big limitation in two different ways. The first way that it is a big limitation is that the data is often not longitudinal. In other words, you are measuring a bunch of people of different ages, but you're only measuring each individual at one age. And that, to some extent, is resolved by by what Kristen mentioned earlier, the fact that there are these studies that have been going on for decades, freezing down samples of blood that we can look at over a large amount of the person's life. But those cohorts are relatively small. We really need a lot more people than that if possible, and we don't have them. That's a problem. The second problem, which is probably even more fundamental, it's a kind of qualitative problem, is that by definition, the people on whom you are measuring stuff in order to develop these markers are people who have not received drugs that don't yet exist, because the drugs don't yet exist, right? And yet, those are precisely the drugs that you want to evaluate on the basis of these markers. So in order to fix that, we really need to have data on people who are very diverse, not only in terms of their age or their gender or their race or their ethnicity or their diet or their lifestyle, but also in terms of what medical interventions they have been receiving. And that includes medicines that are known not to work. We need to be able to identify clocks, markers of aging, predictors of how soon you're going to get sick, that are as robust as we can get, despite the fact that we don't know what they're going to have to measure. So the only way we can really do that is have enormous diversity of what kinds of medical interventions people have received. And I think I've probably said enough to communicate the fact that even now, with the vast amount of data that we're pulling in, it's not nearly enough. The diversity of that those data sets needs to increase a great deal. And I think the only way we're going to do that anytime soon is by a huge coalition and cooperation that needs to exist among groups that don't normally cooperate, competing big pharma companies, things like that. There's a lot of data in vaults out there. And of course, some data is of better quality than others, some data is of more utility than others, but the more data, the better.
Yeah. Yeah. I think that's I was just on a call. I'm over in London now, so on a call talking about the UK government is basically putting out a call for like data governance and suggestions for the public and other organizations what they think should be the next steps. And my whole focus on that call was basically, okay, we need to somehow open privacy preserving AI, kind of federated learning, differential privacy. Basically, you need to get to a way where you can open up these data sets, preserve the privacy and ownership of the data owners, but still model on top of them, because it doesn't seem like, because otherwise you end up with these kind of these big, when you do have a big data deal, it's mostly between large pharma companies, and then that is not something that the rest of us can model on and kind of work off of. Especially if you're talking about, in the context of the conversation today, it was about NHS data and things that are actually, these data sets are made out of public money and are meant for the public good if they could just figure out how to do that in a privacy preserving manner. That does seem like, and one of the reasons we started Humanity and kind of what we're based on is these kind of longitudinal, this paradigm of longitudinal data. And so every time we talk to another group, we're like, we want to find ways to open up more of this, because every person that inspired us actually, you know, most of them had their start of their companies based on the fact that they got access to data and they were able to do some modeling and they're able to, you know, head in a good direction. Yeah, very important point that you raised. Thank you. Peter, it'd be great to hear kind of what Geer's working on and kind of what Kristen did, but you know, give us, you know, what is the strategy? What's the steps towards actually being able to then hand a person a therapeutic that can actually, you know, extend their health span?
Well, thank you. I think everyone here is more or less on the same page. I think we firmly believe that we need to analyze human data. I think it's an underestimated fact, but most of the aging biology studies are done in mice. Mice are living for just about 2 years. It's very hard to learn how not to age from an animal which is essentially exponentially disintegrates and is, you know, explodes in 2 years. Humans are much more robust than that. It's very hard to kill a human, if you believe me on that.
Luckily.
And the character of the aging in humans and mice are very different. So we need to start looking at humans. And as Aubrey said, we should be looking at longitudinal human data, which means that every human needs to be observed many times over the course of life, because otherwise you can end up with very funny, correlations. Like, switching your sex may extend your lifespan by 5 years. This is more or less prohibited along individual trajectory of a human being. So, well, that's just an example. What we're doing is that of course, we're working with all kinds of biobanks. We're looking at every large cross-sectional data set we can find. But on top of that, we're also acquiring longitudinal data sets. Essentially, we are going to hospitals, or we're going to laboratory diagnostic companies. We have all kinds of people who have been measured 2,000 of times in 20 years, for example. And believe me, these people are not very healthy, either physically or mentally. I mean, this is not really a routine procedure. So what I'm calling for here is that we need to find ways how to measure not what we like. Of course, I would like to measure, I don't know, 1 million DNA methylation sites per every cell in my body every second. But this is not going to happen anytime soon. I think what's most important is that we need to learn how to measure what we have, but very frequently, in such a way that eventually there will be a paper published showing individual aging trajectory of a human being. I think that would be quite, a picture and an accomplishment. So we're trying to do that exactly in a way how people simulate financial markets or predict weather. We take a state of a human now and try to write predictive models with AI. And once you have them, I think everyone would agree that if we can combine that with good data sets involving, for example, genetics, as Kristen told us, we can actually generate hypotheses on how to treat aging. And Geer is working exactly on that. So this year we have demonstrated rejuvenation in mice by an experimental therapy. We reduced all markers of biological age in aged animals by a short therapy. And then these animals lived longer and had any measurable biomarker younger. So we believe that eventually this data-driven approach, like Kristen is saying and that other people are doing, will eventually give us therapies which were developed from human data, backported to mice for regulatory reasons and obviously for proof, and then brought back to humans and established biomarker-wise first as working therapies.
Awesome, thank you. So it might be a bit of an open-ended question, but so how far do you think we are threshold-wise? Because I think the clinical trials, people say gold standard, but we all kind of know, like when you make it through the last phase of clinical trial, then you start going out to hundreds of thousands and millions of people, and no one knows what's going to happen, and you got to collect data back from that and see what happens, right? So it's not like you get to a point where you're sure that everybody can, take this thing. How far, just on what you just touched on, Peter, like what do we need, and this is open for anybody to answer, but what do we need to actually get to that FDA kind of, you've made it through phase 3 because you put it through a computer model, basically? Because it sounds funny, but it can't be that far from the same threshold if we get enough of a good model, right? Or am I off? Is it very far off?
Well, I think it's a very important question for everyone here. because I think each of us believes that if we move the biomarkers in the right way, that subject would live longer. But unfortunately, that's not what medics would appreciate. I hope that at the end of the day, if we teach insurance companies to regard well the biomarkers which we are developing and measure, maybe insurance companies will start issuing contracts involving our therapies, maybe even faster than the medics. This is, of course, a little bit, cyberpunk and futuristic, but that's really a big deal. Or otherwise, we'll have in good ways to design medical clinical trials, not biomarkers, but medical clinical trials. But then we will have to essentially narrow our focus to a specific disease. And God knows, maybe for a specific disease, you will have a better drug without curing aging. And that's a big, deal for our field.
Yeah, let me come in on this a little bit, because I believe that there are encouraging signs that this problem may end up being a little easier than it currently seems. The FDA, the Drug Administration and its counterparts around the world, they get a bad rap because it seems like they are slowing down access to medicine and so on. But really, it's not their fault. First of all, they're only doing what the law in their various countries requires. They're just implementing it. But also, they understand the problem. They want to save lives too. And so they do their very best to work with researchers as best they can to come up with something that will actually fly. And I believe one thing that both the FDA and researchers in general need to address, that is really hard to address, is the public attitude to preventative medicine in general. The difficulty, of course, is that when you're not yet sick, you are inherently suspicious about anything experimental because you think it might do you more harm than good. Sure. And it takes a lot to get over that. But there are cases where this has happened. Of course, we have, the big drug family statins that are undoubtedly used preventatively. And the reason they are is because the public gets it. The public understands that high cholesterol is a genuine predictor of how soon you're going to get heart disease. Excuse me. And if you lower cholesterol, that's going to postpone it. Similarly for ACE inhibitors in the case of hypertension. So I think one thing that may end up being a kind of path of least resistance here, in order to speed up the process of clinical trials, especially phase 3 clinical trials for efficacy, is to actually combine biomarkers. In other words, to have the biomarker that the trial uses as its clinical endpoint be something that is actually a predictor rather than the actual sickness thing, whether it's maybe some combination of things like hypertension or insulin levels or cholesterol levels. And the way that you get into those clinical trials in the first place will typically be as a result of the drug or the therapy doing well by these new, more sophisticated, more elaborate metrics like biological clocks. But the acid test is still a quick one, a relatively quick one, because it is these established biomarkers of particular age-related conditions.
Makes sense.
I want to, chime in here too.
Yeah.
I'm pretty bullish on the idea of biomarkers, aging biomarkers in clinical trials. I don't think that's too far off. Mm-hmm. As Aubrey pointed out, right, there already are biomarkers that have been used as approvable endpoints, like cholesterol, for things to prevent disease, like to prevent heart disease. Yep. And importantly, in the development history of those drugs, right, like that wasn't the first indication for the drug, because then you would have had to have this massive trial with thousands of people running for years to see. And, if you have a novel drug, you don't want to dump, hundreds of millions of dollars into its clinical development. You want to do like a short, fast human efficacy first, right? And I guess that's the way that the kind of path that I see for every real aging therapeutic. So eventually first we'll go to sort of one very well-defined, very quick human proof of concept type indication. And this is, by the way, what BioAge is doing for its 2 drugs. They're very specific diseases first, but then you can expand the indication over time, just as with statins. So the first part of that path where biomarkers become important is really right at the beginning, right? Because next year we're going to run this trial. It's going to be for a particular disease. There will be a primary outcome for the trial that is related to the disease specifically. But I also want to know, is this improving their aging, right? And that's really more a biomarker in the clinic as a research question. Because of course, you're allowed to do anything you like as secondary endpoints in your trials. So in our humans that will be taking our drug for several months that are older people, we're going to go to town with proteomics, metabolomics, and see what we can find with all the latest clocks that are out there. So I think that biomarkers are already useful now, because that's going to help convince us that our drug is really impacting aging. And I do see a future where hopefully, like cholesterol, like some of these other, or walking speed, like the biomarker has to predict something that is concrete, something like all-cause mortality, something like likelihood of getting a disease. And I think there will be a path to getting those accepted over time, even for more novel, I would say, multifactorial markers like ones derived from these omics data sets.
Yeah, I hope the same. Yeah, and it seems that way, right? I think so with just a question on, because we use it as an example. So with the statins and like, these expanded, indications, is that real world evidence like RWE coming back and then the pharma companies getting expanded indication? Is that what happened in that particular case, or in cases like that? Or is
Well,
it
a bit of both, right? Because they might go into that already thinking that it has this broad potential, but not wanting to bet the farm on it, right? You've only got so many resources. So let's start with a small indication that's already valuable. We'll learn a little bit about what it's doing, and then we'll sort of expand a little bit beyond that. And at the same time, yes, these, this broader population will be, who are taking the drug for years. And that's where our real world evidence can come in, where you want to look at things like actually preventing future heart disease, because for those kinds of very long outcomes, right? That's not something you really want to do in the context of a trial, ideally,
Yep, makes sense.
But that's the thing, right? Like even in the future where there is, a real aging biomarker, is it going to be true from a clinical development perspective that you want to go into an old population first and look for the movement of that marker? I don't know. Like that might always be a bad idea because we are so diverse. Like I would love it if we could do that first. And but I that's a question I'm interested in.
Yeah, and actually that's I hope it's not like a depressing point, but if you work so hard and Peter works so hard, and each of these companies that are kind of doing the drug discovery and bringing things to market, and then you're able to do something and you're able to help. I mean, it's not depressing because you'll be able to help millions of people, but it won't be applicable to 1 billion people. Like, is that a consideration in the upfront when you start these pipelines, or is it like, let's just help 1 million people and then see what we can do from there, kind of thought process?
I bet all of us here want to help billions of people. But the problem is, I guess, each of these steps is so fraught with risk, right? I mean, like all these things that look awesome in mice, that look awesome in silico, humans surprise you and there's like a negative signal in the clinic. So even from a company perspective, it makes sense first to make, like at BioAge, we want to be a platform company. We want to make lots of different clinical stage bets to take account of this uncertainty, and then double down on the ones that look like they're working. So we just think that is the best way to get to billions as fast as we can.
Yeah, makes sense. Cool. I think, there was a couple kind of things that so when I originally was out in the Valley and was lucky enough to start meeting you guys. The question that I, as the outsider, would always ask when we'd like be in these different meetings would be, okay, what does success look like? What do you think is the, what do we need? We have, things like metformin and different things that were like showing promise, like, okay, but we have it. So what does actual success look like if we already have that? Like, and people didn't really talk in those kind of like far goal, like people taking the intervention kind of, it wasn't much of the conversation. It was more on the kind of the basic science. So a couple of things that, like, as we all know, there was like Greg Fahey and Intervene Immune and Bobby Brook with him as well. And then the one that made the rounds, just to put this in more, popular zeitgeist, the one that seemed to make a lot of rounds lately was the hyperbaric, chamber with I think it was Shai Frati. So basically these treatment and interventions that then, the headline goes out that, aging was reversed. What do you guys think about those? Is it helping kind of move things forward? Would it be better if we had more, a determination of what we really believe is, you know, the best markers of aging, so that we could like definitively say, yes, this happened, yes, this didn't happen. But open to any kind of comments on those.
It's extremely complex and double-edged. I mean, on the one hand, absolutely, when a study comes out and it gets a huge amount of publicity and the publicity is positive, you know, it says, yeah, we know how to reverse aging, that changes public opinion to become more optimistic and more interested and perhaps more willing to support this work and advocate for it and so on, and that's all good. But of course, when the publicity around such things is, you know, in excess by some distance of the significance of the actual study, then it can have a rebound effect of causing things to be more difficult. However, I think within the field that we're in right now, these things happen so often. There's news coming out of different studies so frequently that it forms a kind of big, you know, miasma of kind of intuition that the general public and policymakers and decision makers have on all of this. And that's good and bad again. You know, maybe people feel that the center of gravity of expert opinion is actually moving in a more optimistic direction. And that's certainly what I believe is being seen. But on the other hand, there's also a degree of skepticism that on the one hand is somewhat healthy, and on the other hand is perhaps excessive and overly fatalistic and overly skeptical. So, you know, in a way, it's just the world we have to live in. I think really, you know, what we need to focus on is to make sure that there are no enormous black swans that occur. You know, everyone in the biology of aging, or indeed in any new medical field, always comes back to and refers to what happened in gene therapy just over 20 years ago, when there was just one really bad thing that happened. One guy, one teenager who died of anaphylactic shock in a gene therapy trial, and it set the entire field back by God knows how long. And the number of lives that will have ended up being lost as a result is, well, a lot more than one, shall we put it like that. So, you know, everyone wants to avoid that. I think at this point, the field of rejuvenation is probably pretty secure against such things. But I don't think we need to, I don't think we're in a position to be complacent. We have to keep our eye on the ball to avoid that. And in terms of the, you know, the things that come out every day or every week about this or that new study that may be overhyped, you know, we can just live with that.
Yeah. Yeah, I think the, yeah, I do feel though, and I think we've spoken about this before, Aubrey, yeah, yeah, I'm more on the side of just people's expectations do, you know, lead things. If people expect that you can actually change your rate of aging or, you know, do something about it, that seems like the thing that opens the floodgates even more than, you know, just the expectation of it opens up all the funding, opens up all the demands. Yeah, so I'm always very curious about like one thing we hope to do with humanity is if nothing else, just get that idea out there that first you can see how fast you're aging and you're aging at a different rate than the person next to you. And just that idea alone, hopefully will kind of, you know, help out.
Of course, it's not a black and white binary thing either, because of course the population, the public sit on a spectrum of degrees of optimism, degrees of willingness to dream, you know, to aim high. And so, you know, every incremental step that's made in the direction of improving people's optimism and confidence in all of this will bring a few more people over the fence. And that's what we're trying to do.
Yeah, cool. Talking about that, and you might have actually touched on it, Kristen, and sorry if you did, what's your kind of time scale of going through the pipelines? And obviously, you know, some will be successful, some might not be, but what do you think is going to be the time scale?
You mean in the clinic?
Yep.
Yeah, I mean, so we're very deliberately choosing first disease indications for each of our programs where the phase 2 efficacy trial will be done in a few months, like less than a year. Like, because you know, there's a lot that you can hypothesize, but then the real test is what is it actually doing in older people and taking that initial peek at the data. So we're expecting that our phase 2 trials will take basically less than a year from when they begin, and they'll be beginning in the first half of the next year for both of them. One of them is more related to muscle aging and the other one to immune aging.
Awesome. exciting. And Peter, on your efforts, what's kind of the time scale, and what do you think is like the first thing that might come out?
Well, if you may, I would like to touch on both questions in terms of the public perception and then the timescales, which I believe are actually very much related. I think one of the issues is that, as Kristen is saying, is that, and as I see that, of course, when we plan clinical trials, we will go into very specific population of people with disease, which is somewhat different from people expect when they read papers. Because when somebody reads a paper about an aging study, somebody thinks about being in the age of 40 or 50 with no major strong disease, taking a pill to live longer and happier. In fact, the clinical trials are designed in such a way that we're going specifically to sick people. For example, some designs involve people who are suffering from effects of chemotherapy, having accelerated aging from HIV drugs and stuff like that. So when these things hopefully will reach patients quickly, as Kristen is saying, and I hope it's going to happen, the doctors first will get these drugs into sick people. And it will take another, I mean, if everything is wonderful and proceeds very quickly, it will take another bunch of time before doctors will dare to actually give it to healthy people. And I think, well, as you can see, I'm an optimist here. But nevertheless, we have to plan for the fact that these drugs will reach healthy people to slow down their aging later. And I think that's something which we have to all have in mind. So I think probably we need to rebrand our efforts a little bit, because, the second date on your grave is not really a very, sexy endpoint even to discuss with your potential customers. I think the better way to think about these drugs as drugs which make you younger, more functional, feeling better and happier. So maybe those drugs will get into chemotherapy-induced senescence first, but students will take them before the exams to improve their neuroplasticity. And that's maybe the way how to get, to win hearts and minds of people before actually start discussing aging. So I think first we will have to show that these drugs are going to work in specific diseases. But I think we have to brand ourselves a little bit better to make sure that we are talking about quality of life, not necessarily about the length of life. And that's how you can get more people interested in trying what you're doing, what we're developing here, what we're talking about here.
Yeah, I think, I mean, we specifically speak, mostly always about Healthspan. I know there's the combined hope that, Healthspan leads to lifespan.
It's not only Healthspan. What I'm talking about here is that things which come together with really good anti-aging drugs, like, for example, improvement in your neuroplasticity. Would you buy that? I mean, some people would buy into that even without talking about aging. So I think we should really make the case that good anti-aging drugs actually provide measurable functional improvements right now.
Yeah, makes sense. Cool. I mean, we have a few minutes left. Wanted to kind of open it up if there's anything that we think that we haven't touched on. Also, since this will be a wider kind of audience that will include kind of folks from government through different organizations, is there anything? The people that are out there, what can they do to help with these efforts? Is probably one of the things that we should touch on.
There's one thing I'd like to touch on, which is the diversity of talent within this movement. So as we have moved over the past 5 years or more into a world in which the private sector is so heavily involved in the rejuvenation world, the good news is that there's far more money involved. Investors write bigger checks than donors do, and that's really great news. But there are a lot of ideas out there. Rejuvenation is inherently a divide and conquer approach to aging, where we're fixing different types of damage. So we're going to have a wide variety of different technologies that need to be developed. Those technologies typically come from researchers who are not entrepreneurial and who do not know how to run a company. And whenever an investor talks to them, it's immediately obvious that they don't know how to run a company. So they don't get their money. So we need a lot more people who have the entrepreneurial skills, even if they do not necessarily have the background and the training in biology or in the relevant parts of biology, to partner with scientists who do not have the entrepreneurial skills. There are a few examples of this, at the moment, which are working very successfully. In fact, one of the early people in BioAge, in Kristen's company, is now working as the CEO with a group from Stanford that are, that are bringing in a lot more money than that group could have done without him. So, that's just one example. But there are not nearly enough such people. Because I've been prominent for a long time and I've been able to make the right introductions, I've been able to facilitate such partnerships a few times over the past couple of years, but we need far more of them. So anyone out there who you feel, you're the kind of person who could be the CEO of a company working on some new technology, you will make an enormous difference to the attractiveness of that technology to investors and therefore to the progress of that technology to the clinic.
Yeah, that's a really good thing to touch on. Kristen, you wanted to add something?
Yeah, so just to add to that, to completely agree, right? Like I think if people out there really want to help the field, there's tremendous potential for that. And they should, because there's tremendous potential for aging research. And we're at a kind of special time now, right? I would say only a few clinical stage companies testing hypotheses based on aging mechanisms. And how many companies are there in clinical trials for cancer? Like so many, right? So it's still really just the tip of the iceberg. Like there are so many different pathways that matter for aging that science is being discovered now. A lot of it, I think, has been discovered, or it's at least ready for making a clinical bet. So I think there should be much, much more activity in the sector than there currently is. And it's great to see the way that it's grown in the last 10 years. Actually, to relate it back to biomarkers, right? I think Aubrey mentioned this, but we didn't have any biomarkers like pre-2010, and then came methylomics and omics data sets, and now we have great ones. And that's all been basically in the last decade. So everything is really accelerating right now, but there's still so much potential for growth that can really translate into improved human lives.
Yeah, and I think we used to, Martin and everybody we'd have these like dinners and kind of meetings at the Buck, and basically, it was, and we also did seminars, and it was basically, okay, entrepreneurs that were amazing entrepreneurs, and they sold their big company, and that company sold like sprockets or something that not as exciting as they wanted it to be, but they did well for themselves. Then we'd get them together with the scientists and and together with the investors and be like, hey, now you can make an impact, and now you can use all those skills that you learned selling the sprocket company. You can come over here. So and I think when we talk to people within our kind of entrepreneurial group, it's the people want to talk to us more about our company than the other companies, and it's just because it's an exciting space, right? It's not because me or Pete specifically. It's just like it's an exciting space. So I think that it's a great message to get out there. Is like now's the time to join the mission. For sure.
There is no more interesting problem than this one to solve.
Yeah, and I think unfortunately, like Pete and I got into it because like many of us, we had kind of tragic health events that happened in our families. And you kind of, you learn the adage, if you don't have your health, you don't have anything. And so, why not, kind of apply your skills to this area that, is the most important thing. So yeah, definitely. Well, thank you each so much for joining us at the Giant Health Conference and the Humanities track here. I am sure I'll be talking with each of you, hopefully very often over the next few months. And yeah, thanks again for joining.
Thank you.
Thanks, Mike.
I may want to comment on that. So different biological clocks measure a little bit different things.
Yeah.
So I think that.
But we won't. Yeah, we don't need to answer. Yeah, we'll wait till we go live. But sorry, I was just reading it out.
Okay, just tell us when we're going live.
Yeah, hopefully, I'm hoping Emma will do that. But yeah,
Yep, got it.
Okay, so I believe we're live now. So, Peter, you wanted to comment on well, let's read out the question. So what's the difference in accuracy between clinical biomarkers via your standout panels versus proteomics, metabolomics versus DNA methylation? Peter, did you want to comment on that?
Yes, I can comment on that. So there are different actions. Yes. Should I?
Yeah, please.
Well, different clocks measure different things. We have some clocks that can predict your chronological age, and some of them are exceptionally accurate. Some of them can predict your chronological age within 1 or 2 years accuracy. But that's not exactly what you want. Actually, we want to measure the remaining lifespan. And I believe that the current DNA methylation clock, which is the GRIM age, is presumably, but not exactly known, but I think it's presumably the most accurate biological clock, which measures your remaining lifespan, which is actually the measure of your health.
Awesome. Kristen, did you want to comment?
Yeah, just to add a bit on top of that, I mean, you can already get a lot of predictive power for future health variables, like when you get sick and how long you live from the clinical data alone. But you can do a lot better when you layer on omics data. So you can sort of see the clinical variables plus some more. And I agree with Peter that I think the best published clock out there are these ones based on the methylome, because there's so much data to train on, right? Like there's all these very large cohorts with methylation data to build your algorithms. For what we've seen though, where we've compared like head to head these different omics technologies on like the same cohorts or similar cohorts, be it proteomics, metabolomics, or methylomics, they all tend to do pretty similar. So it's only an intuition at this point, but I would guess there's probably a lot of redundancy in these different omics data sets, and that any one of them can be the basis for a good predictor.
Yeah. And I'll just add on top of that and then I think Peter has another comment. So we just brought on a chief science officer, Peter Joshi at Humanity, and so one of his actual his postdocs, one of their projects was actually going through each of these models. The ones that both kind of Kristen and Peter mentioned, and basically kind of seeing like what they were good at predicting and what they weren't good at predicting. And so I think each of them was an amazing piece of work to show that you could actually predict things. And then I think the work that still remains to be done is really making sure that all these different holes and places that you might not be predicting well are actually covered in the clocks as we go forward. So I think it's an iterative process, but I think we're getting there pretty fast. Peter, you wanted to say something else?
Yes, I also wanted to tell it's like predicting or diagnosing diabetes with markers. You can measure glucose, but it changes all the time. So it's actually very hard to measure your glucose level. But if instead you measure something like glycated hemoglobin, you get much better signal to noise ratio. So what we see in our experiments is that if you measure cellular quantities rather than molecular quantities, like for example, the number of senescent cells in your immune system, you get much better signal to noise. So the question, of course, if all aspects of aging are covered by this kind of measures or not, we still do not know. But I think eventually people will find good cellular rather than molecular measures of aging, which will be much better replicated and more predictive. But that's my personal opinion.
Cool. Aubrey?
Yeah, I was going to kind of say more or less what Peter said, but actually that really brings us on to the next question that's come up in the chat, which precisely discusses the question of whether biomarkers that measure things like the methylome can be as accurate as biomarkers that have the advantage of continuous monitoring. It seems to me that that's kind of the wrong question, that we don't want to be thinking of these things as alternatives, but rather that we can combine those things to get much more than the sum of the parts. by understanding the interaction between things that are able to change rapidly in response to diet or whatever, or exercise, versus things that only change slowly, but when they have changed, they persist.
Awesome. Yeah, thank you. Thank you for each of you for the answer. So the next question we want to touch on, which kind of goes, directly to what we were talking about just before. So what are the most likely pharmaceutical or therapeutic interventions that we can look forward to seeing that we would benefit from within the next 2 to 3 years? So probably put it another way, what do we think are going to be the quickest therapeutics for aging that we see come onto the market and made available?
Well, if it's really the next few years, then that doesn't actually give you time for the full clinical development path. So I guess we'd be constrained to those things that are already in clinical development, but there are a handful of those, right? And looking out to as many as 10 years, I would say that there's a lot of different areas of aging that show promise for targeting and for advancing drugs through the clinic. But the one that's getting the most focus right now, I would say, is senolytics. So Unity Biotechnology is ahead of the game there. They've already done one phase 2 of another phase 1, but there's a whole crop of companies in that space. So something there is going to work, I guess, is probably my biggest bet there.
Mm-hmm. Awesome. Aubrey, did you want to weigh in on that, or Peter as well?
I certainly agree with Kristen that senolytics are way ahead of the game on this. But of course, from the point of view of investors or other people, that it's often important to get in early. I mean, a lot of investors that I speak to these days are actually feeling that insofar as senolytics and other ways to eliminate senescent cells have such momentum already that kind of they ought to actually do something else, so as to get in early in something that hasn't been yet so saturated, so to speak. And the other things that are coming along are things like, for example, using bacterial enzymes to eliminate waste products that accumulate in macular degeneration or in atherosclerosis. This is something that's probably going to go into clinical trials in the next 12 months, in at least a couple of cases. And so, a lot of investors are more interested in that kind of thing. I certainly would expect that within a 10-year time frame, we will see things like that in the clinic and, available.
Awesome. Peter, did you have something to say?
Yeah, well, if the question is stated like what we can have in 2 years, as Kristen said, this is quite constrained on clinical trials. But I would maybe bring somebody's attention to the fact that when people test already approved and even generic compounds in model animals, quite a lot of them extend lifespan. And surprisingly, quite a bunch of them are not senolytics or whatever, apoptotic compounds or even are not caloric restriction mimetics. Quite some of them are antipsychotics and antidepressants. These compounds are reasonably safe, and I think, well, they're not covered by patents, which means nobody cares to do clinical trials or personalize them for life extension. So I think that within a few years, maybe if somebody is gotten sufficiently interested, people can start trying those extremely safe compounds in humans and maybe find cohorts, people who are under stress, depressed, and things like that, which are age-related problem, and maybe get some of these compounds working for quite large cohorts of people and extend their, well, at least happy life.
Yeah, and I think, just to touch on it from the humanity side, I think what we want to get very good at and be kind of our mainstay, and this kind of touches on one of the questions that was asked, is, we want to make it easy for people to see if the thing that they're doing is working, whether that be lifestyle changes or different compounds or whatever it may be. We want, people need a way to actually find out if it's working or not, or they won't continue doing what they're doing. So I think that's part of the equation. And I do agree that we will probably, the more we give that out to the people, the more we'll actually find out that some, safe compounds are already having some effect. And we just need to find out for who and how much.
And I think one other aspect of this that investors should be particularly paying attention to is that the diversity of the field in terms of its technology and in terms of the number of companies that are involved is a huge de-risker in and of itself. it allows investors to take many shots on goal and to believe that this sector is going to succeed in the long run. And we can see that already in the ways that companies are attracting investment. We see this at the level of angel investment and seed investment of private companies. But also, just as a data point, at this moment, I looked up the trajectory of the share price of Unity Biotechnology, which is one of the few public companies in this space, which is a great way to look at this. As we all know, Unity, as Kristen mentioned a moment ago, they published the results of a phase 2 clinical trial a few months ago, which was unsuccessful, and their share price went down by a factor of 4. Now, since that time, they haven't announced any new results, but they've already gone back half of that. They've redoubled their share price. So they were at 12, they went down to 3, they're now back up to 6. That shows that investors are paying attention, investors that are paying attention anyway, are realizing that this sector is here to stay, and that's really important.
Yeah. I'll stay away from saying anything about Unity because I actually own stock, but that might be construed in the wrong way. But I do agree in the space of Senolytics that there's so much promise there. So I do expect to see something great there soon. Well, thank you again, everybody, and appreciate you taking the questions. And on to the next great group.
It's a bad email, or have you not got that far?
Thanks, everyone.
No, I didn't go that far. I'm not sure how to use it.
Okay. If you're all right, just bear with me 1 second. I'm just going to make sure that the other guys are all done, and then I'll be with you in 2 minutes for both of you.
Hello everyone, thanks a lot for joining us today at Giant Health's Extending Healthspan track. We're going to discuss how technology is helping to detect earlier and prevent cognitive decline in dementia with a couple of the best functioning brains in the world, Rhoda Ho and Ivan Koichev. We've all been aware for a long time of diseases like Alzheimer's and other dementia because unfortunately, this is affecting loved ones around us. More than 50% of the public knows someone who has been diagnosed with a form of dementia. We also know that genetic background influences our likelihood to develop dementia. But what we are not all aware of is how much of our future brain health is in our hands. It is never too late to make the right lifestyle choices. To discuss this topic with me today, please let me introduce our big brain experts. Rhoda Ho is professor of anatomy and neurobiology, neurology and epidemiology at Boston University. Wow. She also serves as director of neuropsychology at the Framingham Heart Study. She's using technologies to develop digital cognitive biomarkers with a particular focus on how health technologies enable precision brain health. Ivan Koichev is a consultant neuropsychiatrist at Oxford University and the NHS. With a shared clinical and academic practice, Ivan's research focuses on Alzheimer's disease biomarker development, as well as large-scale recruitment for dementia studies. On my side, I'm COO and co-founder of SharpTX. SharpTX is a London-based digital therapeutics company, and what keeps us awake at night is to enable millions of people to live a happier and healthier life through engaging medical devices for the tracking and improvement of brain health. Without further ado, let's now ask Ivan to tell us more about dementia.
That's great. Thanks very much, Sylvain. Thanks for the kind words. On to the next slide. When we talk about dementia and Alzheimer's disease, I'll probably say a few basic things, but just to make sure that we're on the same page. So Alzheimer's disease is is the most common cause of dementia, and dementia itself is a condition where essentially you're losing nerve cells much quicker than you would like to. And the way that this manifests is through problems with what we call cognition. So cognition is anything that has to do with thinking, memory, in general, mental abilities. And the prototypical syndrome for Alzheimer's disease is difficulty with memory specifically, and that's something that you hear patients and especially their family members recount very often. These people are very good at telling you what's happened a long time ago. So who was their high school girlfriend, or what they studied in university, but they're having real trouble remembering things that happened a day ago or even minutes. So this progressive difficulty in recalling short-term information is an early sign of Alzheimer's disease. But Alzheimer's disease is more than just memory loss. So this is a progressive condition which starts off with the memory problem, but then it gradually tends to, it invariably actually affect other cognitive abilities. So the ability to plan well, the ability to express oneself efficiently. People get disoriented for time and place, and as it becomes more severe, it starts to affect abilities like your motor skills, one's emotional state. People sometimes develop very unusual ideas about what's happening to them in the more severe stages. So it really is quite a complex set of symptoms, but it starts off with generally a few things that are very often difficult to spot from the point of view of the patient or even their carer as something that is abnormal. What is the cause of Alzheimer's disease? There's essentially two findings that come from people examining the brains of people who have passed away with Alzheimer's disease, and they were they essentially have buildups of two proteins, amyloid and tau, and the amyloid essentially clumped together in the neurons, and that's what Alzheimer saw in his patient. And the other protein is called tau, and tau is a very important protein because it helps the neurons keep their shape. But then if and as it happens in a lot of conditions that damage the brain, if this tau protein becomes, as we call, phosphorylated, then essentially it stops being useful in structure, and instead again it starts clumping inside of the neuron, and as we now know, outside of the neurons as well, and essentially it is quite toxic. These two proteins start to spread out through the brain, and the interesting thing is that specifically for the tau protein, we now know that in the typical Alzheimer's disease, we generally know where to expect to find it at the different stages of disease. So it starts off from what's called the medial temporal lobe, so the bit of the brain that sits, if you like, on the inner side of the ears, and that's where structures like the hippocampus is located. That's the structure. I'm sure Rhoda will be able to tell us more if we get to talk about this. But essentially, it's, if you like, the filing station of the brain where each new information is labeled so that it could be found later on. And if this hippocampus formation isn't working well, then new information essentially lacks this contextual information that helps to retrieve it later on. So it starts off in a typical Alzheimer's disease case, it starts off from these medial temporal lobe structures, then it tends to spread towards the inferior temporal lobe, the frontal lobes in these stages 3, stages 4, and then throughout the brain in stages 5 and 6 of what's called the Bragg staging. So the important thing, the takeaway here, is that the tau protein, the really toxic one, tends to spread in a very predictable fashion. And on the next slide is the question that has really been occupying researchers for the past couple of decades, since we realized that actually Alzheimer's disease is a condition which starts up to 25 years before first symptoms. How do we know this? We know this because there's a form of Alzheimer's disease which is familial. So this is the form which starts in people under the age of 65, and we know that it's due to genetic mutations, so very specific damages to the DNA or changes to the DNA. And so what people have been able to do is to recruit groups of people whose parents have Alzheimer's disease, and through genetic testing, we know that unfortunately they're destined to develop Alzheimer's disease roughly at the age of their parents. And what they've done in this study that I'm showing here is they follow them up in a variety of what's called biomarkers, so laboratory measures of the different processes relevant to Alzheimer's disease in these, if you like, future Alzheimer's disease patients. And what they see is a very typical pattern of, firstly, an increase in the deposition of the amyloid protein that we spoke about, the plaques that Alzheimer's disease saw already 20 years before first symptom. There's this movement in amyloid. Then soon after, you start to see increase in the tau protein in the cerebrospinal fluid. That's the green wave, the green line. And then about 10 years before first symptoms, you start to see actually the hippocampal structure in the medial temporal lobe starts to lose its volume, starts to lose tissue. And then also you start to see how the different regions of the brain are not using as much glucose as they normally would. That's the purple line. And then another 2 or 3 years after that, you get to the punctuated line, which is the moment where actually the patient starts experiencing symptoms. The really takeaway message here is that we can now recognize that this process starts decades before first symptoms, which naturally force the change in direction of thinking of the illness.
Thank you, Ivan, for that. So now let's look into the impact of dementia and Alzheimer's to society. So first, it is the biggest health challenge of our time, expected to impact over 150 million people by 2050 with no treatment yet. And even worse, dementia detection is broken. It's long, far too expensive for the system, and it's inaccurate. Practitioners are usually not well equipped or well formed to diagnose and handle pre-dementia and dementia cases. Last, a majority of people referred to dementia assessments are worried well. In the absence of treatment, prevention is therefore critical. The issue is that only a third of people believe that it is possible to reduce their risk of dementia. Current research suggests that at least 30% of dementia cases can be triggered by modifiable risk factors, and that by making the right lifestyle choices in mid to late life, many cases of dementia could be delayed or even avoided. So Ivan, can you please tell us about how dementia is diagnosed today?
Thank you very much, Sylvain. Well, at the moment, essentially, dementia is diagnosed as a syndrome. So a syndrome is, if you like, a constellation of symptoms that occur in a typical fashion. But for all intents and purposes, possible Alzheimer's disease is diagnosed where one has a memory problem plus a deficit in one other cognitive domain. So that could be, for example, language, or it could be how well you plan tasks. Then you have an impact on a daily function. So there's evidence that this cognitive problem starts to impact your daily life. Then the last component is that it lasts for more than 6 months, and then you have dementia. If you have everything else apart from this functional impairment, this impact on daily life, you get what is called mild cognitive impairment. So a condition where you have a cognitive deficit, but actually people still manage to function at a normal level. And that's seen, if you like, as a pre-dementia state, although it's now recognized that a significant proportion of these stay relatively stable. And on the next slide, we have the things that help us to make diagnosis. So it's not just about the interview, but the first thing is we have to determine whether people have a cognitive deficit. Still in the clinic, at least in the UK, we use pen and paper tests like this one here. It's called the Montreal Cognitive Assessment, where you see people, have to do a variety of tasks. You may have heard the outgoing president of the US make a reference to this test in the not too distant past, that he aced it. So he was correct in recognizing the lion, the rhino, and the camel. And the other thing that we use is this brain imaging that you see on the right, which in this case it's an image of a magnetic resonance imaging, so an MRI. And what we're looking for here is loss of tissue. And the structure that we're particularly interested in is this hippocampus, which you can see in the lower left side of the brain. You can, if I had a pointer, I would have shown you. But essentially, the message is that we're looking at a loss of tissue in a very specific manner in this medial temporal lobe structure. And on the next slide is where we're going in the future. So these methods, the cognitive and the MRI, the cognitive testing and the MRI have shown us something. So they're certainly useful day to day, but they don't go far enough in being very specific to Alzheimer's disease. And what we've seen over the past 10 to 15 years is a real very strong advances in a particular biomarker technology called positron emission tomography, where you label compounds which are highly targeted to a particular protein in the brain or a particular molecule. You label them with some radioactive material, then you put people through a scanner, and then these areas where these proteins are targeted to light up. And so there's been two ligands, two of these compounds for positron emission tomography, which have been especially useful for Alzheimer's disease. One is amyloid, which essentially tells you whether people have this very large loading of amyloid in the brain. And the other one, which has been perhaps even more interesting, is the one that shows you where there's high levels of this abnormal tau protein. And this is one study showing how the signal looks like in different patients with Alzheimer's disease, where, for example, on the C panel, you can see this is a tau scan of a typical Alzheimer's disease patient, where this red signal, this tau loading, is in the medial temporal lobe in the hippocampus, while other patients which present with atypical forms of Alzheimer's disease, for example, posterior cortical atrophy, which affects the visual areas, that's the panel A, that's the back of the brain. You can see the signal is very strong there. There are, for example, instances of Alzheimer's disease which affect one's ability to be fluent and to control one's behavior. That, for example, would be panels B and E. You can see that the tau protein is located in a different place, which is extremely exciting for us, because suddenly we can start to see the pathology in the places of the brain where we would expect it to, based on the way that the patient is presenting today. Now, obviously, these are very exciting developments, and they, together with the data that I showed you earlier about the long preclinical course of Alzheimer's disease, open new avenues about us diagnosing Alzheimer's disease earlier and earlier. The obvious problem with this technology is that it's expensive, it's invasive, it requires radiation, and it really relies on a few very highly specialized centers who can administer this. So that is a natural limitation to us bringing this, if you like, at scale.
Thank you, Ivan. So now let's look into the future before we start the discussion with our experts. So to quickly recap, early detection and prevention of cognitive decline are the key to healthy brain aging. There is now growing evidence that dementia biomarker can be seen 5 to 10 years before symptoms arise. And we believe that the public is ready to access such tools in a self-service way. About 85% of people are willing to take a test to figure out where they stand and what they can do about it. But to conclude, and to look into the future briefly, there are sound reasons to believe that technology and research will join forces to help us switch from traditional healthcare to healthy brain aging. Precision medicine, continuous health monitoring, and AI-powered interventions with virtual coaching and digital twins at hand to help trigger the right behavioral changes. A lot is going to happen in the future. So let's now stop here and open the discussion a little bit. So Rhoda, my first question will be to you. Pharma companies have spent hundreds of billions of dollars to find a drug to treat Alzheimer's disease. Why have all trials failed to date?
So I think that the reason we've largely failed is one, because if you look at our methodologies and the kinds of data we collect, we all collect the same data. We all collect, whether it's genetic data, imaging data, and cognitive data, right? And so not shockingly, I think we're consistently finding the same things. The other thing that I think has been very clear, almost from the beginning, certainly from the time that Alzheimer's disease was starting to be studied in a much greater way, which started in the 80s. It's a very heterogeneous disease. We knew that back then, and we know that today. So I think this idea that there's going to be one treatment that's going to, cover sort of this very complex heterogeneous disease, I think is one significant reason why we haven't seen a lot of success to date.
Is it fair to say that because the brain is the most sophisticated in the entire world, Alzheimer's disease and other dementia is one of the most complex conditions to tackle?
Yeah, I think that, at least certainly where I sit, at the Framingham Heart Study, we've taken a lot of the methodologies that we uncovered discoveries related to heart disease and applied it to the brain. And I think you're right. The brain is a much more complicated organ compared to the others, and simply doing what we've done elsewhere and apply it here, I think has not been very effective.
Ivan, my second question is to you. So why should we detect dementia earlier, provided that there is no cure? What is the point?
Yeah, I think that's a reasonable question, and I do get asked that by my patients. I think there's essentially one essentially touches on what we're, and then another one to what you were speaking in your presentation. The first one is that one of the reasons that potentially we may have failed is that maybe we were essentially maybe we already have the drugs to treat Alzheimer's disease, but we weren't testing them at the right patient at the right time. So we know that this process starts up to 20 years ago. We know, as Rhoda says, that there's actually a number of different pathologies when you look into the brains of people who are all subsumed under this category of Alzheimer's disease. So detecting people early and detecting with high specificity what disorder they actually have. Do they have a buildup of amyloid? Do they have tau protein? Do they have what's called TDP43 or something else? And actually selecting the people, highly stratifying people to go into a trial where you're actually testing the compound against the pathology that the person has at a stage where at least we can, at a stage where irreversible damage hasn't already taken place. It holds a real potential for actual tangible change in this disorder. So if you like, the first way to answer the question is because based on our knowledge at the moment, we know that we need to go earlier than than the stage where we've been intervening previously. And the second goes back to the second reason why we should intervene early, we should detect early, goes back to the slide that you showed with all the preventable risk factors, where you show that up to 30%, so 1 in 3 of all dementia cases are preventable. And what that means is that if we detect this preclinical, if you like, vulnerability to dementia at 5 or 10 years, we can look at the preventable risk factors and we can start to address them aggressively. For example, if there's a diabetes or if there's hypertension or something else which we know contributes to Alzheimer's disease, and looking to improve these risk factors. The thinking is obviously this remains to be shown in practice largely, although there is some very encouraging data, and I can speak to that. Yeah, so the thinking is that if we can identify these high risk group and preventable risk factors, we may already have what it takes to at least reduce at least some of the cases for the dementia.
And when it comes to patients today, and the fact that there is no treatment today, what would you say is the price to pay for the anxiety? I mean, no, sorry, you will create anxiety, right? When you tell people you are on the path to dementia. So what good is it for them today? You are.
Well, you see, Sylvain, I think in the past 10 or 15 years, at least in the UK, the stigma around dementia has shifted, and people now, I think, want to be in control and want to have the information, rather perhaps was earlier, where people just didn't want to know. So now people want to essentially, if you like, maintain their independence for as much as possible, and that very often goes through knowing exactly what the diagnosis is and what to expect, rather than hope that whatever problem you have will go away. So obviously, going to a doctor for any reason is anxiety provoking. We can't get away from that. But at the same time, we do know that sometimes we doctors do useful things. So it's not by any means guaranteed. But it's very difficult to know unless you go to see a specialist.
Of course, yeah. Thank you for that. So let's talk about technology and precision medicine for a second, Rhoda. When thinking about at-home passive monitoring, how will wearables, mobile apps, digital therapeutics help solve the challenges of prevention and early detection?
Sure. I think that, one of the things, and this speaks to sort of what Ivan was talking about is, and your question earlier to him, it's, why bother, right? And I think at the end of the day, it's this idea that it just because you have risk for the disease doesn't make it inevitable. And so the idea here is that technology will put that control that Ivan was referring to into the hands of the person to manage their risk. And I think that what we have to remember is that Alzheimer's disease, for instance, and most dementias are insidious in their onset. So right now, where we decide is disease versus not disease is very dependent on the sensitivity of our tools. Now, with digital technologies, we're suddenly in a situation where we can start monitoring our behaviors well within the realm of normal. So we don't have to wait till you go to a doctor and the doctor says, oh, you're on that trajectory. In fact, we can go back earlier and we can start monitoring all sort of risk-related behaviors and outcomes, right? But do it well within that normal range. And so what happens is, instead of waiting to hit some threshold that we call disease symptom, we can now start to focus on this idea of a negative trajectory of change. And if we do that within the normal continuum, and we intervene at that time, we move from a shift on precision medicine to precision health. And that's really what the prevention model is about. It's about not waiting till you qualify for treatment. It's about doing something to prevent you from having to go down the treatment path in the first way. And so, and you touched upon sort of what some of those potential interventions are. I think that technology will also reveal things that we don't know. So there's a lot of things that we presume, but we presume it on very sporadic kinds of measurements. Now with technology and continuous monitoring, we're going to be able to see at a precision level a lot of variability and a lot of the heterogeneity that we talked about that may better define who is on a true risk trajectory versus who isn't. So I think that this is really about shifting the conversation from a precision medicine approach to a precision health.
Precision health, yes.
Yeah.
The US are notoriously ahead of Europe and the rest of the world when it comes to prevention and in technology, at-home trackers. How much of that is true for cognitive health? Do you see in the US regions or technology that are starting to spread in terms of at-home people prevention and monitoring?
Well, I think that certainly what I would say is that these countries are ahead in understanding cognition. So if you look at lots of parts of the world, there's actually no PhD programs in neuropsychology in those countries. So I think it's more of a sort of a knowledge base and an understanding, and it's that lack of awareness that a lot has that we don't see in the US or in the European countries. But I think in terms of knowledge about executing prevention, I would suggest that the COVID situation indicates that we might have the knowledge, we have the know-how of what to prevent, but we're not necessarily the best in actually executing it. So I think that our advantage right now is pretty short-lived. Technology will actually help bridge that gap in capabilities and allow other countries to catch up very rapidly and probably even exceed us.
Ivan, my next question is to you. What are the most promising fields of research in early detection of dementia?
Well, I like to think of, I usually think of three particular areas that have come to light. The neuroimaging that I showed you about, that I showed you a slide about, the blood biomarkers, which have really exploded over the past two or three years, and of course the digital technologies. So the imaging biomarkers are exciting because of the reasons that I showed you earlier. So they actually allow you to see where these proteins that you are concerned about are accumulating in the brain.
15 years before symptoms.
Say again?
15 to 20 years before symptoms.
Well, exactly, yes. So you can actually see the buildup of the protein in the brain. Now, here, perhaps the thing which is very relevant to Alzheimer's disease in particular is that if you remember that tau spread, which was very predictable. So with that tau imaging, we can now, if you like, stage the Alzheimer's disease similar to the way that we stage cancer, in that we can see how far along this network that we know that this tau protein spreads is the deposition in that particular patient, which can again guide what one could expect if you were to put this person through a therapy with a new agent. The second thing that I mentioned are the blood biomarkers. So blood sort of testing for a disease in blood, as you can imagine, Sylvain, is the, if you like, the holy grail of medicine, because we can get blood fairly easily. And it's for a number of conditions, it's the go-to method to actually monitor them. And with the new technologies that have been developed, we can now detect the biomarkers for amyloid, biomarkers for the tau protein, and also a biomarker for the increased neuronal death. So you have the three key components of Alzheimer's disease now being detectable in blood, which is a complete game changer as far as monitoring people at scale is concerned. And I'm sure that large and well-established cohorts like Framingham are looking at this as a way to see to what extent they can detect dementia years before first symptoms. And the third, of course, is the reason why we're here today. Is the value that the digital technology brings to the table. And I really think that it boils down to what Rhoda was talking about, which is the fact that with the wealth of data through passive monitoring, but also through active monitoring, you can actually start to define trajectories, so individual trajectories, what is normal for this person, and then to look for very subtle deviations in that normal, if you like, performance as means to point to them actually being in a preclinical disease.
The negative deviation.
Well, yeah,
that's what I was talking about.
And that is a real sort of departure from the way we practice, medicine and detection of disease states at the moment, because we tend to use, if you like, cutoffs for particular values, which are, if you like, averaged over thousands and thousands of patients. We've decided that a magical number of 8, for example, is what differentiates healthy from unhealthy. And then if you're above that threshold, we look at you. If you're below that threshold, we don't. Which is looking at the value that digital technology brings, if you like, dispenses with this whole method and looks at the individual, collects data over years and years, and looks for very subtle deviations. And that is particularly also, in addition to detecting small change, it also has values for the studies that follow. So bringing that person into a clinical trial where you give him a particular medication, now you're suddenly powered to see essentially effects which you would have missed otherwise, because you know so much about this person. You know what his trajectory is, and then you know that once you've given them the medication, or given them the medication, you're looking for a much smaller change, which essentially decreases the costs of research, no need to enroll hundreds of thousands of people. You can do very elegant trials with much lower numbers. I think these are the three things, and I've spoken for quite a bit, but I'm very excited about the topic. So.
Yeah, you are passionate. That's good. Final words, because we're running out of time. Final point to Rhoda. You will have the final words. Rhoda, where will we be 5 years from now on all these questions? Will we have found a cure for AD?
So I think that we will have found effective treatments for AD, but it depends where along the continuum. I think it's very hard to cure AD once you have pathological damage. So I think that on the one hand, we'll have effective treatments for arresting progression of disease, and I think it will be for subtypes of Alzheimer's disease, not for AD as a whole. And I like to use the cancer model in that respect, where there are many effective treatments at many different stages of many different types of cancer. And I'm an optimist, so I'm rather optimistic that currently we have those in the pipeline. I think, as Yvonne has mentioned before, we probably have some effective treatments. We're just not targeting the right people. So I do think that through precision stratification, we will start to see successes along that way. I think that where we'll be from 5 years from now is really, I think that besides finding ways to effectively intervene to stop progression, I do think that we'll make great strides in prevention. I do think that the concept of digital biomarkers will be much more mainstream and comparable to what we see in terms of blood-based biomarkers. And I think that the impact is that we're going to be much more inclusive in the work that we're doing in the treatment. We're going to be much more global in our ability to do this much more effectively than we are now. I think that we're going to be very data science, AI driven in many of these kinds of solutions. And by having sort of these representative samples all across the world, we'll actually have digital solutions that are truly global in their reach and in their effectiveness. So that's what I see as coming down the pike. I think we're going to see compressions in the timelines in which we will be able to find solutions and treatments. And so I'm very optimistic about where the future is headed and how technology has an important role to play.
Thank you so much, Rhoda and Evan, for this great discussion. It was extremely insightful. I hope everybody enjoyed. Thank you.
Thank you for having me.
Thanks for organizing.
Should we just wait here for now?
I think we may be live, looking at the feed, if I'm not mistaken.
Are there any questions for our lovely speakers? Maybe?
don't think we have anything in the chat that I can see anyway. Rhoda, do you want to tell us perhaps you're an investigator on the Framingham study, which essentially is the longest study into chronic disease. It's been running for over 40 years. Can you tell us what you're doing in the Framingham study around dementia risk?
Sure. Can you hear me all right?
I can.
Okay, good.
Yes, we can hear you fine.
Yeah, so, you know, Framingham, of course, the great thing about Framingham is that we have 72 years worth of history.
Yeah, I think it's pretty unique. I think it's the only, only in the US do you have these sort of longitudinal studies.
Yeah, but so it's kind of hard because we're getting some feedback, so it's like on a delayed thing, so it's really hard to sort of figure out how to respond here. But what I was going to say is that Framingham, so at Framingham, what we've been doing is trying to actually bring some of the technologies into the study. But you know, because we have a 70-year plus history, we have to do it within the longitudinal context of what already exists. And so that's really the challenge of how do you preserve what you've already been doing and then move forward and bringing forward these new opportunities that technology provides. So the balance of Framingham for me is figuring out how I can take what we're already doing, embed technologies on top of that without destroying the longitudinal nature of the study, and then push forward in terms of doing new things without overburdening the participants on top of that.
I see. So have you been able to implement any of the newer technologies that we were talking about? Yes.
Yeah, so we have just started to test some of the smartphone applications that I've been working with. So we've been able to collect a lot of digital voice technologies. I've actually initiated that many years ago, starting in 2005. We have almost 10,000 of these digital voice recordings on people longitudinally, in which some people have now progressed to dementia. We've been using the digital pen in order to capture written responses to traditional tests. And we have thousands of measures or digital pen measures, which allow us to get at much more subtle behaviors. And then more recently, we're starting to deploy a whole digital platform around the cognitive assessment using smartphone applications. And that's just getting underway, where we're going to start monitoring people's cognitive related behaviors on an ongoing basis, about quarterly, in order to see if we can compress the timeline in which we're able to detect subtle cognitive changes that are much better than what we've been able to do typically with our traditional measures, in which we've been measuring them every 4 to 5 years.
Great. And the digital pen technology, I think I've come across that. But what sort of variables are you able to extract that are relevant to brain health?
Sure. Yeah, so in digital pen technology, what's great is the way we've deployed it is from the participant's perspective. They're still using what they think is, more or less a regular pen on paper. It's just that the paper is picking up sort of it's a dot matrix print that's picking up sort of as they move the pen across the paper. And what that's allowed us to do is really to get at item-specific responses where we can track how long it takes a person to answer item by item by item. We can also differentiate now what we call the ink time versus think time. So ink time is when they actually have pen to paper, and we can track again how often they have the pen to paper, but we can also look at think time, which is when they have the pen off the paper. And that sort of allows us to look at changes in decision-making capacity. We can look at, for instance, in the clock drawing test, after they complete the circle of the clock, there's a pause period while they decide what to do next, and we can measure that. So there are decision-making latencies across an entire task that someone's doing that we can now pick that up. And we can do that actually both with the digital pen for written responses and for digital voice with spoken responses.
Yeah, and presumably you're aware of the research which is looking at linguistic richness as a predictors of dementia. I think you know, the study that always gets cited is this nun study, where essentially back in the day when people were applying to become nuns in their 20s, they would write a long written text explaining why they want to go into the convent. And so some researchers found that the richness of the language at the age of 20 predicted the dementia risk going, essentially four years into the 40 or 50 decades into the future. So is that the sort of thing that you can do with the voice recordings?
Yeah, that's exactly the kinds of things. And we've started to do that somewhat. So again, we started in 2005, and we've been able to longitudinally collect this data. And again, people have now progressed to dementia. So now we're able to look, are there voice biomarkers that are reflective of change as people progress from what we consider normal cognitive status into the preclinical and then into the state of dementia. And so, and we've actually done that. I know Christine Lemke is going to be on later. We've done some work with her, and we've worked with a number of other groups that are looking at linguistic biomarkers for dementia, both in terms of audio features as well as linguistics features.
Was there anything that surprised you as a biomarker in voice biomarkers, something that you didn't necessarily expect?
Well, I think that the whole capability of doing this kind of analysis is pretty amazing. It's like a little bit of magic. I mean, I'm just a neuropsychologist, so when my colleagues on the digital signal processing side of this can do this, but I think the most important message, what I would say, is that there's no one measure. This is going to be a profile of different measures, and that profile, it's really about the patterns that we see. And so it won't be one pattern, it'll be a multiple patterns. And I always try to liken this back to the fact that if you ask family members in order to report when they first noticed changes within their family member, they didn't give a bunch of tests to their, and they didn't give the same tests, and they didn't look at the same measures, but they can pick up sort of this profile of change over time. And that's what I think that these digital voice indices will allow us to do in a much more natural way than in the way that we've traditionally done, which is sporadic testing.
Yeah, and presumably you'd use machine learning techniques to tease out these components, or?
Yeah, that's exactly it. We use, we as in my colleagues, not me, use these very advanced analytic capabilities. And that's why I see a lot of our solutions going forward as being data science AI driven.
I think we are out of time, or almost out of time. I'm not sure if we have time for one last question for you, Ivan, but there is one on the chat. It's about the blood biomarkers you referenced for early detection. Question is, do you feel there's a responsible approach to make these assays accessible directly to consumers?
I think that, yeah, can you hear me okay?
Yeah.
Yeah, I think that's a very interesting question. So at the moment, because they're at the stage of development where they're not validated to the extent where they unequivocally are linked to a diagnosis, they're more indicative of a risk state. The current if you like agreement is that they're not they're not sufficiently well characterized to be released directly to consumers. But it's a very rapidly developing field, and I wouldn't be surprised if they're available to clinicians in the relatively short term, and from then on, as we know, things develop quickly in terms of availability to consumers once they're well known in the clinical world. So I would say that in the next 10 to 15 years, I wouldn't be surprised if they reach the consumer market.
Okay, I think it's time. So thank you again for participating and everyone for questions and attention.
Thanks, Ivan. Thanks for organizing.
Thank you.
Thanks, Rhoda.
Thank you.
Hello, this is Peter Joshi. I'm guessing my camera is looking awful, is it? Hi, my name is Peter Joshi. I am the chair for this session that we've entitled Biomarkers for Aging, Using Wearables and Digital Biomarkers to Improve Healthspan. Thomas, could you just give me a nod if I'm coming through, because I'm not 100% sure?
Yes, you are. I can hear you
Brilliant.
fine.
Okay, thank you. Can you see me?
I cannot see you, but
Yeah, there's something going on with my camera. I think you're going to have the benefit of not being cursed with my face. I'll try again in a moment. It's coming up as some big stripe on my screen, which has never happened before. Okay, right. So I guess the challenges of a virtual conference, the opportunities as well. Got a fantastic panel of speakers from all over the world. As well as my Joshi, we have Peter Fedichev, and Thomas Olivier, and I hope Christine Lemke is also going to join us very soon. She is having another sort of technical difficulty, but I did speak to her a moment ago. She is trying to get into this room. Okay, so maybe I can just start with some introductions. Maybe just start with myself. My name's Peter Joshi. I literally joined Humanity formally today as their Chief Scientific Officer. Up until now, I've been working at the University of Edinburgh, where I've really started as a genetic epidemiologist, looking at health and disease, and actually particularly lifespan and more recently Healthspan. I've looked at very large data sets, most obviously UK Biobank, set up a few international collaborations to get up to studies of about 1 million lives. That work, I think, culminated with really finding that the common variants that seem to affect our lifespan are mainly about common diseases. We have had some signals more recently, most obviously the heme pathway that seems to identify generalized aging, but a lot of it seems to be in genetic terms about disease, particularly heart disease, to a lesser extent cancer. I guess the good news for all of us, and what we really, I think, want to get into in this conference, is that interventions seem to have a lot of scope. Less than 10% of the variation in UK lifespan seems to be genetically determined. So it's other things than your genes that are determining how long you live in the great part for most of us. Anyway, more recently, I've been focusing on biomarkers of biological age and chronological age, and trying to understand the commonalities and differences between established aging clocks, things that you may have heard of, the DNA methylation epigenetic clock, proteomic age, and so on and so on. So I turn to Peter Fedichev. Hopefully you can at least see Peter on the screen. I'm sorry you can't see me. Peter's the founder of Geer, who are a biotech startup aiming to hack human aging by applying modern AI machine learning activities alongside good old physics to these huge biomedical data sets we're now able to generate. And they're aiming to quantify and indeed intervene against aging. Geer pioneered and published an application of AI for deep phenotyping in longitudinal data, with the first biomarker of aging from motion data from wearable devices, and established aging phenomenology in both mice and humans, and have enabled them to predict a maximum lifespan in humans, which I might be interested to hear about later if we just got time. There's papers on these currently on bioRxiv. He's hoping to see them published in Nature Comms early next year. Our next panelist is Thomas Olivier. Thomas is a registered nutrigenomics practitioner and was the first to study that basics of individual DNA makeup in that context. Thomas started as a sports scientist advising elite athletes, and quickly realized that helping to test improved diet and lifestyle. He mainly focused on how genetics can influence health, but in 2016 he started GenStart Limited, a platform that allows individuals to upload their data and provide an assessment and personalized recommendations. He also set up the GenStart Academy to train health professionals. Sorry, GenSmart Academy, I mustn't get your brands wrong, Thomas. The GenSmart Academy to train health professionals. If that wasn't enough, he's also written a book, Cracking Your Health, and he's also the CEO and founder of Omnos. Finally, Christine Lemke, who I hope will join us, is the co-founder and co-CEO of eHealth, who measure health in everyday life using data from our daily interactions, phones, wearables, computers, and digital devices. Okay, so the format we're going to take today is I'm going to present a sort of general question and each of our speakers are going to talk a little around that, and then hopefully we'll have some time for Q&A towards the end. So as chair, I had the privilege to ask myself a question. So I really wanted to talk about the challenge of measuring biological age, measuring biomarkers, and understanding interventions in that context. And I'm thinking here that, in essence, we're all believers in an underlying biological age, or perhaps set of biological ages by organ system, that each of us has, that's different from our chronological age. If we're lucky to have aged well, our biological age may be significantly below our chronological age. And we hope that that's going to lead to a better quality of life, less age-related disease, so on and so forth. So one of the challenges in the field clearly is, can we measure that? And the other challenge is, can we change it? Ironically, the two things that I've focused on in the past have particular characteristics in that context and are, broadly speaking, immutable. I focused on the effect of your genes, your DNA that you're inherited at birth and is pretty much the same in every cell in your body, and how that affects your expected age. Key point here, the central dogma of biology, is that there's no reverse causation here, that your biological age does not affect your genes. That has an advantage that we can see clear one direction, perhaps, of aging genes leading to accelerated biological age, and we know the direction is that way. The other focus I've had more recently has been on the chronological clock and trying to train markers of passing of a chronological time. I mean, I think we've all heard of Horvath and Hannum's epigenetic clocks. I think most of you are probably aware that there are many other clocks out there now, and I've been trying to understand, again, in that unidirectional way, how the clock is affecting biology, and that can actually, again, be seen to be just one direction. There's no question that you can change your chronological age by going out for a run or smoking less or eating better. But I think for all of us, the more interesting questions are around interventions and lifestyle. And here the problem, as a classical epidemiologist, would see it is confounding and reverse causality. So we see health outcomes, for example, associating with something that we might think of as an intrinsic biological age. They may be tagged by biomarkers, cholesterol level, albumin level, etc., etc. Indeed, for the purposes of this session, they might be tagged by things that we can monitor using wearable devices, whether on your wrist or your phone in your pocket. But the question is, in my head often, which is cause and which is effect? And we know that actually both are happening most of the time. If you have a poor biological age profile, that is probably harming your health, depending exactly how it's measured. But conversely, poor health can often lead to a reduced biological or a worsened biological age profile. So disentangling that is certainly one of my focuses. Alongside that, I think the sort of things that we're then interested in, obviously, is if we were to change a biomarker, is that going to improve health? Happy to talk about the question and marks around high density HDL cholesterol and LDL cholesterol, but I think it seems very clear that LDL cholesterol is a biomarker of poor biological age, but at the same time, it causes poor health. Whereas HDL, I think there is, at least in my mind, significant doubt as to whether or not it is just a marker of good things rather than good in itself. Although I'm sure cardiologists may take me up on that in a moment. So if my hypothesis were correct, obviously an intervention in both would improve perceived biological age, but only one would improve health outcomes. And how are we going to track that? How can we be sure? How can we be sure our studies are not confounded, for example? Lifestyle is another one where I think we have this reverse causality relationship. People in poor health probably don't eat as well, probably don't feel as up to good exercise patterns. But equally, we know that people who have those poor lifestyle patterns suffer worsened health, we imagine, through that increased biological age. So I'll kind of leave you those thoughts in the context of what we're going to talk about next, and maybe invite Peter Fedichev now to talk to us about how can we use wearable devices to measure aging and apply those findings to identify novel targets for aging therapies and make generalizations between mice and men. Peter.
Well, thank you for the introduction and for the right questions. I think you posed the very right questions, how to actually interpret very large epidemiological studies. How can we be sure that whatever we see is the cause or effect? I think this is the most important question for the coming few years. We take the following approach. We believe that we should start increasingly looking at what is called longitudinal data sets, which means that every person should be observed multiple times along their lifetime. I think there should be a paper in the making somewhere where biomarkers of aging are actually monitored throughout the lifespan of humans. In our company, we call this flow of life. So eventually, I expect there will be a paper with all these lines, connecting the dots from year 1 to year 100 for a bunch of people. So the punch here is that when you have trajectories, you are solving the cause and effect riddle. And this is very important. So that's why we're working obviously with UK Biobank. This is our largest source of very well labeled data. But on top of that, we're acquiring every possible longitudinal data set. So we're working with consumer diagnostic companies, for example. So we're acquiring blood work from people. We have people who have given away their blood for markers up to 20 times in 12 years, for example. They're obviously not very healthy, either mentally or physically. But on top of that, the best signal, I mean, of course, I would want to have DNA methylation in every cell of my body, 100 times per second. But this will never happen in the coming years. So the only signal which actually gives you trajectory is the signal from your wearable device. Think about that. No normal people will ever go to a doctor and give away his blood for blood biomarkers, I don't know, more than 6 times per year if a person is healthy. But if our customer or a user gives us consent and we get access to his health kit, normally we have up to 5 years. I mean, some people have 5 years long tracks of their motion data. And this is really a piece of aging trajectory. So we decided to look at wearable devices, not because they are the best biomarkers. I mean, DNA methylation is probably better. But this is the only continuous biomarker which is sampled at enormous frequency. And we start seeing very interesting things. So essentially, we're building AI which takes a human state now and tries to predict the human state in a few years to come. So this is like weather prediction, good old physics. When you have such a machine, you have a model of a human being. You start seeing obviously interesting things. For example, you can see that people who smoke and quit smoking have their biomarkers of aging going down in a fully reversible way. Some people will hate me for that. But what's best in this approach is that once you have the sequence of biomarkers which characterize the future state of human being, you can go to UK Biobank and you can overlay it with genetics, and bingo, you have the targets and you have the hypotheses which you can actually test in mice. So that's how we work, and I think that's how many people will start working very quickly from now.
Thank you, Peter. And that's, yeah, absolutely. I completely agree with much of that. Okay, maybe Tomas, if you'd like to take up the following challenge. You've got a lot of experience in practically implementing these ideas, limitations in data collection and tracking on the one hand, but I'm also interested in how to make these things meaningful to customers. I've done quite a lot on genetic risk scores, and how one conveys that to the general public, I think is extremely challenging. I think the same issues are going to arise in the domain of biological age and wearable results. And then I think there's other questions of beyond communication at an individual clinical report level, how we actually can implement these things in clinical systems and health systems more generally.
Yes, exactly. So I think it's important to do the collection of the data, but then having the other part, which is to make all those data meaningful and implementing the learning really to appreciate the evolution with end user. And what I would say is connecting the dots between genetics, lifestyle assessment, which also are very important data about someone, and also genetic, so all the genetic markers, but biomarkers, and then connecting the dots between them in terms of making sure they're not working in isolation. Again, it's coming back to the trajectory you were talking about. We can really uncover new pathways. For example, we'll know from certain genes like ApoE genes having with dementia or Alzheimer, lithium as a biomarker, also very important for all those things. So starting connecting the dots and what in your other biomarkers could deplete you of certain of those key elements. And I think it's important to really, on one side, connecting of those dots and having the background, doing all the research behind, and this is why machine learning is very important to uncover all those new patterns. But on the other hand, making sure we keep the end user engaged in retesting and showing the progress in potentially diminishing the biological age by doing progress, by implementing little life hacks that actually can optimize those pathways. And I think this is where a lot of efforts still need to be done, because we do have amazing research going on, but we need to really try to desalinate everything and make sure that the explanation bit to the end user is there, so we can really engage the end user and making sure we have all those data that go upstream really, if it makes sense. And I think this is what I'm really enjoying working on, is trying to translate the whole science behind Healthspan and trying to really make all those available to everyone at their fingertip by connecting all the dots between everything, but also trying for them to really understand that what they do on a daily basis, it can be, you mentioned smoking, for example, but even little things just like meditation can have an impact on certain things, certain gene expression, certain biomarkers, or quickly looking at things like the HRV with some, Oura ring, for example, or measure this, will definitely help to appreciate and to create this feedback loop. And I think this is what we need to do, is to create this feedback loop from the research to the end user, and have a really strong ecosystem, and really working a bit less defragmented between everything, to really have a bigger set of data and real-time intervention, potentially appreciating what it does.
Thanks, Thomas. Okay, Christine, can I ask you to do two things? I gave only a very brief introduction to you at the beginning of this meeting, sorry. But so maybe you could tell us a little bit more about yourself in the first hand, and then talk a bit about the challenges that you've seen actually implementing this in everyday life.
Yeah, absolutely. So hello, everyone. I'm Christine Lemke, one of the co-founders and the co-CEO of Avidicare Health. Our tagline is, we measure health in everyday life. So this is collecting all the types of data that everyone has been talking about, wearables, data from your phone, and all sorts of other digital devices that we're interacting with on an everyday basis to paint a picture of someone's health outside the clinic. We've been at this since 2012. We've got a cohort of about 4 million people where we're engaged with these individuals to track, various aspects of their health in everyday life. And most of our customers at Avidicare are global biopharmaceutical companies who are trying to understand their therapy in everyday life and trying to understand the side effects and symptoms of people's disease trajectory over time. All the challenges that have been mentioned already are definitely resonate with me. One major challenge, of course, being just we've never been able to see this level of data on people before at this fine-grained level. We really don't understand what some of this continuous minute-by-minute level information about folks, how that ties to their biological outcome. We just don't know a lot of those things yet. We see some very fascinating associations. Some of our work has spanned from working with Eli Lilly and Apple a couple years ago on cognitive decline and collecting everything from voice and speech to video to really fine-grained accelerometer and gyroscope data from phones, the way they're using their apps, their call patterns, texting patterns, in addition to just all the data a watch might give you on their wrist, to understand the tiny, tiny changes in cognition from a day-to-day basis. The challenges in all of this is just separating signal from noise, separating real correlation and causation from spurious correlations. As you can imagine, when you have that much data, all that data can tell you anything you want it to tell you, unless we're really specific and cautious about trying to find the associations that are truly there versus the astrological associations that you could divine, from terabytes of data a day on a single person. So there's a lot of learning to be done. We think there's tremendous promise. We do see some strong signal in the data. But one hard lesson we've learned is you have to be careful about zooming out and looking at population level data and stats. And really, this is all about changes in individual trajectories. These are very much about N of 1 types of data streams, where even if you take cognition, someone who looks like they could be in cognitive decline perhaps aren't, and vice versa. Someone who was a professor of physics, their cognitive decline looks very, very different from somebody who maybe does what I do for a living, which is look at PowerPoints all day. So we have to be very careful to put this data from all of these devices in close and specific context to that person, which requires, we found, more than just the tracking data. It requires also active tasks that the participant does, their clinical data, not just genomics, but proteomics and clinical data captured by the system. So it turns out you just need this constellation, that the wearable data itself might give you some hints and clues, but you really need a lot of rich context around a person to divine what's truly going on.
Thanks, Christine. That was great. I don't really know where to start, or if any of you want to sort of add some richness to each other's contributions. I think, Peter, you talked about the need for longitudinal data.
I can maybe add something here.
Yeah.
So I think that people in medical profession are used to think about certain levels of certain variables, like you have to have certain number of LDL, HDL. So most of the time the outcomes are numbers. But what we see in the data, and that's what surprised us a lot, is that, all these numbers can change a lot and you can still be healthy. So it depends if you partied or worked or been stressed or something like that. But there is one thing which we can get from longitudinal data is the characteristic time which your organism requires to get back to the norm. That's a property which changes with age. That's your resilience, essentially, how resilient your body is. And that quantity you can never get from single measurements. The issue is that in order to measure resilience in humans, you have to have multiple measurements over 1 month's time. And that's not something which we can do with medical analysis once again, because nobody is going to go to a doctor a few times per month or something like that. And that's where I believe the wearable data gets to the point. You can really see these minute-to-minute changes, as we have just heard. And the dynamic character of the physiological state is also the biomarker of health. And this is the only thing which you can get if you have the longitudinal data. So I think we will see more examples like that. So we will have different organismal compartments resiliencies. They will be related to diagnosis and they will be related to treatment. So in a way, we are coming to the age of looking at human state as a dynamic system, human health as a dynamic system, rather than just a collection of certain levels and norms.
Yeah, indeed. Tomas?
Yeah, no, I totally agree with this, and even more at the dynamic system, but also more and more in the interconnection between all the different elements within, pathways and different elements within a body, and all of this together, this richness of data is huge. So then this is why we probably need, to uncover all those patterns, the like of machine learning and big data analysis. To help us really uncover all those things. But yes, we really with the convergence of all those new technologies, so wearable, artificial intelligence, even cloud computing and machine learning, all of this will really help to actually have a better picture and trying to understand what it all means in a contextualized way. So again, is this person at this time, in his body, in his conditions, all of this matter, rather than just one single or few biomarkers in isolation at a time, really. And I think this is very important, yes.
I think one thing that's really helpful to point out that both of you had hit on before in the conversation is that the technology and even the machine learning is moving faster than the physician, that we can do all this cool stuff. Like I can literally gin up a model that, predicts someone's trajectory into cognitive decline. I can gin up a model that predicts, or at least describes when somebody might be having a severe migraine or not. But putting these tools in the hands of the medical establishment so that we can deliver care in a far more personalized way has been a challenge. Teaching physicians even simple things like AUC curves, isn't really their thing. And so one question I had for the group is just how do we think about translating some of these cool things that we're doing, where we're measuring health in this new way, into practice?
If I may, I think it's looking at the separation in some sort within the acute care environment and the preventive environment, which are two different total things. One is about fixing you if you break down, and the other one is about optimizing on an ongoing basis. And I think the optimizing on an ongoing basis will not come from the same system, and we need to create that from scratch. So I know it's quite a big endeavor, but funny enough, it's like the banking system. You've seen all those innovation with the fintech, and now digital innovations are happening and very fast, and it will come from there. It's this decentralization that needs to happen, and this decentralization will allow this democratization almost and the conversions of all the technology to be made accessible to everybody, and have potentially networks that work with peer collaborations via cloud system, via all those things. But right now, if we look at a healthcare model as we know it, just looking at data is, it can be dangerous and not really something we want to do. We don't want to share data. So there's this whole, sort of reality that we face in like, okay, yes, I do want to do machine learning. Oh, actually, no, because that's a bit dangerous now. I'm going to share clients' data or patients' data. No, I cannot do that. So there's this chicken and an egg almost thing going on. And this is why it needs to be separated, I think, and it needs to be coming from digital innovation, but also this digital innovation to have strong foundation, which are legislative, and yeah, they need to be supported somehow by the governments as well.
Yes, yes. I guess a couple of thoughts that build on some of that. As I think some of you are aware, in the genetics world, we have had, well, papers with up to 400 authors. And the reason that that's come is that we've been able to share data amongst ourselves very effectively in a very anonymized way using meta-analysis and very standardized protocols. I think we're all very proud of the machine learning and the sort of larger data sets that we're gathering. But certainly our experience in the genetic world has been that even bigger is better. I mean, UK Biobanks transformed things a bit again. But I wonder what opportunities any of you see to share data or share analyses or results in a way that we can sort of mutually reinforce each other's work? Or do you think that's a problem that's going to have to be solved sometime in the future?
Yeah.
Can I?
Okay.
Yeah, I would like to comment on that. So first, to the previous question, I do have respect to physicians. So I believe that if somebody is broken, I would rather go to a doctor rather than rather than fire up my app and try to see what's going on. So I think everyone agrees here that the issue is that healthy people are dark matter for the medicine. So they jump out from a white hole into the hospital, and then of course doctors know everything about them, but that's kind of too late. So what I believe is that we may have help from insurance. So I believe that at the end of the day, insurance people understand mathematics well. Well, the financial people understand mathematics well. So the methods which we are using are somewhat similar to what quants on stock exchange are using. So essentially, I think at the end of the day, we need to learn how to do financial instruments which are betting on human health. This is a bit futuristic, but I think, well, at least what we feel, that life insurance has lots of interest in these biomarker studies already. So they are very advanced. So now in terms of the data, yes, with GDPR and other things, it appears that we are living almost in hell. It's almost dangerous, as you told, to touch patient data. But on the other side, if you look at an application like Female Health, you have this period tracking app, which has 20 million users. You just said that you have 4 million cohort. So the digitalization of health studies essentially democratizes them to the point that when the data acquisition costs almost zero. So what I think we need to implement in coming years are kind of encrypted systems where you can actually have the data, train algorithms on the data, and provide the outcomes of the algorithms on the data without seeing the data, using different kind of encryption tools. I know that there is a bunch of startups which are busy in this field, so this is mathematically feasible. So I hope that in the same way as digital and AI and ML tools help you to collect this amount of the data, in the same way mathematics will come here and help to actually keep everyone apart, you know, to enforce to solve the legal issues and still get us to look at the data through our algorithms.
Yeah, and it's a very good point because it's actually pretty much my talk tomorrow. But data ownership is one very crucial thing that needs to happen, allowing this to this sort of system to take place. Because by data ownership, we all know that it's a very big, fast-growing commodities, and if people start to have ownership of their own data, potentially we can create encrypted cloud platform that we can also trade for research via grants or anything. But what I mean is we would have access to and participate, like almost a participative way of end users to share those data and potentially have a huge data bank. And from this, having this whole system, as you said, algorithm, or analytics, predictive analytics with AI and machine learning. And this is where it becomes collective learning. Then we can share all this across peers. And yes, if it's something clinical, then it's more relevant. And this is where instead of going to a clinic, then someone reach out to you because we know something is going on there. Your body temperature has raised, all these sort of metrics that we know, something is going on. The right person will contact you with this set of data. And I think this is where it should be going. But all need to start with the democratization of all those data and data ownership, where people can opt in or opt out of sharing those data.
I really struggled with this notion of data ownership, having been, someone who worked on this very, very early in concept back in my last life. And I've struggled because if you give, away your data or lend it to somebody, you're not really lending it, are you? Because you have no recourse if they drive away with it and never come back and, oh, by the way, make copies of it and send it to all their best friends, all thousands of their best friends on the black market. So I've really struggled with this notion. It's not like your data is not like the deed to your house, because there's not an accompanying, there are not accompanying regulations about use of the data. So ownership in its current theoretical construct for me falls short for data because there's no recourse once your data is out there. And once your data is out there, you can't really claw it back, So for me, for sharing to really open up, I do agree that there are differential privacy methods and startups that are doing some interesting things in that domain. So I think that's one technical way to move things forward. But I do also think there needs to be a correspondent restrictions or some sort of guidelines on use of data.
Yes.
If I give my data to you, and by the way, all data is becoming health data. So these Facebook posts I'm doing, these interactions I'm having on my computer, the phone, the way I use it is all instructive to how I might be feeling that day. Then I want to make sure that Facebook can't use it to learn that I'm depressed and then do whatever it wants with that type of health data. I want to make sure that my job doesn't look that I'm cognitively declined based on my usage of video in a Google Meet, and be able to discriminate against me from a professional perspective, especially given the state of where we are in determining whether somebody's cognitive decline by video or not. So yeah, I believe in data ownership, but I'm worried about sort of implying that people actually own their data without corresponding restrictions on use of it.
Yes, I totally agree with that. In the sense that you should opt in what you want to share, and the things you don't want to share should be kept for yourself.
And how it should be used, and how it should be used.
Yeah.
Because
you don't know the inferences. Sorry.
Yeah.
Indeed.
Sorry, go ahead, Peter.
No, you go ahead, Christine. I think we'll wrap up after you.
Just to underscore my point, Facebook has advertised that they have basically figured out how to tell someone's depressed or suicidal by the way that they're posting and interacting on Facebook. That was a press release like 2 years ago. And for all its good intent, did it make me feel safer or better? Not at all. Zero. Because I didn't give them that data for that intent. And so especially in health contexts, when I'm giving data over, I want to be sure that it's being used for the intended purpose I understand versus the secondary use that Facebook's using it for. And I'm just picking on Facebook because they're easy to pick on. When Avidicare asks people for their data for a research context, we're very clear about we're using it for this use case. And oh, by the way, then we're done. And then if we want it again for another use case, we will ask you, which honestly gets terribly annoying. We have to find even a better model. But we're conservative on purpose because we understand sort of the double-sided nature of this data.
Yes.
I think we could go on and on the specifics and the wider issues raised, but I think we're running out of time. I hope I've really enjoyed this. Thank you to Peter, Christine, and Tomas. Thank you to the conference organisers as well, and I hope these discussions will continue and provide a good springboard into tomorrow. Thank you for listening.
Thank you.
Bye.
Thank you.
Hello, everyone. Thanks a lot for joining us today at Giant Health's Extending Healthspan track. We're going to discuss how technology is helping to detect earlier and prevent cognitive decline in dementia with a couple of the best functioning
Excellent. Excellent. So very, very exciting to very excited to have three amazing people whom I met a month ago in Helsinki at a biohacking event to tackle a subject which is very, very close to my heart, which is how to, or whether or not a biohack, yeah. Okay, well, this I didn't join the link. Yeah, okay. Yeah, let's see. Okay. Excellent.
All right. Everything okay here?
Excellent. So I guess we're live. Somehow I can hear myself. Great. So can everyone hear?
I can hear you quite well.
Excellent, excellent. So super excited to have all of you here. I think we all met a month and a half ago. The time runs in Helsinki at the Biohacker Summit, and I'm very excited to tackle a subject which is very, very close to my heart, which is whether or not biohacking, which we all do, is a niche market or it becomes a norm. And just a quick introduction. So we have here Timu. Timu, you are the co-founder of the Biohacker Center in Helsinki. You are a technology entrepreneur, author, and professional speaker. And you are one of the forefront thinkers on the digital transformation of work, health, and society. And I believe you were one of the top 100 most influential people in IT in 2016. You've got awarded the Speaker of the Year in 2017 and the Leadership Trainer in 2019. And you're also the author of a book which I really enjoyed reading recently, which is the Biohackers Handbook for optimizing health, performance with biological and technological tools. And the book is there. So thanks, Timo. We also have Edward De Wilde. Edward is the CEO and the founder of Life Healthy and of Norcod, which is one of the biggest, if not the biggest, European-based supplements company. And Edward, I still remember your story in Helsinki, where you told us that 20 years ago you've got severe anxiety and panic disorder as a side effect of anti-malaria a drug called Lariam, which I was taking as well. I'm actually in Africa now, so I sometimes take Lariam. But this is what brought you into biohacking. And this is also what made you decide to change your career and focus on biohacking. And your mission is to share your experience with other people like us and help us getting the same benefits that you've got through what you've done. We also have Sim. Sim is from Estonia. He's an author, speaker, and also part of the Biohacker Summit in Helsinki. I believe you are considered one of the youngest known biohackers online. And despite your young age, you've written a number of books such as Metabolic Autophagy and Stronger by Stress. And you also have a degree in anthropology, and you've created a lot of content on human optimization, performance, and longevity. And I believe your latest book is The Immunity Fix, which you co-authored with Dr. James Di Conalantonio, who is a very, very esteemed cardiovascular researcher in the UK and the US. So thanks again for being here. Myself, it's a very, very quick intro. I'm an Africa-focused entrepreneur and investor. I'm the founder and CEO of a company called Ilara Health. Ilara Health is a high-tech point-of-care diagnostics venture which aims to democratize access to diagnostics across emerging markets. And I've started this in Kenya, where I'm now, in Nairobi. I'm actually super, super passionate about prevention and early detection of diseases. And I am an avid biohacker like most of you. So I will kick off the panel with a question which makes me think very often. Shall we call what we do biohacking, or shall we rather call it health upgrade, or longevity, or just healthier living? What do you think?
You're on mute.
I think Timo, you're on mute.
All right, let's choose the right microphone. A chance. Good. Okay, so in the definition of biohacking, I mean, it's a kind of an umbrella term for a lot of things. I mean, it's what you make out of it. Biohacking can be health optimization. Biohacking can be better living through science. Biohacking can be, nutrition or technological approaches to improving your health. It could be about looking at your body as a biological system and doing systemic interventions. Those systemic interventions could be direct or indirect. Indirect in terms of taking some food or supplement that influence the status of your health. Or it could be direct. I mean, you could inject stem cells into your body, and there is so many different ways how we can kind of look at it. But where I come from, in Finland, biohacking became synonymous to quantified self tracking and self-knowledge through numbers. But in the end, biohacking doesn't really require any kind of biometric tool or device to measure your health or well-being. It's definitely a good aid in it. Just like a hacker is looking at the human body, as a hacker is looking at the computer system as a system that can be understood and put under a test, in a similar way, a biohacker is looking at the human body as a system. And I think biohackers are systems thinkers, and it has a connotation that is kind of negative because of the hacker term right in there. But I mean, in building businesses, we talk about growth hacking. That's kind of, it has street credit, right? You're a growth hacker. Why not the biohacker? I mean, biohacking can also be about bioterrorism and all these things. But in the end, the definition over time has kind of became kind of common vocabulary, just like blogging. I remember I was in the early days when blogging came along, and a lot of people online were talking about, should we call it weblog? Should we call it the blog? Should we call it online journal? But blog really stick out, and no one really thinks about what the term now means. So culture kind of creates definitions for these things. And but right now, trying to put your finger what biohacking is kind of hard, obviously. And we can talk about digital health, obviously, as part of biohacking. We can talk about nutritional interventions and smart nutrition, especially as something of biohacking. So you can do it any and all means through which you optimize the environment inside of you or outside of you. That's the definition that Dave Asprey likes to give. Basically looking at these aspects and dimensions. For me, and for the European approach, biohacking is not really about better, faster, stronger, like in terms of better health, better performance, more. It's not about that. It's not about, I mean, a lot of people are drawn to biohacking because it kind of promises more energy, less ill days, and so on. But to us here in Europe, I think it's more about the balance, the homeostasis, the equilibrium, finding, where all systems are in harmony. And in the end, a lot of things where you're kind of pushing the limits, there's a side effect, there is a drawback at some point. If you increase your heart rate by using a lot of stimulants, you probably get a lot of things done, but you're wearing out your heart muscle. So there's a payback to a lot of things where you're boosting, or improving. But I think in the end, if you oil the machinery, if you take the rate limiting factors out, if you're taking out the things that are hindering you, the things that are not working in the way like nature intended, or where it really functions best, that's where you find optimal health. The human body is incredibly good at healing itself from illness. And that's why, for example, personally, I'm focusing on things like silent inflammation or inflammation, controlling that with lifestyle interventions. But I mean, there's many different approaches to this. I'll let the gentleman speak for it.
Yeah, I think that one of the common denominators of biohackers is that they like to experiment, and because it's all individual, and a healthy lifestyle is not the same for everyone. And most biohackers they choose a fact-based approach and to see what works for them and not for others. And I think that's typical biohacking, and that's the difference between biohacking and just the more generic approach about a healthy lifestyle.
Yeah, I agree that biohacking is a very controversial term, and it can definitely make some people very suspicious and even very cautious. And I think it also, at the end of the day, it matters who are you speaking to and what kind of an audience are you, referring to. So if you're like maybe talking with medical professionals, then eventually it's gonna, probably take the form of some like digital health or technological health, something along those lines. But if you are talking like people who are experimenting and doing these different experiments on themselves, then like the street term would be probably biohacking. I think that's gonna stick around. And like, even though the biohacking term can be very controversial, I think it can actually be also like a positive thing for the entire reputation of biohacking, because like it does stir up a lot, like pricks a lot of ears, and people are very, very curious about it. It sounds dangerous, sounds very like an breaking rules and breaking into our biology and whatnot, and hacking and those things. It sounds like something that is you're not supposed to do, but at the same time it can just help to spread the message, because once people just educate themselves about it, then they eventually will learn about that it's not just about injecting implants under your skin, or taking some drugs or something else. It's mostly just a lot of the entire lifestyle, and figuring out how do you improve your entire like environment as well as your inner body with these different kinds of systems, way of thinking, and routines.
I want to add, because I'm from Finland, and we popularized the term biohacking through our books and writings and news interviews like 10 years ago, around like in 2011, 2012, 13, started doing that work, and it kind of stick around as synonymous to preventive health. So it became synonymous to the change in healthcare. When I started talking about these things, preventive health and patient-centered medicine and so on, that was kind of it was a growing trend, but it was still on the fringe. It was not on the lips of every healthcare professional in every health conference. And I remember a friend of mine was in the board of one of the biggest biotech companies, medical companies in Finland, and he advised those people to take a look at some of my presentations, and they said that, no, this is not the future. Now, years later, in 2019, the strategy of that company is preventive health. And one thing that kind of happened also was that biohacking was picked up on the political level, so it became part of some of the agendas as well. So it has a lot of street credit in where I live. So it's not kind of some weird term. It's cool. It's something that high-level professionals even use to describe trends. It's kind of like, it's cool to talk about. It's just like talking about AI or machine learning. You talk about biohacking. It's even in it's even in this emerging technology roadmap. Gartner's last year report listed biohacking as one of the things that CIOs, chief information officers in companies, should pay careful attention to. They saw that as an emerging technology, but their definition was way too much technological. It was based on implants, it was based on wearables, it was based on different kind of technologies like synthetic biology, very hardcore biohacking, I would say. But the softer side, like people taking responsibility of their own health in a quantifiable and measurable way, that was kind of still missing in it. But I see that as a much bigger trend now, kind of the implants and transhumanistic ideas, the wearables, all of that has become kind of mainstream already, and everyone has some kind of activity tracker. So it's nothing strange anymore in a way. The wearables and the trackers and the sensors are everywhere. It's in the latest generation of virtual reality technology, AR, VR, it's mixed reality interface. All of them rely on being able to gather different bodily signals, being that orientation or pupil dilation, or it could be in the future even your heart rate, maybe modifying user interfaces based on your biometric signals. But I've been using things like biofeedback for quite some time to improve my ability to control my stress response, for example. And there is applicable implementations that you can start using right now, but just tracking things like your heart rate variability, resting heart rate on a constant basis, you can learn a lot about the status of your body.
Yeah, sure. I mean, I think that there are people who are super interested in measuring the HRV or taking supplements, but still, when we look at biohacking today, even if it ranges from just nutrition and fasting, for example, or taking supplements or wearing devices, it remains still limited, even if it's been growing a lot. It remains still limited, in my opinion, to people who are in this super health conscious state. Now, it's not cheap, right? I still remember, Dave Asprey spent $1 million, 10 years ago. We probably spend in the thousands and thousands of dollars a year. What do you think that is going to be the trend to bring this, to democratize this, to make it cheaper, more affordable, and closer to the masses, and not only for the people going to the biohacking conferences or to people who have the financial means to afford this? What will be the steps together, and how fast do you think this can happen?
My very quick comment is yes and no. I'll let the other gentlemen voice their opinions, and I'll go on then.
Yeah, I think we live in an area of exponential digital growth, and that means that for example, the devices will become cheaper and cheaper in a very fast speed. So that will democratize the accessibility for people that are not that wealthy a lot. And that said, if you talk about healthy food choices, I think that will still be quite expensive, and there are certain ways to work around the organic, the very expensive organic food choices that you can make, and the grass-fed beef. There are ways to hack it, but in the short term, I think it will still be something for the more the people that are prepared to spend a certain part of the income on their health, and where other people spend their income on beer and other activities. It's what is your priority, and if you look at the spends of different kind of people, then I think, okay, you make that choice, but you can also make other choices, and then you have to leave something out of your lifestyle that is maybe not healthy, but and that's also an approach, I think.
Yeah, definitely it's true that biohacking can be a very expensive hobby, and at the same time, I think a lot of the most expensive gadgets and tools, they aren't the most effective things, and they're not the best things for your health. The best things for your health are actually free, sunlight, some breathing exercises, exercise, fasting, sleep. Those things are free, and even the other things like the sauna, cold exposure, those are one of the best things for your health, and they don't necessarily require a massive amount of money compared to something like a very specialized magnetic machine or something else that may help you to achieve let's say 5 or 3%, but it's not going to give you the foundation. The foundation is the things that is going to be free. But the only challenge I may find is Edward said, that good quality organic foods is probably the biggest hurdle at the moment, because nutrient deficiencies are very widespread, and the average person is missing at least the multiple key nutrients for optimal health, like magnesium, choline, vitamin D, vitamin A, and other nutrients. And those nutrients are also very much depleted in the food that we eat nowadays because of soil erosion and using pesticides, fertilizers, those things. So I think the biggest challenge is actually just making sure that we start eating quality food, because processed food, refined oils, refined grains, other just ingredients in them, they basically remove most of the nutrients and vitamins and minerals, and nutrient deficiencies are going to basically undermine your health. You're not going to detox properly, you're not going to have good sleep, you're not going to build muscle, you're not going to burn fat, and you're going to have a weaker immune system. So I think that's the biggest hurdle, and you don't necessarily need fancy gadgets and fancy technology to stay at optimal health. But even some other Dr. Jose that we saw in Helsinki as well, who was speaking, he said like once these technologies, especially like longevity and lifespan technologies come out, then people are going to demand that it's going to be free or something, because the governments aren't going to stay in power for long if they keep it away from the people. So who knows like what's going to happen? But I think that as the technology goes along, these things are going to get cheaper. But we definitely should focus on like improving our food quality.
I guess a lot of people are not aware actually of their issues, right? I still remember. I think I listened to an interview with a founder or chairman of Human Longevity, and he was saying, look, he discovered that he had massive health issues, and this is what brought him to found a company, to start a company. So how important do you think is measuring? I mean, we talk about HRV, we talk about other things. Some things I guess we can measure, some things we can't measure. We may not be able to measure, red light therapy effect. But what are the things which are measurable and which can potentially push people to get faster into this movement?
All right. So a continuation to the previous question and this one about, I totally agree with Siim that most of the good stuff is free. Even supplementation is a supplementation on top of an existing well-rounded diet, and still like most people lack on that side. A lot of people are taking supplements like multivitamins that don't do anything, while they should be measuring their values. Like this time of the year, vitamin D, for example, might be something that you might be lacking. How much you should be taking, you should measure that. And that means that when we look at measurement, previously it was a lot more expensive. I mean, these devices are actually very cheap compared to what it used to be. Measuring your sleep used to cost like thousands of dollars per night. Now you can have for 300 euros or so, you can do that every day, year round, with clinical quality almost. And this will come down because of exponential technologies and reduction of price. The price per biomarker will come down, including blood biomarkers. Theranos failed on that one, but in Finland, for example, there is Nightingale that takes from very little blood, very accurate measurements of lipid values. So the fact that we will be moving from point snapshots to actually more continuous monitoring and measurement at an affordable price will drive that to mainstream. Now, like I said earlier about the wearables, like most people have some kind of experience of that already, and but it was not commonplace like 10 years ago. You really had to go searching for those devices, and they were not necessarily as developed as they are today. And the usefulness of these things are improving quite a lot. Like we are moving from a pedometer, just telling the number of steps that you are taking, to actually having a kind of AI-driven coach in your pocket that knows more about you than you know about yourself. And you say things about like red light that maybe it's not measurable. Of course, I can measure my inflammation markers and see how that's working, but still. The most of the best stuff is free, and people are not doing even the free stuff. Now, what I've seen in the biohacking community with these kind of things also is that the people who are most interested in wearables and these kind of devices are, as you said, already kind of healthy geeks, and it's not mainstream. But you have to remember that these people were often previously extremely sick people. And I've seen that across that health community. There are people with chronic diseases, people with health problems. They were basically in a place where they had no other thing, no other choice, not a doctor, not a pill. They had no other choice but to look in the mirror themselves. That, okay, I need to change myself. I need to change my behavior, and that experience led them on this path. And once you have this very deep emotional connection to improving your health, you're going to stick with it. And this kind of thing was called in ancient Greek by ancient Greek philosophers as wounded healers. So that's what most doctors are. I mean, most clinical psychologists actually come from a background of childhood trauma. So they are actually solving their own problem. So if you take people like Dave Asprey spending hundreds of thousands of dollars on improving his health, he's a good example of someone who was extremely inflamed and sick person, and was basically back against the wall. Here in Europe, I mean, if you look at the people who are funding longevity research, are people who were previously obese, inflamed, and almost dead, and now they change their health and they want to, spend rest of their wealth in improving health for the general public. So this is the experience that people have, and it's unfortunate that a lot of people have to go through, the hard way. And maybe that's the way how we actually get interested in health. You really have to have serious health problems before you actually get interested in it. But we hope that by sharing this information, making it more affordable, more accessible, easier, more embedded in existing practices, kind of cool, trendy. This is the way how we can actually prevent other people learning it the hard way. I mean, all these degenerative diseases, diabetes, cardiovascular disease, Alzheimer's, there's a lot of different studies that show that in the end, you can influence quite a lot the potential health outcomes, even COVID, by taking responsibility of your own health. People who are now running around avoiding getting a virus, they should be running around avoiding getting metabolic disease first, because that is the biggest risk factor in the end. It's not age. We say that there are age groups that are highest risk factor. Why is that? Because of degenerative diseases. If you can slow down aging by also reducing your blood sugar values, improving your health biomarkers, reducing your inflammatory biomarkers, taking care of your immunity. I mean, that's a way how you can not be in that risk group in the end for a lot of things, not just COVID, but a number of things. And that is kind of the key thing. So this year has shown people that, there is no drug, there is no medicine that's going to help you. It's your immune system. And if you take care of your health, that is the best investment you can do. I'm a firm believer that improving health is much cheaper than treating disease. And any and all means, if it costs freaking 300 euros to improve your sleep quality, that's a very, very cheap investment compared to what it costs once you're in a hospital.
Yeah, maybe this was the best thing that happened in my past 6 months.
The main challenge is that these self-directional people, they are in the minority. So most people, and that's the biggest challenge. They don't care. They don't want to change their lifestyle. They are looking for the magic pill. And if you talk with them about biohacking, and you talk about all the things that you do to improve your health and your energy and you are excited about the outcomes, then they are very interested. And then if they see what is necessary in order to improve your lifestyle, then they back off. Then they get offended because they still want to eat their bread. They still want to drink their beer. Life has to be lived. And I think the main challenge for the biohacking community is to make the information that is collected, to make it accessible to that people in a way that they are not offended anymore, but that they can understand it, that they don't need to know the science behind it, and just know what to do and how they can improve their lifestyle with very small steps and benefit from it, and then feel the experience and the results, and then get motivated by it to continue their journey. And I think that will be the biggest challenge.
Very short comment. You're right on the money right there. Like when I think about my friends who are kind of in the group that you describe, the biggest things that get them interested about biohacking is how can they avoid hangover by taking a few supplements, and the other one is how can they eat bread by using some digestive supplements that will break down the gluten for them. So in the end, it's yeah, they're looking for the magic pill, and I think changing behavior as little as possible is one of the key things. You want to embed these things into existing behaviors.
Yeah, like I want to add to the question that the foundation to preventative healthcare is tracking and self-quantification. So tracking sleep is one of the best things for yourself because you can sleep is the most important thing, I think, for health and recovery. But also just paying attention to like your biomarkers on a regular basis, like once or twice a year is a good idea to take a blood test and see actually what your health is, because then you can stay on track with things like your metabolic health and inflammation levels and those, and you can see what maybe your lifestyle isn't working and maybe there's something that you need to fix. Because like if, for example, if I were to consult someone, then initially I would definitely ask for them like to get like a full blood panel, all the cholesterol, triglycerides, blood sugar, inflammation levels, and those things to see where they're at. Because if you don't know where you're at when you're starting, then you can you can start going in some random direction and you don't even know if you're heading in the right direction. So making sure where you are is the most important thing for beginning, and then adjusting your course based upon the feedback you're getting. And fortunately, there are, the sleep trackers are pretty popular at the moment, but also like tracking your blood sugar is becoming increasingly more easy because like a lot of companies now offer these continuous glucose monitors that you can use at home. You don't need like a medical prescription for it, and you can use just the app, and you can just see the continuous glucose all the time throughout the entire day. Like you can see what foods affect your blood sugar, and that blood sugar response is actually one of the best indicators of your metabolic health. And you can see maybe you eat too many carbs, maybe you react negatively to some foods. Like some people spike out when they eat like a banana, whereas others don't, and some others maybe have like an allergic reaction to gluten, and then they get a massive blood sugar spike as well. So that's a really valuable information for you, especially to know what foods suit your like body and the genetics and the lifestyle, because like biohacking has to be done customized to the individual. Like there's no one diet that suits everyone. The best diet for you is the one that is suitable the best for you.
A lot of people have actually done these lab tests, some kind of basic like yearly measurements and so on, but they are not getting the information how to improve their health. They get lab tests based on taking medication, like if you're outside of specific values, should you take a medication or some kind of treatment. For that reason, we actually developed and made free. This is a free app called HealthDX. So you basically, what you do, you just enter your biomarkers, and here are all the biomarkers that I have here. There's like 49 of them, but this is kind of a typical report that you would get. So what we actually do, we give you exact information, what these biomarkers mean, what is an optimal range, even within a reference range. Like I'm within reference range with an inflammatory biomarker called homocysteine, but it's not optimal. And then it's telling me take vitamin C, take methylated B vitamins. I can look at my cholesterol, lipid metabolism, whatever. So it's actually giving me actionable knowledge what I should be taking to fix these aspects here, and it's combining that to some top recommendations, and it gives you a 0 to 100 kind of a resilience index, what you should be doing if you want to stay healthy. And these kind of things, the information is becoming more available. If you're interested, by the way, look at health-dx.com. You can download it for free. Yeah. But these things are coming out of research now, like how we can actually prevent disease based on lifestyle interventions, based on the basic lab tests that you're getting.
I just gave to all my employees the HealthDX blood test course. So I really found it amazing. But so what you're just saying brings me to the next and one of the final questions here. So I still remember a discussion that I had with Humanity Inc. founders who look at how can what are kind of the 2080 of you mentioned Tim, you mentioned the 49 blood tests. I do same about 40, 50 blood tests a year. But do you all think that there is a 20% of those blood tests, those biomarkers, continuous or seldom biomarkers that can give perhaps 80% of the results and end up in actionable outcomes, because not everyone can do 40, 50 blood tests every year. And in their countries, you can't even do a blood test. I mean, I was in Denmark for a few months. I just couldn't get a blood test done because doctors were looking at me and asking me, "Are you sick, or why do you want to do your blood test?" So, what do you think are the kind of the minimum set of bloods that someone will need to do to get some kind of good information about the health state of the person?
I think we are getting soon very affordable home tests and kits that you can just send in, so you don't have to go to a clinic. But in the end, still, if you want to get really accurate tests, the full blood analysis, like from a vein, is done by a certified clinician at the right time after fasting is still the gold standard to go for. But I think we are getting close to indirectly looking very accurately at some of the biomarkers from saliva, for example, or there might be new types of technologies coming along. The dry blood tests are not that accurate really, but those are mostly done right now. But you can do a saliva test for DNA. You can do that for genetics, but you can do that also for epigenetics. Companies like Chronomics can tell you about how your what your biological age is based on a full genome analysis, looking at changes on a full genome-wide analysis compared to your age group, and how things like alcohol or tobacco smoke, etc., might have influenced your epigenetics. That's very interesting stuff that you can do on a yearly basis, although DNA tests are kind of, you do it once and you get that information, but the epigenetic test will be very interesting in the future, but they're very expensive right now, like $1,000 to get that test. But at least here in Finland, I can get for 50 euros, I can get a full panel of lipids, vitamin D, blood sugar values, and basic blood profile, and that's already